so many friends, so many experts at the same time. We have a very important session today. We're going to be talking about the complication associated with US-guided gastroenterostomy and anastomosis in general. I'm going to give an introduction, going over the data so that we can just kind of get oriented, and then we'll discuss with other experts some of those complications. So if we can connect my my computer, that's great. So as you know, originally when we were dealing with gastric ulnar obstruction, we were doing enteral stents, and if we wanted something that will be permanent in patients that may survive longer, we will think about sending them to gastrojejunostomy. People that cannot undergo surgery will get the stent, and the other one will go for surgery. And the idea was to recreate what the surgeon has done, but endoscopically, and US-guided has allowed this. So those are the first three papers that went over this technique. Ito Takao has been very important in pushing the field in creating this concept of an anastomosis. And his first article with 20 patients show an efficacy of doing this anastomosis in 90% in terms of clinical success. This was confirmed a little bit later by the Hopkins team and by our team. There was more study performed that confirmed the initial safety and efficacy of the technique than in expert hand. And then, once you have enough study, you go and you get them together and you create some kind of a meta-analysis or review paper. And here, one of the biggest one was about 200 patients. Interestingly, 1/5 of the patient had benign diseases. So we start doing it in benign diseases. Simply because we were able to do it, and the benign diseases were an opportunity for us to assess the long-term efficacy of this technique. And we were talking about this yesterday, about how long can you leave the stent in place? Do you have to revise it? So there's really open field in terms of data when it comes to discuss US-guided GJ. Now, when we compare to the gold standard, which is surgical GJ, whether it's laparoscopically done or open done, you can see that the same procedure has efficacy, but the advantage of the EUS technique is obviously cheaper, and it has less adverse events. Now, if you do cost analysis, you can see that EUS-guided GJ will be more cost efficient, because once the anastomosis is done, you're not dealing with occlusion by the cancer. So basically, the GJ allow you to bypass where the cancer is. So the cost analysis was in favor of GJ. Whenever we compare it to enteral stent, it was exactly the same concept. So the question then is, why we're not using US-guided GJ or US-guided GE everywhere? So, well, first of all, it's not an easy technique. If it goes well, like we were saying yesterday, it's a home run. But if it doesn't go well, you can find yourself in a pretty bad situation. So one of the biggest challenges, the bowel is a small target, and it's a mobile target. So sometimes it's difficult to find, and sometimes it's difficult to access. In terms of learning curve, there's two studies. Our study was looking at US-GJ, or GE in general, when you are doing other therapeutic US procedure. So it doesn't take much to do this procedure once you've mastered all the other one, especially US-guided BD or US-guided BD. The Hopkins team did a different way. They just look at the learning curve if you're not doing those therapeutic US procedures. So this is why the numbers are different in terms of learning curve. So there's a lot of techniques out there. I mean, if you look at the literature, you can literally spend a day reading about different techniques that you can do. You have rendezvous technique, you have the balloon technique, you have the snare technique, you have the direct puncture, the node technique, reverse GJ technique. I mean, there's a lot of techniques. So the question is, how do we put all together, when we're doing those procedures? The biggest issue is to use the technique that you're obviously the most comfortable with, and allow you to deal with the profile of the anatomy that you're dealing with. But the biggest debate was not so much about what technique, but should you do it with a wire or freehand? That's really where the debate was. And we have to say that that study was very interesting by the Hopkins team, where they actually compared the two techniques head to head. And the direct technique was better, and simply because when you try to do the over the wire technique, the bowel tend to escape from you. So most experts now in the field have agreed on that concept to use the freehand technique with the wire typically preloaded or not. There's other debate, obviously, and we discussed some of them yesterday during the live cases. Should we go directly to a 20? Should you start with a 15? Should you dilate the lambs, etc.? So there's a lot of variety. And I'm going to show you here the technique that we use, which was actually inspired from the way we do it here in Milan. So we actually call it the Milan technique of doing a GE. So the very first thing we do is to use a nasocystic drain preloaded with a guide wire to access the small bowel. This was a patient with a gastric cancer involving the pyloric outlet. So you see here we're crossing the obstruction with the nasocystic 7 French, nasocystic in this case, preloaded with a wire. We're going to advance this as far as we can, ideally at the level or beyond the ligament of Treitz. So once you have that, then you can remove the wire coil, and then you're going to remove the upper scope or the coronal scope, depending. Here we were using the therapeutic scope. And then what we're going to do, we're going to come back with the EUS. Typically, we like to kind of confirm our roadmap, and simply by just puncturing the targeted bowel and inject contrast. You can skip that step if you have a very nice vision and the bowel is distended. We're using the nasocystic to obviously, inflate the bowel, and here we are with the hot Axios, preloaded with the wire, entering the bowel, and then first thing we do is opening the flange, bringing that bowel against the stomach. At that stage, just like we did yesterday, you can then put the wire, which is your safety net, and then you deploy the second flange into the scope, you push it out from the scope, and you can see in this case, normal saline mixed with indigo carmine gush out. We like to dilate because we know from animal data that when you dilate in, you're approximating the bowel to the stomach. So, we also kind of place always a pigtail to decrease the chance of ulceration on the other side of the wall. So managing complication is the biggest problem. I think everybody who does EUS Guided GE found himself dealing with complications. So the range of complication in the literature is anywhere between 7 to 27%. We believe that, once you have mastered the technique, you can still deal with up to 10% of complication. So there's this very nice way of classifying the different misdeployment of the Axios when you do in a GE. The type 1, basically, you deploy it through the stomach, but you're not through the small bowel. Type 2 is the same, but you have a small opening in the small bowel. So basically, in this case, the cautery system had created a fistula, but unfortunately, the Axios was deployed too superficially and came out from the bowel. Type 3 is the opposite. The Axios deployed into the bowel, but you left the stomach. It escaped from you. This happens typically when you forget to lock the Axios when you deploy the second flange. You have to be very careful with that. As soon as you can, you have to, as much as you can, you have to keep it into the working channel of the scope. And then type 4 is something that also we experience, is when you deploy it into the colon. And you have to be very careful because sometimes you are seeing the bowel and you are about to deploy into the bowel, but there is the colon which just right in the middle passing by, and it takes one small angle of variation so that you find yourself into the colon. So this is where you really have to be careful. So I'm going to give you a few examples from our own experience. So this is my fellow deploying his first GE at the end of his training. And I was very nervous when I saw that, obviously, because it just escaped out of us. So luckily, he kept the wire in. So in this case, we know that we had the bowel, but as I said, we lost the other flange into the peritoneum. So it was a very easy fix once you have the wire to literally bridge it at the same time. So very important to have that wire ready, because this is your safety net. And I think most of the case, if you don't lose the wire, you are typically able to salvage this, especially in this case. We like to use TTS esophageal stents because they're longer, and some of them actually have a diameter bigger than the Axios, so that you basically bridge in with a longer and bigger stent. And as I said, especially with the long stent, we like to place a pigtail to decrease the friction on the other side of the bowel. So we talked about this complication, but there's other complication where actually you finish your procedure, you think everything is fine, you are delighted, you dilate the Axios, and then you start seeing this. So this is something that you're going to eventually encounter, and unfortunately, there's different way to think about that. One of the most important thing is you have to make sure that in this case, the bowel on the other side hasn't been traumatized or compromised. In this case, what we did, we switched to a therapeutic double-channel scope. We went back, we grabbed the piece of bowel that was the target, which is literally right in front of us, and then holding it with the Ratus forceps from one of the working channel, we access the bowel with a needle knife. So once you do this, we published this actually, this case, once you do this, you inject contrast, you confirm that you are into the bowel, and then same thing, while you're holding the bowel, you're going to place a TTS stent, and you're going to deploy it, bridging the stent. This is a very interesting case because we had the opportunity to follow this patient for years after that. She actually recovered, went back home, and she's following up with us on a long-term basis because she has a benign disease. So this is a great opportunity for us to follow up and see how she's doing. So this is Todd Barron, a variation of this technique. He published this a few months after our own publication, where he's also doing a GJ. And you can see here, he's kind of losing the vision. And this is the problem, is like sometimes the bowel really escapes from you. And you have to be really careful about that. So in this case, clearly the vision wasn't clear. He's deploying the Axios, but you can see by EUS that the Axios is clearly not into the bowel, confirmed by fluoroscopy, and he's even injecting contrast, showing that actually he is in the peritoneum. So that was clear just by the position of the Axios. So one more time, this is where you if you decide to proceed forward, you can, as long as the bowel integrity is confirmed. So he actually got into the peritoneum with the echo endoscope. And then into the peritoneum, he actually accessed the same piece of bowel. So instead of grabbing it like us with a therapeutic scope, holding it, he accessed it. This is, I'm going to be honest with you, a little bit harder because the bowel wants to escape from you. So I prefer using a therapeutic scope with a double channel, holding the bowel, because that is much harder. So you really have to be facing the right bowel. You need to let cautery doing the job, and you have to make sure that the bowel is not escaping from you. So it's a very, very difficult technique, but if it works, it's very elegant. So this is Manolo. Manolo told me about this case before he published it. We discussed about it, and then he told me, the issue is that we didn't have a double channel scope. So we're going to see what you do when you don't have a double channel scope. You can see actually very nicely from this video that the Axios is clearly far from the bowel. So here we are here deploying it, and then the next step is to dilate, and then the idea is how we're going to bridge this. And in this case, he's not going to do this with an echo endoscope. He's going to actually use the Axios itself to bridge uh, the missing bowel. So here we are entering into the peritoneum again. And then the idea here is to figure out a way to access the bowel without this escape. So what he's going to be doing is going to be aspirating a lot. You see, so he's aspirating a lot, trying to suck that bowel into the axios. So far, so good. So he's not holding the bowel like we were doing it with the tutti scope. He's going to do an opening with the needle knife. Here it is. So far, it's pretty step forward. See, he's doing a nice opening. When you do this, there's no turning back anymore. You could technically stop the procedure if the bowel are okay. But you see, this is where the problem is when you're trying to access that piece of bowel wants to escape from you. So he was able to place a wire, but you see now we went from being inside the axios to deep into the peritoneum. But you see, he has a wire. So luckily, all he has to do now is follow the wire with the cautery system, and then he's literally pushing the bowel against the wall of the cavity to be able to cauterize and get into the axios. So this is the most crucial point, is actually get that axios open. Once the axios is open, you can then bring it up. It's much harder. I truly believe that from all those techniques, the most efficient and easy technique is probably the technique of doing it with a tutti scope. So now I'd like to go to the next slide here. So basically, you have to make sure that your target is the biggest possible. This is where inflating the bowel with normal saline, giving Buscopan, glucagon really helps a lot. And the second message that we've learned the hard way sometimes is let the cautery work. You really have to let it work, like very gently let that cautery get you into the targeted bowel. If you start pushing the bowel too fast, the bowel will escape from you. And then once you have deployed that first flange, what we typically do, we don't lock the system, the deployment system. So because we want the first flange to open and advance further into the bowel, so you don't lose it. Once you have that, you can then bring the bowel against the stomach and do the apposition, and it's much easier. Okay. So if misdeployment occur, so number one, stay calm. The majority of them luckily can be managed endoscopically. Stabilize the patient, and then you have to decide what to do. If you have a type 1, you can remove the lamps and just close it. If you have a type 1, 2, and 3, you could, if need be, jump into the peritoneum and bridge it. And I think once you're committed, this is a technique that could be very safe as long as you're comfortable and you have the right instrument. And then the other thing you can do is let the fistula mature and bring the patient back to remove the lamps and close the side. This is when you have deployed it into the colon. So I thank you for your attention. And I don't know if we're going to take some questions now or we're going to go over the cases. I guess we can take one or two questions quickly about technique, and then we're gonna go over the different other presentation. Thank you. Okay. So Paolo's telling me that actually we should move on with with the next two speakers, so that each one of them has 10 minutes. You want to use my computer, Matthew? Or? You want to plug it? Because if you want to plug it in, you can use this.
No, probably.
So you want to take it out?
Charger. Okay.
So I'm going to take it out.
Yeah, yeah. It's quite difficult to add some consideration because Michel showed everything so comprehensively. So just a comment, probably. We charged some tapes, but are similar. Type 1, type 2 notes. My question to Michel is, why did you choose an esophageal stent instead of another LAMS, same feature, the previous? Because it seems to be longer and... Oh, thank you. Scusa.
Okay, so that is indeed a great question. So the first time that it happened to us, we wanted to bridge, and my fear was that the bowel was already far enough, so I wanted a longer stent, and then the other thing that I wanted is a bigger stent, because I didn't want the stent to slide through the axios. So that's why we thought that the DTS stent was the best option. It's kind of an ERCP thinking. Like when you do ERCP and you bridge, you always try to bridge with a bigger stent in terms of diameter and a longer stent in terms of length. So that's, I just applied an old ERCP principle.
Okay, okay, thank you. Could you show us the first video GI, I don't know. Yeah. This is something that Michel showed very well. We try to identify the loop, jejunal loop, in a good window. We try to dilate as much as we can with the water and so on, methylene blue. When in this case, I don't know if you can see, we had some doubts about the right deployment of the distal flange, even if it seems inside the lumen. So this was a Spaxus stent. That's why the... Okay. I remind to you that the flange is completely different from the Axios stent. So in this case, we dilate as Michel showed us before, and we used, of course, the guide wire. Guide wire, on my personal point of view, is useful to describe if you are in a loop or not. The movement of the guide wire is useful, on my point of view, just for this. If you are free in the peritoneum, of course, the guide wire goes everywhere. So from that movements, you recognize that you got a misdeployment instead of the EUS image. That's why we used to preload the guide wire always. This is, of course, the same procedure that we perform, that Michel showed us. We were lucky because we use a lot the double channel endoscopes, so you can fix the loop and so on. I'm so sorry I cannot move the video. This is a knife, and then we put the second lamps inside. We can go to the other video, please. So probably we are in a hurry. It's similar to the moment. Yep, the other one is video GI2 probably. It's always type 1. wanted to show you this because it's nothing interesting, particularly interesting, but there are some questions that we can have to the audience. In this case, in which you are not so confident that you target the right loop, what are you going to do? So, if you can stop, remove the catheter and stop the procedure, remove the target and close the hole in the stomach, or do again a procedure. We tried the third. We close the hole in the stomach, as you can see with Ovesco, up, and then in the near side we place another one. So our thinking was, if we had a damage of a distal loop, we can close it using a lens, because it's near the previous hole. And so we prefer to use this strategy and to put another lens. If you want to add some consideration, fortunately we face just these two situations, fortunately. But it's always, our suggestion is not to escape, but try to, as Michel said before, try to be calm and use your weapon that you got in your room.
Yeah, definitely agree. Congratulations for your cases. And from the largest published experience, we know that misdeployment is 10% rate, but only 10% of this 10% needs surgery. So it means 1% of all our procedures. It means that in most cases we can solve the situation in our room. So these are perfect examples. Now, if there are questions for, yeah, we have 15 minutes more. Yeah. So I don't know if we have questions for Professor Di Matteo. Otherwise, maybe Professor Lactaglia wants to show his video. I can skip mine if you want to show yours. It's not a problem.
Thank you, Giuseppe, for allowing me to present on your time.
It's a pleasure.
Can we have the slides on, please? Yes. I think Michel covered most of these things and very nicely. And Demetrios, your videos are very nice. Thank you for educating us. These are lessons learned in humility. And who said that? As a person who's chairing the session, Michel Calle. He said yesterday. And we learned it hard way yesterday again in a different case, which was transmitted from a center in Hyderabad. So I'll skip some of these slides which have been shown. So in our place, we use double balloon occlusion to fix the small bowel, which is the target, the landing structure on which we place these lamps. And just to show you that, this is the double balloon in a cartoon format, which is generally straddled over the DJ flexure, fill the intervening area with a lot of saline contrast and a coloring agent, and then that becomes like a pseudocyst type structure, which is then targeted by lamps with a freehand technique. So this is how the double balloon looks like, and if you have a vertical limb, that's a safe landing zone. I'll skip this video, and that's how finally it looks like. If everything goes well, you feel on top of the world, but if things go wrong, then they can be really wrong. And I'll share one case here. This was a patient with non-Hodgkin's lymphoma due for chemotherapy, presenting an outlet obstruction. And before we start doing GJ in a patient, we always place a nasojejunal tube for feeding purpose for 1 or few days. This also lets us know there is no distal obstruction. He's tolerating feed, then he'll also tolerate a LAMS, which is placed for a GJ. Let me just run this video here. So this is the guide wire passed, and then we have the bowel which is ready. You can also see the tube inside, which kind of reconfirms that you're in the right organ or the target bowel. Looks quite straight. Now let me fast forward this video to the next one. So this is how we started. The balloons are in place, so we have the bowel fixed for us. This is almost an year ago. And while we are deploying, the stent is not opening. We also observed this yesterday. So inner flange is not opening. This is a fast forward video. This almost took 3 to 4 minutes. Normally they open very fast. And that's when you start getting jitters. What's going on? How long can we wait? And that's where sometimes a jiggling movement helps to expand it. Nevertheless, in this case, this was a learning lesson for us. We deployed the lamps without it fully expanded distal stent. Even the proximal valve did not expand. This is another slow part of the video, and you see the stent is going in. It's gone. It's gone outside the stomach. So we learned from the experts, one of us sitting here, that okay, come back with an endoscope. So we immediately passed the guide wire. That's the first thing we did. We had the preloaded guide wire. And now you see the stent there. The guide wire is inside. The balloons are inflated. But it's not going very deep. And then we dilate this path with a balloon. And then carry another lamps inside to catch it. At this point, we made one mistake of E-pass was deflated. Both the balloons are deflated. I think we should not have done that in hindsight, because what it did was the balloon, the bowel then moved away almost to the pelvis, and we're now catching it, trying to go. We place a nasocystic tube over the guide wire, so that remains as a target. And now we're following scope exchange with an upper GI scope, not a double channel scope. This did not cross our mind. Michelle, you have not been teaching me well. So stent is lying horizontally, the guide wire is still inside it. Now we've removed the E-pass and now carrying the endoscope after dilating the balloon. And now chasing the stent down. You see some indigo carmine there, but this is a stent hidden now behind the omentum. Even if we catch it, I don't know whether we can pull it out, because the stent is opened up now. We carried another stent over this guide wire, another lamps, hoping that if we can fix the distal part and pull it back. It didn't work out. Patient had palpitations, and we were on a higher heart rate than the patient while the case was ongoing. This is a second stent being deployed, so if we can grab and pull back. But the omentum was preventing us from dragging it further, and it was causing injury to the omentum, and that's when we said, okay, our time is up, let's call the surgeon. This was a type 3 type of adverse event. Surgeons immediately operated, and I'll show you the internal findings. So this is a stent hidden inside omentum. I don't know whether if you caught it also, we could not have pulled it out. Look at the Lehman opposing force. It went through the transverse mesocolon into the jejunum, and then they opened the lesser sac, removed the stent, and used the same opening to create a gastrojejunostomy using stapler. So they saved us, and they're always going to remind us each time we we take a case up for a gastrojejunostomy. So the learning lessons were be modest and be prepared for the worst. Wait a little longer for the axios flanges to open up. Jiggling helps. And I think I always use double balloon. And I think in this case, if I had not deflated the balloon, the loop would still have been closer to the stomach, and maybe we could have escaped the problem. Thank you very much for your kind attention.
Yeah, thank you, Sandeep. That was really a beautiful video. And, you know, another recollection about staying humble when you're doing those procedures. You want to show one of your video? We have time. Yeah, we
Yes,
have
if you
5
have
minutes.
time, I think you can please.
Thank you, thank you. You have already shown most events. I will just want you to see that sometimes it's not needed to escalate too much. As you know, we place an orojejunal tube inside the jejunum to inflate the small bowel. But as you can see in this case, the window is not so good because this is how it should appear on the right. But what we had here on the left is not enough dilated loop, large distance between the stomach and the small bowel, and a transverse direction of the loop. So when we advanced our electrocautery enhanced lumen opposing metal stent, this was a 20 millimeter Otaxios. Actually, we had some resistance. We could see some boiling effect in the jejunum, so we thought we were in the jejunum. But then, I'm sorry, probably I did something wrong. So we thought we were in, but then upon release of the lumps, so what you would do here is to retract the lumps, and you want to see the catheter inside the loop, and we were not seeing the lumps inside the loop, as you will see in a moment here. And upon release of these lumps in the stomach, we could not see any blue coming in the stomach. So what we love to do when we are in trouble is to inject some contrast through our orojejunal tube. As you can see here, contrast injection resulted in no aspiration of contrast through the lumps into the stomach. So this is a sign of incorrect placement of the lumps. And so here, what would you have done? And I don't know if you have your app, surgery, notes, redo use guided gastroenterostomy, or placing an enteral stent. If you have your app, you can vote. We have some results, or not? Okay, I will show you just what we, okay, perfect. So redo use guided gastroenterostomy is exactly what we thought to do, and this is especially due to the fact that we saw no enterotomy, I mean no leak of contrast on the jejunal side. So here is another advantage of having your orojejunal tube there. You can exclude large enterotomy, you can exclude leak of contrast from the jejunum, and now we deployed the second lumps, and as you can see now, upon retraction, you can see the lumps inside, and you can now inject contrast and aspirate contrast through the lumps into the stomach, and we usually dilate our lumps, and you can see now the jejunum through the lumps and the catheter. And as you can see, this is the whole of the previous lumps. You see no leak. So probably the electrocautery enhanced holes are, I mean, not very functional, or even if we decided, of course, to close that hole. So just to, you can find, I mean, in this publication, the signs of what we fear when we are misdeploying a stent, and signs of correct placement on the other side. maybe I will just stop here because in the interest of time.
Maybe we can take some questions or comments from the audience before we wind up the session. Yes, please.
Yeah. Do you have any suggestion about any eventual abdomen decompression while you're doing peritoneoscopy?
I think, Dario, your point is well taken. If the abdominal compartment syndrome kind of situation happens and the oxygen is dropping and CO2 retention is happening, it's worthwhile placing a syringe or a needle inside the peritoneal cavity like people do for POEM and other things.
Yeah, there is also a very nice video on the ESG guidelines about managing of perforation. There's a nice video of decompression with a venous cannula of the abdomen in case you have compartment syndrome.
Andiamo alla mia immagine sul videoschermo grande.
I think Professor Arcidiacono is calling us in the room, so enjoy the next steps of this Congress and see you there.
Thank you.
Good morning. Good morning. Thank you. Thank you very much, Michelle, and thank you very much to all the panelists. Very interesting talk. But today it's my pleasure to start our first connection of the day with the Institute of Digestive and Liver Care in Mumbai. Professor Deer, I don't need absolutely to present Professor Deer because everybody knows him very well. So Vinay, good morning. Welcome to EURO-US. We are ready to have your talk and your cases.
Thank you, Paolo. Thank you very much for having me in this conference. And I'm hearing the lectures, very, very wonderful lectures. Sandeep, Yusuf really showed us wonderful videos. I have 20 minutes for this case. So I already have started this case. Just to introduce, let me show you the history briefly. Can we put on the history, please? Basically, this is a guy with a CA head pancreas and obstructive jaundice, bilirubin of 22, dilated CBD, IHBR, and ERCP attempted outside failed. They have referred to us. We could have done an ERCP before, but since this conference was coming up, we thought we will show an antegrade procedure. Bibin, forget it. Can we show the live? The images, please. So as we had a little less time, I thought I will start the procedure. And I started the procedure and I made a very common, very silly mistake, not common, a silly mistake, which I will show you what I have done. So we went into segment 3 and we injected contrast. Give me the EUS pictures, please. And you will immediately know what has happened. So we start with this problem and then we are trying to sort this out. Just give me 1 minute. We'll get you the live here. So basically what happened is we forgot to prime the needle. And so what I have is air everywhere. So a basic learning point here, always prime your needle before you put it in. Otherwise, you will have a picture like what you are seeing now. So there is air everywhere and you do not see much of, dilated radicals.
We're not
sorry,
seeing the
take a moment.
EUS yet, yeah.
Yeah. We are giving you, give me a minute. We are giving you the live. So just hold on. So, Are you hearing me, Paulo?
Hear you very well.
But we cannot see you,
Okay,
unfortunately.
okay. No, we'll get you, we'll get you.
We're getting some modern art interpretation of you
Yes.
in real time.
Yes.
No, I think connected to the room. He right outside. He's so these are sometimes usual issues. Yeah. So you are seeing me very well, but you are not seeing any of the images.
At the moment, you're back, and
Yeah.
we are
You see
seeing.
now?
Yes, perfect.
You are seeing a lot of air.
We are seeing a lot
We're
of
seeing
air.
Paulo.
Yes. I'm seeing everything. So
I'm
now
in
we
a-
are
We're
moving
seeing Paulo.
to. Yeah, I know. But here in my room, I can see everything. So, but now you can see everything as well. So.
Okay, is it seen in the auditorium now?
Yes.
Okay. So what I have done is I have removed the 19 gauge needle because I was not confident of getting the right puncture. And I have put in a 22 gauge needle, which I am a little more confident with. It will not cause much trauma, will not go into the vessels. And I am trying to see if we can inject some saline and make the duct visible. So Bipin, if you can inject some saline here, saline. Yeah. Is it going easily? Good. So you see, injection of saline will hopefully push the bubbles away and also dilate this area so that I can puncture it if needed with a 19 gauge. I also like to always do a fluoro. Show me the fluoro.
Vinay, the
Can you see
patient
the
is in a
fluoro?
prone position?
Patient is in a supine position.
Okay.
So we do these procedures in a supine position. The patient is on his back. And on fluoro, you can see the needle position. So we have punctured the segment 3. What I will try now is rather than changing the needle, we'll pass an overnight wire and see if it goes easily. So Bipin will pass an overnight wire. Before that, let's inject some contrast to see what is the roadmap. This can be dicey because sometimes you may puncture something other than the radicals, and then there will be issues. So slow injection, please. Let me see where things are going. Correct the thing. Yeah, inject. Is it going? Yeah. Okay, so I think we are in the biliary radical. Saline. So this is a segment 3 radical. You should look on my fluoro and see the position looks pretty good. The scope is tipped up, the needle is looking up, and you can see the segment 2 radical also coming that side. So we use a 018, a very thin wire. The problems with this wire is it doesn't take accessories very well, and it is not seen so well on fluoro. But since I already have a 22 gauge needle in, I thought let me try for 1 or 2 minutes whether we can pass it and then pass a cystotome over it. Then of course we can exchange the wires. So Bipin is passing the wire. So it is a Terimo, 018 Terimo. We also have, I think, the Boston 018, which is a straight wire, pretty good wire. So this one is a Terimo wire, and let's see. Are you able to see the wire? I think it's a little faint, but it's going down. Change the other direction. Yeah. Magnify this fluoro image, please. No, it is going down. You want me to withdraw a little? It's very important for us to have a coordination with, now it's good. Going down, withdraw completely. Withdraw completely. Withdraw. Gently withdraw. Gently withdraw. Now move up in the other direction. Needle withdraw. Okay. I am withdrawing the needle a bit. Now. This is better. Slowly go in that direction. So you need a good wire manipulation for antegrade if you want to do antegrade procedures. I know not very popular. I love these procedures. They are my go-to procedures. Very nice. Now go a little more forward and turn. Yeah, very nice. Now turn more. See where it is going? Can you see the wire or is it not seen there on the fluoro?
It's
Hello?
faint, but you can see it.
Very faint, no? Yeah. Yeah, so the wire is nicely going from segment 3 down. कहाँ तक पहुँचा? Yeah, nice. Has it turned there? It should go straight. Oil here. Ah, fantastic, fantastic. You can see the wire going down. I know it's very faint.
Yes.
But, ठीक है. Can you see? So we are into the bile duct now. We will coil it here and remove the needle and pass the cystotome. So always have these all kinds of wires with you. If you are trying these, should I remove? Nikalu? So I am removing the needle now. And Deepak, my other assistant, his job is to see that the wire is always seen on ultrasound. So slowly, 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 slowly. Yeah. So you see, it's important that you see the wire in the EUS image. Because when you are using the cystotome, this is a 018 wire. It doesn't have any strength. So you need to see the wire on the ultrasound image when you are burning through the liver. Are we okay? Ready? Nikalo? Good. So you see we did the rapid exchange method with the saline infusion. So he used a small syringe at the back because this is a short wire, 260 centimeters. So the exchange is faster if you do it like that. Now we are using a 6 French cystotome and Aya?
Do you reuse your cystotomes?
Don't ask me. In India, we have to reuse everything. Aya. So we are having a little. Aya, pakado. वायर बराबर आ नहीं रहा है आया वायर थोड़ा खींच हाँ so now you see on fluoro image the cystotome is out and I want to see the wire nicely on EUS image before I puncture. So here is the cystotome. I think I am through. Can you see on fluoro image?
Looks nice.
So we are in the bile duct now. Now what we will do is inject a little more contrast to see what's happening in the distal part. And I'm removing the overnight wire. And we inject a bit to see what's happening there. So the magnification is off, we don't need it anymore. Contrast please. More, little more contrast. Okay, so that is, we are at the level of the block actually. You can see bilateral dilatation. Now the critical part is to be able to pass the wire across the stenosis. So that is the limiting step for antegrade procedure. Everything else till now is exactly what we do for HGS. Now, what wire are we using? Now we are using Terimo 032. This is our favorite wire. We love that wire, 260 centimeters. And very easy to go through strictures with this wire. We love that wire. नीचे कुछ contrast गया क्या? That is a cystic duct. Okay, some contrast has gone into the duodenum also, so I am hopeful. Winter. Okay, I'm coming up. So basically this is an angled J-tipped Terimo. We have to find where the opening is and then go. मैग्नीफाई कर लो ना, उनको भी कुछ दिख नहीं रहा होगा. Now we are very okay. Turn clock इस तरफ, duodenum की तरफ. Yeah. किधर जा रही है? So this is a hugely dilated system, and sometimes then it creates a problem in passing the wire because the wire keeps on coiling. So the cystotome should help if we can find the opening. At this stage, most of us give up and say, let's do a HGS. What is the use of doing all this? It's relevant here because we can use the ERCP stents, which are cheaper than the EUS specific stents which are available, much cheaper. And very nice, that is going good. And most of the patients still in India don't have insurance. So we save some money for them if we try another 10-15 minutes. So that's why this is my favorite procedure for EUS guided biliary drainage. But looks like here we are in a big soup because we are not seeing any opening. Okay, okay, okay. You are good, 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 good. Fantastic. Great, great. You are in the duodenum. You saw how angled it was? It's a hugely dilated system. Now we are going through the tumor gently. I think I am in the duodenum now. Okay, inject. We'll confirm that we are in the duodenum. था, तूने वायर किधर किया, पोजीशन दिया सब, आप रे, ये क्या है? इंजेक्ट किया? चलो नीचे इंजेक्ट करके देखो, पकड़ के रख, कुछ दिख नहीं रहा है। नीचे नीचे नीचे। Okay, now we'll inject some contrast. Inject, na? Hmm? Okay, we are in the duodenum. एक Buscopan दे दो please. Fine. You want me to go further forward? ऊपर दिखाओ. वो स्कोप खिसक रहा है मेरे को लगता है, बहुत नीचे चला गया स्कोप. नहीं नहीं वो दिखा स्कोप मेरा. ये देखिए मैं करता हूँ ना, स्कोप खिसक रहा है. दिखाओ नीचे दिखाओ. हाँ ठीक है. Pass the stiff wire. So one more step now, passing the stiff wire and then finally place the stent. अभी आया पकड़. And you see on the ultrasound image, you are still seeing my wire and my cystotome in place. That is crucial. Please keep looking at it, because sometimes the scope position changes, and when you have punctured at one spot and then placed the stent at another spot, निकाल दो. ऐसा रखना यार, प्रॉब्लम क्या है मेरे समझ में नहीं आ रहा है. ऐसा निकालो. So I am removing the cystotome now. You see the wire is deep in D3. निकालो. 6 centimeter. We are going to place a 6 centimeter uncovered self-expandable metallic stent.
We have a question from the floor, Professor. They're asking if can you use cutting for passing the tumor with a cystotome if the stenosis is very narrowed and hard?
That's a very good question, and the answer is yes. You can use a cystotome to go through the tumor if you are not able to pass the wire easily.
And what settings do you use on the cystotome?
So we use the same settings as we use for lamps, 100 or 120 pure cut. Now this is the last step. Are you seeing on fluoro? You have to be very careful, because you will immediately know if you are in the right area or not with your scope. Sometimes the scope moves and the scope starts, you see. It's important that you check that the stent initially has entered the liver. So do it slowly, very slowly. The next step is when it turns at the hilum. That time it pushes your scope back. So you have to do this step very gingerly, otherwise you will lose position. So see this? This is a difficult, and now I have you will have to remove the wire a bit. थोड़ा वायर निकालना पड़ेगा. So these small things matter, because now see, if you see my endoscope, it's looking very bad. See this? Now नहीं कुछ नहीं, पीछे करना पड़ेगा. So I'm coming back a little, trying to come close to and see if it goes. So at the hilum, तेरे को वो निकालना पड़ेगा, हाँ, wire. See, it has to, ठीक है, Flora? It has to turn there. Once it turns, then it is easy. But if it doesn't turn, then it creates a loop in the stomach wall. Show me the stomach. Stomach, other way. See this? How far I am now?
You never go to endoscopy. You always stay with the U.S.
If you go to endoscopy, you are finished. Now, if you see on EUS, my scope position is completely changed. So this is not a good sign. I need to bring it back to where I was. So I'm trying to see where the wire is, where the liver is. See? Now I've got it here. See this? Here. So I've got it back to where it should be. And if you see on fluoro now, this looks a good position to push. I hope it goes. So I'm doing gentle movements. You see the stomach is not happy. It's moving up and down, but the stent is moving down. So these are small steps which we need to be always careful about. You tend to go far away from the stomach, liver wall. See, I am now very far from the liver wall. So you can again try to adjust your position, withdraw a little bit, bring it in line, and see where is the ultrasound. See that on ultrasound I am seeing, see this, now I am seeing this. This looks like a good position. So in easy cases, it is very easy. But sometimes, if the tumor is tight or if there is a complex stricture, it doesn't work out the way we want it to work. So now we are at the stenosis. I hope the stent goes through, otherwise I'll withdraw the stent and again dilate that area like was suggested before. So I hope it will go here. A little bit I'll try. Wire kitna hai niche? So all these times Bibin is managing the wire. नहीं नीचे कितना है wire? नहीं तो बड़ा हो गया. Floppy tip नहीं आ जाना चाहिए. It has to go through the tumor and it's creating problems for us. Again, I will change the position. See that I am in good position of the scope. Now, last 2 centimeters is remaining. I hope it goes. Yeah, it is going, slowly but going. So, if we anticipate that it is going to be tough, then it is better to dilate as was suggested. But I think now we are through almost. Are we through? Inject karo. Let's inject and see if we are in the duodenum. Yeah. Okay. Inject more. Inject more. I want to see, and that is the next part here. You have to check the position of the papilla. So you have to inject contrast in the duodenum to see where the stent is crossing the duodenum. This looks like pretty good to me, but what we will do is we will open the stent a little bit. Since this is a expandable biliary stent, we can always close it back again if you are not happy. So open a bit. Open. Magnified, eh? Magnify karo please. I want to see the stent opening. Looks satisfactory. See, it is nicely opened in the duodenum. Okay. Slowly keep withdrawing. Slowly keep withdrawing. Yeah. Upper. Show me above. Okay. Okay. And we are done.
Nice.
Great.
Thank you.
Great, Vinay.
Thank you.
Thank you very much. Fantastic procedures as always.
Thank you. Thank you.
See you very soon for another case.
Sure.
So
Thank
now
you very much.
So now we start the first case here in Milan in San Raffaele HPB unit. We present the case in room number 5.
Okay, so the first case of room number 5 is a patient of 60 years old, is a female. So she was admitted to emergency department for abdominal pain, and for this reason she undergo an abdominal CT scan and an MRI showing esophageal cystic lesion of the pancreatic body, 36 millimeters in size, conditioning upstream dilation of the main pancreatic duct. The tumor markers showed an increase of CA 19.9 of 50 with a normal value of below 37. So here we can see the lesion of the pancreas. Today's procedure is a fine needle, EUS plus fine needle aspiration with rapid onset evaluation. The operator, Prof. Iglesias Garcia and Prof. Useroli.
Hello, Julio, Pietro, good morning.
Hello, good morning to everyone.
Thank you for waiting for us. But this means that you have very, very few minutes to show everything and to perform something, okay? Thank you guys, good work.
Okay, Paolo, well, thank you very much again for letting us be in here. I'm working with the team, with Pietro, Matteo, Antonio, and all the anesthesiologist team and all the people that is helping. We work with the Olympus system, with the MCU3 console, and we just have the stable image to show you just the first impression that we were discussing with Matteo and with Pietro, how important is the role of AUS in the evaluation of pancreatic lesions. Because we are coming from the CT, that it seems to be just a cystic lesion, probably with a suspected degeneration, but what we saw is completely different to the CT. Yes. So, Pietro, you can show the image and talk about the elasto evaluation that we just have a still image to show you. But we can see it's not really we will show you the cystic component, but it's really a solid pancreatic tumor, big one, over 3 centimeters, hypoechoic, irregular, infiltrative pattern. You are looking to the elasto evaluation. It's a hard lesion, mainly blue. We've done the histogram. In the histogram, we have a value of 30, below 50. So this is providing a lot of information in this moment that this is really a pancreatic malignant tumor. Based on elasto, we see that is also confirming the idea of malignancy. And now we will unfreeze and we'll show you live everything that we see.
Just to mention, Julio, that this technique is based on the Hugh histogram. So we were discussing we can get rid of the reference area with the Hugh histogram.
Absolutely.
As opposed to the strain ratio. So we just evaluate the tumor area with just one ROI. And this curve is a very reliable curve because we have just one peak and it's all concentrated in the blue area. So we think this is very hard tissue. So let me now unfreeze for you.
Yes.
And so you can show the B mode.
And when we arrived to the lesion, and now we are in the pancreatic body because everything was located, the first thing when we started, we see this is the cystic component. So of course we agree with the CT scan that we have a cystic component, but when we look at the cystic lesion, it is not the typical pattern that we see in an IPMN, because it's a dirty content inside, it's like a lot of debris inside. So our first impression when we see this type of characteristics in a cystic lesion is more linked to a pseudocyst with debris inside. So when we see this type of content in the cystic, we start to change a little bit our mind and try to see what is really going on and what is the cause of this cystic part. So we start to gently focus on the pancreas and on the rest of the exploration, and a solid component appears, and this is exactly the main cause of the disease of the patient, because what we are really looking to is a solid pancreatic mass, and probably it is producing and inducing an obstructive pseudocyst. And we will try to show you very nicely the PD. That is, look, this is the lesion. Pietro is showing the lesion, and now we are going to focus on the PD. And we see that from this solid component, we start to see a dilation of the PD. I'm tracing, doing a very gently right rotation, clockwise rotation. So we're going to the pancreatic tail, so there is almost no pancreas anymore. It's like a huge atrophy of the pancreas with a dilation of the PD. So this is another sign in favor of a malignant pancreatic tumor, not so much a degenerated IPMN. So we keep tracing, trying to reach the pancreatic tail. We now see the left adrenal gland there in the screen, I think. And again, we are now looking to too many tubes in the upper part of the screen. So when you do this complete evaluation and you start to see too many tubes, maybe it's not something very nice going on related to the pancreas. So this is very important. This is the spleen. So we are very close to the fundus of the stomach, and this is collaterals that we should not see in a normal patients. So this we were discussing. There's a very nice study from Elubedi showing that if you see collaterals when you are facing a solid pancreatic tumor, maybe it's because the message is this is an advanced pancreatic tumor with vascular infiltration. So we start to have a completely different approach to, according to the CT. It is not an IPMN. This seems to be a pancreatic cancer with dilation of the PD related to the obstruction, with pancreatic atrophy related to the obstruction. So it's like chronic pancreatitis changes because of the obstruction of the mass, with a cystic component, probably a retention cyst, that it can be a good concept. Do you know, Pietro, Matteo, what's your thoughts on these ideas? Yes?
Do you think it could be a malignant transformation of an IPMN?
To be honest, my first idea, more than a malignant transformation, I will state first this is a pancreatic cancer with an obstructive PD and a retention cyst. This is my first impression.
But in order to answer this question, we might go to contrast.
Yes.
Because if this is a malignant transformation of IPMN, we might expect a ISO-enhanced tumor. So let's move to contrast, and let's get ready with Sonoview injection, please. So
this is the good thing to work with Pietro. Yes, please.
So the mechanical index. Yeah. Injected? Okay, so we start the counter. Timer? Yes. Okay. Okay, so you see on the right the splenic arteries and veins that have been filled by the contrast. What do you think of the tumor, the primary tumor, Julio?
I think the primary tumor is hypovascular, so there is not really uptake. This is a very nice image that we have of the tumor. And we see that is some arteries that is very common to see in pancreatic adeno, that we have some arteries in the arterial phase, but then we have the washout, but there is no uptake in the component. So this is very typical of pancreatic adenocarcinoma.
I agree. This speaks in favor of a pancreatic ductal adenocarcinoma.
And in fact, if we go to see, look, there is no single, there is completely avascular. There's nothing inside, and this is also in favor of this, might be being a pancreatic tumor with a retention cyst.
Yeah. So now, if I look at all these vessels, I think of Julio, who has to perform a fine needle biopsy through somehow.
See, sometimes when you take these cases, you see, this is great, we have a pancreatic body mass, so it's the best place to access the lesion, no problems, and then you have this image, and you say, okay. So, and we are in the meeting, which is complications related to AUS. So we will try to end the procedure with no complications. But very important information, because we were discussing again with Pietro. I mean, we have not only role for biopsy, not only role for advanced imaging, but we have a critical role for staging pancreatic cancer. So we have a lot of very nice information here to provide before going to the biopsy, because look, now we have all the artifacts of the vessels, but now it's of help, because we can see there is an absolute infiltration of the splenic artery and of the splenic vein. We can see that they are absolutely inside of the tumor.
Yes.
We have another very nice information that we obtained before is the collaterals that we saw in the fundus. That means that probably there's so much more infiltration. But before we get on live, we went to look at the flow in the aorta, which is not so nice. And we can see going out of the celiac axis at the superior mesenteric artery, and that flow and that enlargement of the wall of the celiac axis is not very good looking. So this is some of the signs that you might see when you stage pancreatic cancer, and it's what is called the encasement of the vessels. That is a sign of vascular infiltration.
And this is also how contrast can help you in improving staging capabilities of US. Because you can see with the tissue harmonic mode, you are still able to see contrast effect for many more minutes, as opposed to standard B mode like this, where it's less visible.
So now we are going to make, if you all agree, we have, I think it's clear that we have a pancreatic tumor, 3.5, 3.6 centimeters with a cystic component that seems a retention cyst with vascular infiltration, so it seems to be a locally advanced. And now we go to the best part of the technique, that is trying to make a biopsy through all the vessels.
So what needle would you use?
Okay, I think in this case, we're going to use the new Acquire 25S with, you know that this is a new, very good idea of the design, because one of the problems of the Francine type needles is that you need to puncture with three things at the same time. I always tell the same joke. If you want to kill someone, use one knife, don't use three. Because if you want to kill someone with three knives, you need to be really very strong, like The Rock. So we want something softer to go inside of the lesion, so that means that you need something sharper. So the concept of this is try to have to use the stylet all the time, because we have a sharp stylet in the tip, going a little bit out of the needle, so it's much easier to go through the stomach. That is the most critical part. So the key thing of this needle is don't remove the stylet before going for the biopsy. So you need to remove the stylet once you are inside of the lesion.
Yeah. This
Professor,
is particularly important from the stomach, where the gastric wall can bounce away from you.
Did you get any important information by the contrast enhancement behavior of the lesion to eventually target any specific area of the lesion during FMB?
There's a couple of trials stating that it's not really an advantage, because we are all biased by the expertise of using B mode. But it's true that in these cases, try to focus in the areas of hypovascularity, because not in the avascular pattern. Sometimes when you do pancreatic cancer, you see a lot of non-uptake at all. That means that is the necrotic part of the tumor. So try to avoid the pure non-uptake and try to focus on the hypovascular. When you have a little bit of uptake and then it washes out, that is probably the best place to place the needle. And something similar to Elasto. The heterogenic pattern, and this is more for qualitative than for quantitative. When you look to the qualitative, go for the blue component, because the green is usually the necrotic debris in the pancreatic cancer. Though it is very difficult to go for a trial, because we are already biased from the beginning. So I think this is the best accessed way. So you can use the Doppler if you want, so you will be a little bit afraid. So you can put an ECG in yourself to see how you start to increase your heart rate. So a couple of tips and tricks, because this is for tips and tricks. When you have this issue, you just need to take the stylet and try to displace the first vessel, even if you need to go much far away with the sheet. So now we have the sheet, and I'm going to push away the vessel with the elevator.
So the sheath is now almost entirely out at 5 centimeters.
So I'm trying, what I'm going to try to do is try to use the, okay.
You see
now you see the tip of the needle.
Here?
So we have the vessel below, and we have the other vessel getting away from the needle. So now I'm going to try to go very gently, skipping the vessel very gently, and now I'm inside in between the vessels.
Very nice.
So now we are going to take out, and it's very easy to go inside with this needle because it's very sharp. So again, with this needle, again, there's another idea, because the stylet is a little bit bigger, so do a slow pull. I know that if Sahan is in the room, will say, no slow pull, no aspiration, no nothing, just put the needle inside of the lesion. Sometimes I agree. But it seems that with a slow pull, in this case, we can obtain a better material. So I'm not going to do so much fanning in this case, because I don't want to get problems with the vessels. And I hope the sample is going to be good by just going back and forth slowly.
Per favore.
Yeah. There's no room for fanning in this case.
Better not do fanning in this case.
Yes.
And let's hope. Okay, I think we're done. Now we're going to take the needle out, secure, not to break the scope.
Julio, Pietro.
Yes.
Paul.
Fantastic show. Thank you very much.
Okay.
Everybody could follow the results of the adequacy of the specimen on the Vivascope on the Express channel. So if you want to see what's happening, you can go ahead with this channel. So now we are going to present the next case in room number 6.
The next case is an 81-year-old female. She had bilateral breast cancer in 1999 and Klatskin tumor with nodal and lung metastases in 2020. She underwent ERCP in July 2021, placing a double uncovered SEMS in left and right biliary ducts. Multiple episodes of cholangitis with endoscopic clearance of common bile duct stones. In February 2023, she had abscess in left intrahepatic biliary tree, for which she underwent use-guided hepatogastrostomy. The last CT scan showed disease progression with also infiltration of gallbladder, pancreatic head, portal vein, common hepatic artery, and first duodenal portion, causing gastric capillary obstruction. Today's procedures is use-guided gastroenteroanastomosis. Operators are Professor Di Matteo and Professor Lavtakia.
Francesco, Sandeep, good morning.
Good morning.
Good morning, hello.
Hello.
Hi, ciao.
Thank you for waiting for us. We have seen you on the other channel that you have already performed something. So you can start the procedure and explain us what are your algorithm now.
Okay, thank you so much for the kind invitation. Thank you so much for choosing an opinion leader like Professor Sandeep on this argument. So I'm feeling comfortable enough after a speech about the complication of GE. And so I'm here with the staff, with Delfina, Vito, and the anesthesiologist that is vaporized. No, Olivia, okay? Thank you so much. We have placed already with us by the same instrument. I mean, Fujifilm EG740 UT, the new probe, and the Arietta 850. We place a tube, a nose biliary tube, 8.5 French, over the stenosis, bypassing the stenosis. And now we are feeling the jejunal loop, try to select the best windows to use. And I'm asking to the colleague to use water as much as you can. And we are trying with the X-ray too.
Thank you, Livia, for injecting that. Do you have the EUS and the fluoroscopy view on the screen?
Yes. So you're not using the double balloon?
Unfortunately, we don't have a double balloon. As you know, in Europe, we don't know.
I am the double balloon.
Yes, as you can see from the EUS picture, ultrasound picture, probably this is a good axis to use. Again, try to. No, but methylene blue and water. Yeah, I'm asking to the anesthesiologist now using the hypotonic drug as Buscopan or glucagon. Not so much, but.
And the patient is supine or stomach or what position?
Supine position.
Supine. As you can see, the target is beyond where the tip of the tube is, nasocystic tube. So it's beyond that.
We prefer to use a lens
pre-charged with a guide wire inside. Just
in case.
Yeah, just in case. Thank you so much.
A 20 millimeter?
Like a very good landing site.
Ne avrò bisogno di tanto. Anche io no.
Professor, do you think that Trendelenburg position could favor better access due to gravity countertraction of the bowel? Do you ever use it? Do you think it's useful?
Not personally. I don't know, Professor Lactakia.
So we don't use that. My personal preference is a prone position so that the stomach gets compressed against the table. But everybody has an individual way of doing it. That's a good novel thought that you suggested of a reverse Trendelenburg position where head is low and the bowel can then be a little more dependent towards the stomach side. That can be considered. It's an interesting thought. But idea is to bring the target loop as close to the stomach so there is not much of intervening vessel or any vital organ.
So do you always keep the Doppler on all the time?
That will, I think he'll pull it out in the last minute. He's just playing around for the time being. You want it off or?
No, just, we are going to check the axis.
Okay,
just,
okay,
yeah.
okay.
Then, of course, we have to remove. Stai mettendo ancora? Mi dai del blu?
So some more flush of saline by Livia. Thank you.
So I would note for the audience, when you keep the Doppler, when you're doing the cautery, it can cause a lot of artifact, and I think it's really important to really see the catheter clearly at that time. That's the most critical time to really make sure that the catheter is going smoothly in. And if you have artifact from the Doppler, I think it can make it very difficult.
That's a good one. That's a good one.
Puoi dare ancora Buscopan, per favore?
As you can see on the screen, the catheter on the left of the screen, and that's a distance of 6.6 millimeter tangent.
Hai dato Buscopan ancora? Grazie.
The fluoro is off now. Sorry, the Doppler is off.
Fai vedere per favore? Seems inside, but I want to be sure.
I think it's in now.
Scopiare per favore.
Yes. So that's the stent in the bowel. Just want to be very sure. Is it? He's deploying the proximal flange in the channel.
It's a 20-millimeter stent.
Yes.
Isn't it? Okay. So we should see the
Look at
lens at 5 o'clock. We have to move a lot because it's...
The blue color when it comes out would be the
proof.
Evidence to suggest that we are in the right position. The EUS view was not perfect, I would say, at the time of landing inside, but let's see.
There was a lot of air on one side. It was a bit difficult to see really where the stent was.
We want to see if there's...
The bowel now, and the blue color.
Yeah, blue color. Blue color is our drug, vasoactive drug for our coronary artery. There's no blue color, so we have to probably use...
Some blue color is coming out, some blue is coming, it's coming, you have to suck it out.
So, we removed it.
Yeah,
Could
we
you
can,
stay there with
we can
the
leave the wire inside and maybe then suction may be a little better.
Yeah.
If we leave the, yeah, the here it comes, here it comes.
Piano, 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 piano. Could you show us? Thank you for your support, but
Yeah,
I was...
He still wants to double check it.
Yeah,
So we're taking out the assembly, leaving the guide wire inside, and we'll try to see the folds of jejunum, if we can see that.
Yeah, you see that with the G lock, it's quite fast the maneuver.
Can you try to inject through the nasal tube?
Of course.
Some contrast in order to see the contrast flowing out.
Yeah, that's a good idea.
Yeah.
I'm looking for
contrast.
a
Do you have a contrast in that? Yeah, okay. So, Livia is injecting some contrast through the nasocystic tube, which is positioned at the DJ flexure. Although our puncture
Mettiamo
is
grande
much,
l'immagine radiologica.
I think.
What do you say, Professor? Like that, yeah.
Let's keep a watch on it for some more time.
Yeah. We are not in a hurry.
We're not in a hurry. Absolutely not. I think these are very crucial steps to be 100% sure that the job is perfectly done.
We can put the contrast medium from the instrument.
Yes, I think maybe a catheter. So we can inject.
Datevi ancora l'immagine radiologica però ragazzi, non solo quella endoscopica.
Yeah.
Mettiamo il cateterino di prima?
Okay.
No, just directly.
Direttamente lì?
Yeah.
So the advantage of puncturing at the loop of the nasocystic tube is that you can inject and it comes out, and that's a target. Here we are more distal to the nasocystic tube position, and that's why we want to be extra careful of the position. So we take different clues. If you see the fold, see the contrast leaking out or the blue color coming out. So blue color is certainly coming out, that's for sure. There's no leak of contrast outside the bowel, and that's very reassuring. I think we are in. I think we are in a good position.
Okay. I follow the suggestion of Professor Laktakia, so
No,
it's
okay.
okay.
Yeah. So we'll inject some contrast now through the, and whether it's fluoro. So there is no leakage outside, as you can see. It's only the bowel which is getting filled through the stent.
If
Yeah, I
not,
think it moved. It moved. It's in the bowel. That's for sure now.
Yeah.
Yeah, let's see. You see. Yeah. So when you suck, that bowel comes up.
Yeah,
And
right.
that's a proof of the accurate positioning.
we can use
Well done.
a gastroscope to
Yeah,
check
yeah.
it.
So, would you like to dilate and see, or just leave it like that?
We just leave it
Leave
like
it like
that,
that.
usually, but in case of some doubts, we prefer to dilate and go in. I don't know. And do you use a double pigtail to protect
not
the,
necessary. Not necessary.
the
I think
jejunal
we're
loop?
in a good position. So we've got some evidence to suggest that it's accurately placed. The contrast is very nicely seen when he's sucking. The loop gets pulled back. There's no leakage of contrast outside the lumen. One more thing which you could have seen was if the tube was very close by, we could have seen the tube like we saw yesterday when Michel was placing the Axios in the afferent loop. Or if you see the folds of the jejunum. I think we are in a good position. So what Professor DiMatteo is doing is pulling out everything, and maybe he'll just pass an endoscope to see what's happening from the end-on view of the stent. I think every effort should be made to reconfirm. But I think it's quite accurate. Anand, what do you feel? Dario?
Yeah, I think
it seems somewhat convincing.
Yeah, it is convincing. Even if you have a look to the X-ray image, it's quite. I feel really comfortable because there is no air under the diaphragm, so I think it's nicely done.
So Francesco Sandeep, while you are moving to the gastroscope, we present the next case, and then we will back to you.
Sure, thank you.
Grazie.
Next case is a 73-year-old female. In 2016, she underwent pancreatic duodenectomy due to pancreatic cancer, followed by chemo and radiotherapy. In 2021, she had to undergo a resection of the duodenojejunal anastomosis due to actinic stenosis and the reconstruction of a gastrojejunal anastomosis on a Roux-en-Y loop. Since 2020, she presented with recurring episodes of cholangitis, with radiologic evidence of stenosis of the biliodigestive anastomosis and episodic dilation of the afferent loop. An colonoscopy-assisted ERCP was attempted, but didn't reach the anastomosis. In February 2024, she was admitted to ER due to fever, and a 7 by 4 centimeter abscess in the 7th segment was detected. So a decision was made to perform an US-assisted transenteric ERCP. Operators will be Professor Chahal and Professor Calais.
Pablin, Professor Chahal, Professor
Yes.
Kahela, good morning, welcome back.
Hello.
Hello.
So we
You are-
have a very challenging case.
Yeah, we know that you are struggling. We have seen your procedures since now. So please go ahead. We are going to move to another room in a few minutes, but just show us what you have done until now and what you are planning to do.
Hi, good morning, everyone. So this is a patient with an unknown length of Roux limb. We don't know where the afferent limb is because of the recent surgery. So we tried to go with a colonoscope first, and then we got down. There was a stricture, presumably somewhere in the Roux limb. Although the patient is supposed to have a jejunojejunectomy, we were not able to pass the jejunojejunectomy, and then the afferent limb is beyond that. But we encountered the stricture before. That's where we left the wire. And then the nasobiliary drainage tube, as you see, the loop is way down. So the challenge is we don't even know how far down the nasobiliary tube is and how long the length of the afferent limb and biliary anastomosis is. So then we went with the EUS scope. We are trying to follow. It's a really atrophic pancreas. Look at the afferent limb anastomosis from close to the bile duct. Looks like on EUS we identified the afferent limb, and then we are trying to get into the afferent limb with a 19-gauge needle, see if we can inject a contrast and distend the afferent limb that way. Right now, the afferent limb is not distended. Patient doesn't have an afferent loop syndrome. So this is a very collapsed afferent loop. So that's another challenge we are dealing with. So we just got a needle in there. We injected a contrast a little bit to see if we are in the bowel or where we are. So far, that's where we are. Yes, it's a challenging case. Fluoro?
And that's one of the techniques that we were discussing about this morning, that, you know, you could directly puncture the loop that you're targeting and try to inflate. So this is where cautious and very careful injection of contrast should be done.
Can we get the fluoro image too, please?
Yes.
So this looks like a very, you know, like stenosed, sclerosed bowel, which is something that we do see. So this is on EUS. We saw it was not easy to get the needle through the bowel loop. I don't know if you can see the EUS images. This is an extremely thickened bowel loop. And that's something that we see somebody who is post-treatment. The bowel gets sclerosed, really thick, and that's almost like a lead pipe of an appearance. And these kind of bowels, they don't distend really well, as you can see. So that's another challenging situation here. And they also rip really easily. So if you try to do endoscopy in this and you try to balloon dilate and go, they rip apart very easily, this kind of bowel. So inject a little bit more. So thoughts here.
So
there. Yeah, looks like an afferent limb. Yeah, I think we are confident. But you look at the length of the sclerosed segment. That's just.
So Shahal,
yes.
We'll be back to you in 2 minutes. Thank you very much.
Sounds
we move
great.
to
Thank
room number 6.
Yeah.
Okay.
Far veloce.
Francesco, Sandeep, we are back with you. Give me the endoscopic image there. Okay. Datemi l'immagine endoscopica.
You want to speak?
Okay. So.
You are looking for a grasping.
Okay, so now we have passed a double channel endoscope and looking through the stent. What we see is some fat around.
Yeah, it's the loop, and you see the loop there.
Yeah, we see the loop. Just, I think the stent has scratched it and come out.
Yeah.
So we'll.
So you plan to perform a stent in stent.
Yeah, that's right.
To grab
that's right.
the loop.
Yeah, grab the loop. So is yours a forceps? Open, please.
Are you using a double channel?
Yeah, double channel scope. Yes.
Yes, great. So we will follow you on the express channel. If anybody wants to follow you, can follow you on the express channel. Then we go back to room number 7. Okay.
Right in the segment of the anastomosis.
Okay, guys, we are back with you.
Yeah, save that.
Go ahead.
Yeah.
Giuseppe, Michel.
So obviously,
we are back.
We basically injecting more contrast. I think in this stage, it's very important to understand the anatomy very well, and you can see that the opacification is now opacifying some of the biliary tree here.
Yeah. So I think you guys can see the retrograde reflux of the contrast. We think that's the bile duct, and you see the PD going across the spine. And then you see the sclerosed segment of the bowel. You see probably the distal biliary stricture, anastomotic stricture. You see a little bit of the air cholangiogram now. And we are right at the end of the afferent limb there, where the needle is. There, you see the bile duct opacifying higher up now. There you go. So yeah, we are confident we are right at the end of the afferent loop. And that's the disease segment of the bowel. It's a tough situation. You have about 5 centimeters of the bowel distal, so endoscopy will not be that easy. So now we are contemplating, should we just drain the afferent loop? Hopefully that'll help this patient a little bit.
So what we did is very important. We need to understand that this is a roadmap that's going to allow us to select the segment of the bowel where we will attempt to do the anastomosis. So if you look very carefully, half of the opacification is clearly not the place where you want to go. It's sclerotic, it's not expanding.
That's good. Save
you
that.
don't want to be there.
You see the bile duct.
So if you want to get an anastomosis, you need to go into the portion of the bowel that is more healthy, the lower portion of the bowel. You can see on the fluoroscopy. Very important to understand that part of the advanced endoscopy is injecting, understanding, and then making a decision based on the images.
Where do we place the
So you
lamps?
need to go down there.
Yeah, I know, but
Yeah, you
that
need
will just not gonna.
You
there's
probably
a
need to
stricture
remove your
lower
needle
down.
and go down with the scope.
No, there's a stricture lower down also.
I know, but see if you can get the scope close to those bowels there. It's much higher than where the nasocystic is. So now what we're going to do is we're going to use our injection to try to see if we can find those dilated healthy loop by EUS. So step one, distend. Step two, reorient your echo endoscope, trying to find those pieces of bowel that are more healthy that could sustain an anastomosis. Because anything closer to the biliary tree will not sustain an anastomosis. You gotta go a little bit further down.
Floro?
Okay, Michelle, thank you for explaining us your plan. We will be back to you in 2 minutes. Now we go to the room number 6.
Ritirati però. Non me la spingere lontano perché no, non facciamo.
Francesco, Sandeep, we are back with you.
Okay.
So you have already grabbed the
Bowel?
loop?
Yes.
Yes?
And he's got the needle knife with a guide wire inside ready. So Professor Di Matteo is making a small hole with a needle knife. As we saw in some of the videos in the morning. Is that okay?
Un po' di meno.
Yeah, maybe a little bulging area, maybe. That's very close to the forceps. Somewhere there.
Yeah. I try to see the movement that I can achieve. Okay.
Lasciamo.
Dentro. Fuori algo. Ok, fermati.
Yeah. I think that looks okay. That should be okay. Ready?
Connector.
All set? Connected?
Doesn't work. What's the message?
The cautery is not. Is it connected to the same cautery?
Okay.
Yeah, it got it. Okay, now you can maybe pass a wire inside. And then we have a fluoro, please.
Dentro, con l'ago? Sì. Ok, puoi mettere piano piano la guida? Con piano piano, proprio piano piano.
The wire is going in into the bowel. Yeah, now, yeah.
Ok, mi devi dare un po'
Okay, yeah. That's good.
Adesso posso recuperare un po' se vuoi. No, ok, mi va bene. Un po' più profonda. Sì.
Go deep as possible, yes. As deep as possible.
Sì, vengo via. Pronta un altro stent, un'altra LAMS?
Stent is ready? 2010,
Non ho l'elevatore, quindi mi tieni tutto fermo.
Vediamo?
Scopia.
So it exchange?
Sandeep, are you planning to put another lamps?
Yeah, so the stent is ready.
Yeah.
We are exchanging now, removing the needle knife, keeping the guide wire deep inside, and we'll place the stent. We have not dilated this stent, but I think it should be okay.
Okay, another 20 millimeters.
Yeah, another 20 millimeter, that's right.
Great.
I'm too expensive.
That's right. We'll only give antibiotics. We're using carbon dioxide, so it should not be a problem. We have salvaged the as nicely said by Giuseppe in the morning, that there can be 10% complications of EUS-GJ. Out of this 10%, only 10% go for surgery. 90% can be handled by endoscopy, as Professor Di Matteo is doing now, is handling that adverse event which has happened, but this is a salvageable situation.
Professor Di Matteo is so polite with us that he wants to show in direct the salvage
He's
I
very
didn't want
relaxed.
to do it.
He is very relaxed.
Yeah, I'm relaxed because I got the colleagues behind me.
I know Francesco since probably 25 years. He's always relaxed.
He's kept the room relaxed too.
Okay.
I have seen sometimes people start throwing tantrums, and that can be disastrous.
Sorry guys, I moved 2 minutes to another room.
Sure.
Yeah.
Okay.
Go to room number, I don't know the name, 7. Okay.
Okay.
Michel?
Yeah, so you see,
we are here.
We were able to use the fluoroscopy as the landmark and engage into the efferent limb as deep as we can to find, you see by EUS, I don't know if you can see by EUS, those dilated healthy loops.
So we were able to drive down with the EUS scope right where I left the nasobiliary drainage tube. It looks like we are about 15 to 20 centimeter below the biliary anastomosis, and about 10 to 15 centimeter maybe below the sclerosis segment of the afferent loop. We identified this loop looks promising, so we've decided to go with the LAMS in this part of the loop.
Which
size
of lamps are you planning to put?
So going a bit conservative here, we are going 15.
15, okay.
Yeah, Buscopan, please.
And then are you going to dilate afterwards, or you stay with it?
No, we'll just stay with it because patient right now is not cholangitic. The plan is not to do immediate ERCP. That will be challenging because you see the unhealthy part of the bowel, and it's not a completely stenosed biliary tree, so there looks like some drainage. So plan is to do this in 2 stage.
So Prableen, sorry, why not put a 20?
Yeah, we can do 20. It's just looking at the bowel loop, and I mean, yeah, I think I have enough landing space to go with 20. My scope is pretty straight, even though we are quite far down and back up. We can make 20 happen, but my gut
No, I just thought there was another.
Gut. And there's actually not going to be any difference, right? It's not that we are dealing with, we are going to do a 1 stage where 20 is better. There's not a lot of food. You can still perform ERCP through 15. So I don't see a whole lot of downside going 15.
Certainly, it's certainly easier if you're concerned about space and stuff. So.
Yeah. So we had to get a backdoor entry here, go with the needle and inject, and because nasobiliary drainage tube was unhelpful. Well, sort of unhelpful, not completely unhelpful.
I mean, it's a landmark.
Right.
We can actually see where is the stricture. See, we're on the other side
So
of the
Michel,
stricture.
so Shahal, are you planning to put the needle and then inject more? Or you're going directly
I mean, we
straight?
have a pretty good angle. We could directly place the axis.
Okay, great.
I think
so
you
we
can
stay
see,
with you
Yeah.
for the placement of the axis.
You can see here, we have a very
You were
nice,
saying something.
decent EUS angle. You see how we place in the bowel in a direction so we can deploy the first flange. So, you know, very important to put it in a longitudinal way so that at least you have a lot of space to let the first flange open. So you see, we're trying now to stabilize the angle.
Well.
Did we give some Buscopan? Yes? Thank you. Scopia, please.
Are you seeing some staples there? Are those staples or what's?
It's a good question. It might be actually. I was wondering. Yes, you might.
Floro?
So you see this is an angle here.
What do you think?
I think you have a pretty good angle. I think this
Yeah.
is it. This is your angle. I will let the cautery, so, you know, we always say, let the cautery do the work. We tend to want to push a lot. Actually, you shouldn't. You should very gently first put your feet on the pedal and let the cautery do the job. And you want to see the bubbles. You want to see those bubbles, bolla, and then do not lock the first flange. Do not lock it, and it deploy it. So that it actually, it definitely advances while it's deployed into the bowel. Here it is. Now you can bring the bowel back to the transducer, so that you basically have apposition. You deploy the second flange with the device locked into the working channel, and then you open, and you see now we have an entero-enteric anastomosis. Fluoro, please. And you can see a lot of enteric content gushing into. So I think at this stage we can actually see bowel. We could dilate. Yeah. We could dilate to reinforce the apposition.
So fantastic procedure, Shahal.
Yeah, thank you.
Are you taking care for the patient now? We go back to the room number 6.
That was very tough.
Very nice.
That was very tough.
Francesco, we are with you.
Okay. So what Professor Di Matteo is doing is he's made the needle knife hole in the jejunum, which is grasped, and now he's passing the second lamps, as you can see on the X-ray, and the endoscopy view over the guide wire. Fluoro. So now we use fluoroscopy as our vision. The distal flange has been deployed, as you can see on the X-ray. Good, very good. So we are in a safe zone. Now we'll pull back and bring the bowel as close. Pull the assembly back, I think. Maybe that would help. Yes. More. Pull back more. I think assembly has to be pulled back. Yes. Till we see the black mark sometime. It will almost overlap the distal flange. The two flanges should almost touch each other. Very carefully he is pulling back. Yeah, here comes the black mark.
Allora, vedi poco indietro con lo strumento, poco indietro. Vedere? Poco ancora indietro.
And now deploy the proximal flange while pulling back the scope.
Okay, stop.
Yeah. I think it should be okay now to deploy. Unlike the conventional hair is deploying under the vision. Yes, yes. Yes. millimeter by millimeter is pulling it back, and that's the crucial part. I think let it go. Yes.
It's really good, Matteo.
Yeah.
Grazie, Michelle.
It's really fantastic.
I hope so.
Yes.
That's why probably it's better to use an esophageal stent because you are more friendly user than a lamps without the lock on the instrument. That's why it's used.
At some point, you need to let go of the battery for the rattle.
I think let it open and then leave it.
I think you should let it go now.
Okay, leave the biopsy forceps.
No,
Leave
no,
it
let it go.
open,
Leave it,
open,
leave it,
open,
leave it.
open.
Lasciala.
Open forceps.
Allora, vediamo. Aspetta.
Yeah, I think it's the forceps is out. It's come out. Yeah, it's okay.
Be careful with the forceps.
Yeah. It's still anchored. Yeah, but it can be disentangled if you rotate. Rotate. Well, yeah. Jiggling also helps. Yes. But that's a perfect rescue mission achieved by Professor Di Matteo. Wonderful. Now we see the bowel inside.
Francesco, Sandeep, fantastic job. Thank you for showing us how to deal with complications and to be perfectly calm during the procedure.
Yeah, it was not by intent, it just happened. I know the complications is the theme of the conference, but it happened.
You are too polite. So we need to move.
Respect the tradition of room 6.
So we need to move. Thank you very much again. We need to move to Mumbai back.
Well done.
Vinay, can you hear me?
Hi, can you hear me?
Hi. Good to see you again.
Yeah,
So,
I'm enjoying your difficult cases. Very nicely done.
Yeah, the team here is fantastic as yours.
No, they are fantastic. Very nice.
So go ahead.
The next case I am showing you is basically a patient who had chronic pancreatitis, has had for many years, underwent ESWL and endotherapy also in the past, is pain-free right now. But about a month back, he started developing vomiting. So he was investigated outside. Somebody did an endoscopy and found that there was a block at the antropyloric region. So he took a biopsy which came negative, so he decided that we will dilate. So balloon dilation was done twice in a short span of about a month with no response. And then the patient has come to us. You can see the CT scan, hugely dilated stomach. There is a narrowing at the antropyloric region. And everything looks inflammatory. We have done an EUS and taken biopsies from this area. And in the meanwhile, since he has lost almost 10 kgs of weight in the last, let's say about a month and a half, we thought we will take care of his nutrition and put an EUS GJ. So it is a probably benign condition. We are not sure. It looks benign. But anyway, he needs GJ, either endoscopic or surgical. So I have already passed a gastroscope at the stenosis, till the stenosis. If you look at the fluoro picture, you will see that the wire is deep inside. I'm now passing 7 French nasobiliary drain deep into the DJ flexure. and then we will instill water and methylene blue and see what we can do. So lots of EUS GJs, you have seen some really complex ones, some nice ones. So it is a difficult procedure. We have to understand that there is a 10% complication rate, as Sandeep just mentioned. And so our job is to be very careful and not take it as any other endoscopic procedure. And if you don't like it, if you feel things are not nice, abandon it. There is no harm in abandoning if you find that, because there is always a surgical duodenostomy available, surgical GJ, I'm sorry. So this is the NJ tube. Kidhar hai bhai? Oh, yeah. So you can see the NJ tube passing into the DJ flexion. Now, udhar dikhao. नहीं, udhar. दूसरे तरफ दिखाओ. किधर है? Where is the end of the DJ tube? नहीं है? किधर है? Okay. So as you see, the NJ tube is going just beyond the DJ flexion now. We will keep it here and withdraw our gastroscope. Okay, slowly withdraw the scope. Yesterday, when we did the EUS, we removed almost 2 liters of fluid from his stomach. There are still some minute solid stuff inside, but we have cleaned it with stomach washes. So this is an easy part. Passing a guide wire into the jejunum is not very difficult. Now we shift to the EUS. So gastroscope is removed and the EUS scope is put in place. And then we will see which loop is ideal. I like to use a lot of fluoro. I know there are issues regarding fluoro, but I think fluoro guides us along with EUS, so there is no harm in using a bit of fluoro if your procedure becomes safe enough. So we started these procedures with Takao's, the tube, and we published also the double balloon. It's a beautiful thing, but over a period of time, as we gained confidence, we have started doing it freehand. We feel that it saves time, and we found that we found that sometimes it could be problematic with the tube, because if the stenosis is very tight, then the tube doesn't go so well. Another friend of ours, Chen, has just developed a wonderful tube for this. And that is through the scope tube. It's a very nice tube, and I hope that helps us further. So this procedure is under evolution. So where do you stop? This is a very dilated stomach. See here? Hugely dilated stomach. So we need to find a good loop, and that is where fluoro also helps. Now we are going to put water with contrast, little bit of contrast, and methylene blue with a water pump into the So I position my scope here. I like to keep my scope straight. You see on fluoro image. Chalo, dalo. as the water comes, we will see what is happening in this area. This patient, because he has chronic pancreatitis, he also has portal hypertension. We have to be very careful because you see the vessels on EOS, otherwise we'll create a major bleed here. To be careful where to puncture and check that there are no vessels either in the stomach or outside the stomach. So you can see the tube here. This is the NJ tube, you can see it, see this? Thoda contrast dalo. I'm trying to see if any of the loops dilates enough. Where is the end of the thing? It's here. Thoda withdraw karenge. We'll withdraw the NJ tube a bit. This looks like a dilated jejunum actually. Withdraw more. So I'm withdrawing the NJ tube. We can turn the scope 180 degrees and puncture on the other side also. We'll see which is a good site. Or withdraw. We have got a good thing. See this? This looks like a nice one. Doppler. All around Doppler. All around Doppler. Okay? Looks like good. Pakadoscope. And now we will put the Axios here. Doppler बंद कर देते हैं. We have given Buscopan to suppress motility. Fluoro. I like to see that my scope is straight before I puncture because otherwise sometimes the
Professor, can you see the tube into the bowel to double check you are in the right one?
Yes, you can see those air channels. See, that is the tube. You can see that? That is the tube.
Yeah, we can see that.
Yeah. So in fact, when I puncture, I think I will go probably very close to the tube. So one final checking of the position. Aisa pakdo. Then we take out this is a critical step and we should take lot of time here and without worrying much about the time. So I'm taking out my, not coming out. Now it has come out. So this is a, step which is literally blind and you don't know where this thing is going to go. So you should use everything in your power to see that you don't push it here or there. So what you do is keep the puncture site in view here and then it looks okay. There are no vessels. Close, keep it close. And we start slow burning. Looks like we are in, but we are not sure. So this is a problem, see? If you don't know where you have gone, it becomes a problem. And what helps you is to look at the tube, number one. See, this is now you see it, we are nicely in, pakdo. We'll push it all the way down. Yeah? And then we deploy the distal flange and see what's happening. So it is vital to see that you have placed the stent in the jejunum or distal duodenum. So I'm slowly withdrawing and seeing what's happening. Okay, now you are seeing both the limbs of the tube here, so it looks safe here. Now we lock this and we withdraw a little so that we oppose the gastric wall to the jejunal wall. This looks good enough. The best way is to see if the metal tube in the center, which carries the wire, it touches the opposite flange. Then we lock it and deploy it within the stent. And now it is finally deployed. We switch to endoscopy view, turn at 3 o'clock and see what is happening. So for this, you have to be careful because scope should not be withdrawn too much. Put little bit of air. I'm not seeing the stent as yet, so I withdraw a centimeter. Okay, we are seeing the blue water. That is a good sign. Push, 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 push. And little you can do this and you are through. So the blue water reduces your blood pressure and pulse rate.
Professor, do you think it's useful, also considering the experience of a previous case we had here live with Professor Di Matteo and Professor Laktaglia, to double check by, now it's quite evident that procedures is successful, but do you like to inject contrast both through the scope and through the
I do that.
to the
very useful step.
catheter?
So how I confirm this is I spend some time here. So I suck. See this? I'm sucking a lot of water to suck, but normally you will see jejunum. If enough water is sucked, you will see jejunal mucosa. That is one. And second is, yes, you can pass a catheter beyond and confirm that you are in the right position. The best thing is the blue water. If you are getting blue water, means you cannot be wrong. Now you see, you will start seeing the jejunal mucosa through this hole.
We have a question from the floor. They're asking if you had considered eventually to send the patient directly to surgery, considering that he's a young patient and in the suspect of malignancy.
Very good question. Very, very good question. And we have been debating this for the last 3 days that the patient is with us regarding the surgery, because even if it is benign, I think our hope is that inflammation in the head will subside and maybe the natural path will go through. But if it is malignant, then surgery is definitely needed. So it's a question very, very valid. We discussed it with the patient, both the options, and he said, go ahead with endoscopy first. If needed, I can always go for surgery later. So these are questions for which there is no ideal answer.
Can you hear me, Vinay?
Yeah, hi.
Vinay
Yeah.
and Paolo. So,
Yeah, hi, Paolo.
Thank you very much for these 2 fantastic cases that you have presented from Mumbai.
Can you see the fluoro? Paolo, just last image.
Yes.
You saw the fluoro?
Yeah, we see everything.
Fluoro image you are seeing?
Yeah.
Yeah, so we are in the duodenum.
Yeah.
Sorry, jejunum.
We were,
Thank you very much,
we were
Paolo.
absolutely sure since the beginning that you were there. So thank you very much. Thank you very much.
Thank you.
And hopefully see you for the next US in 2025.
Thank you.
Thank you.
I would
Thank
love
you.
to. I would
Thank
love
you.
to.
Bye.
Okay. Bye-bye.
We are
Bye.
going to present the next case in room number 5.
So the next case in room 5 is a 42-year-old female. So the patient was admitted in April 2023 for new onset of aspecific abdominal pain. She underwent an abdominal MRI showing dilation of the main pancreatic duct at the neck, 5 millimeters, probably due to the presence of an hypervascular lesion of 10 millimeters in the size. The tumor markers were normal. Today's procedures, US guide and fine needle aspiration with rapid on-site evaluation. The operators, Professor Saftoiu and Professor Seijan.
Adrian, good morning. Andrade, good morning. Welcome back.
Good morning, and thank you very much one more time for the invitation. So I'm here with Andrade, and Matteo is near us as well, and we have a very nice team of nurses and anesthesiologists and also technicians helping us. So what we are using today is an Olympus, the X1 processor for endoscopy, and the small EU M3 processor for ultrasound. And we will try to show it because basically this is, let's say, more or less the same machine as the Arieta 850 inside. So it's only a matter of settings. So we can start with the, we started the examination, we placed the endoscope. Now we are in the duodenal bulb or somewhere at the junction between D1 and D2. And we set up the machine on far. So now it's, the resolution is pretty low. The penetration is up to 8 centimeters. And you already see that the pancreas head is quite inhomogeneous. But what we are always telling to the young doctor is to know their system very well, because those are high-resolution systems, high-end systems, and you can change a lot of settings. So the first one is to maybe go like this on the pancreas, and you increase a bit the depth, so you change the depth of the image. And then when you start like this, you see that the image is very grainy right now. And then you can use tissue harmonic imaging, and then you reduce a bit, you increase the resolution a bit, and you reduce the echoes, the artifacts in the, for example, in the gallbladder or in the portal vein. And then you can also move to tissue harmonic imaging on resolution mode, and then you see a bit better. And what you can always do is to take advantage of the resolution of the system. So try to increase a bit the image until you see the image on the whole screen. And now you can look a bit and you start looking at the landmarks. So let me see, this is the flow. So you see that there is a collateral circulation around the pancreatic head. And then Andrada is helping me, and you see where you see a vessel there, and you see where the confluence and the portal vein are. And then you can also see, okay. So now we have switched to power Doppler mode. It's a bidirectional power Doppler, so it's exactly like the Arieta. So quite a nice image, but I'll get rid of the Doppler. So I'll come back to the grayscale image, and we'll try to show you if we have a pointer. Okay, thank you very much. I'll try to show you a bit. That's the bile duct here, and that's the pancreatic duct here. So we are, and I'm trying, as Anand explained, you only need one hand, so you need your left hand and very slow movements. You can move with your hand like this, or you can move slowly with your body. So you can also use your body in order to do very slow movements. So you don't have to be, you don't have to rush. You need slow movements. And now you see that the pancreatic duct is dilated here. We know that already. And if I turn a bit like this, if I turn my body, you see that it ends here, it disappears. So that's probably the site of obstruction. So you can always follow the pancreatic duct. So Andrada is showing that. So the pancreatic duct is dilated here. If I turn a bit clockwise, you see that it goes like this and it disappears. So most probably this is where the mass is. And initially we thought it's a bit smaller, but actually it's quite large, so we can freeze a bit and then I'll try to measure it here. So it probably starts here somewhere, a set, and then it goes like this. So it's we don't have a clear interface with the portal vein and the confluence. So that's one of the problems because it's a young patient. Then the other thing is that the common bile duct is also a bit compressed. The patient is not yet jaundiced, but you see the, where it is, the pointer. So you see here a bit of the common bile duct, and you see it's a bit, if I turn slowly towards the mass, you see it's a bit compressed here as well. Then what we can do further, so we need to characterize the mass. So it's hypoechoic. It's a bit larger, as described by CT. We did power Doppler. You saw there's a bit of collateral circulation. We can also do elastography. And now maybe you can see better that it's a hard mass. And you can appreciate better maybe the margins of the lesion. Like this. So you see the wall, the GI tract wall, and then the surrounding fat probably. There's a bit of surrounding fat here, and you can also see that the mass is actually a bit bigger on elastography. That can happen with pancreatic tumors because they are a bit diffuse, and you get a lot of fibrosis and infiltration of the pancreatic parenchyma. And you see Andrada is showing nicely the mass, and it's actually really close to the portal vein, and yeah, we'll do a strain ratio as published by Julio in a lot of articles, and you can move it in the middle of the tumor. So you can do a strain ratio, so we'll pick the first region of interest and then another region of interest towards the GI tract wall, and you see the value is 15, so the report of the two regions. So you can do it qualitatively just by looking at the mass, you can do it quantitatively. So one important thing also to mention is we will try to do a contrast examination, so try to keep the mass also. So you see that when we change to the contrast, I think it's okay, maybe a bit like this. So when we change to the contrast, you have to keep in mind that the grayscale image will become a bit worse because the mechanical index for the grayscale image, it's really low. We don't want to destroy any bubbles. And you just need, just please tell us when you, yes, please go. So we inject the Sonoview, and I'll try to keep it still. You see a bit of the vein below, and we'll wait for the contrast. And you see that the mass is hyper-enhanced in some parts, but there is a part, so on the bottom part here, it's hypo-enhanced. And what you also see is that it has, yeah, now you nicely see the, actually both the, I think it's the SMA and the SMV, so you see that the SMA is pulsating a bit. So whenever you do the staging, then contrast might help you. Now you nicely see the SMV is here and the SMA is here. It's a bit pulsating during the contrast. And what you also see is that the mass actually has washout. So it has, I don't think everything is hypervascular, so probably the lower part here that Andrada is showing, that's a hypovascular part. But we already know that whenever you do the differential diagnosis, of course, neuroendocrine tumors are usually hypervascular with necrotic areas. Adenocarcinoma can be hypervascular in 10% of the cases, so it's usually hypovascular, but it can be hypervascular in 10% of the cases, especially in advanced lesions. and they both wash out. I don't know if we have, yeah, if you have the, yeah, and if you have accumulation on this one, or no? Okay. 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 It's okay. Okay. Together. Now we can go back. Thank you. So now we got back to the grayscale image.
And you
so,
want to go there?
Yeah, I think we will probably target the lower part. So, but anyway, we'll try. I think we will try with the endoscope is in a bit of a long position, so it's a bit torqued, but we're seeing the tumor better from the first part. We have tried from the second part, and it doesn't work like this. Whenever you are in the first part of the duodenum, the endoscope is a bit torqued. So then the final aspiration biopsy can be a bit more difficult. So I think we will use a 25 gauge needle. We saw a bit of collateral circulation, so we have, if we have a 25 gauge needle. Okay, so we have it's a Microtech needle, so it's the same principle as the other needles on the market. The difference is that you don't have knobs, you have only 2 buttons, but it's the same principle. So I'll try to first fix it. You see, whenever the endoscope is torqued, you have to be very slow in the terminal part. We don't want to damage the channel, so I'll try to get it out. You have to get it out from the elevator, so we fix it here, and then we try to get it out. From now it's over the elevator. Now you see it on screen. You see 2. Okay. I think it's fine. If you could hold the scope, it's very nice to have an experienced assistant with you, because they already know to hold the scope, because you have to push a bit. The endoscope is in a slightly long position, and when you take your hand from the scope, and you need to have your right hand on the needle, and then the scope moves back towards the stomach. So then you need an assistant to keep the scope steady. Sometimes it also tries to rotate, and the force, of course, you can rotate with the whole body or with your left hand, but sometimes somebody needs to keep the scope fixed. So now it's, I think we are out. You don't have to take it out too much, so it's only just a little bit out from the biopsy channel, and then you unlock the upper button. You retract a bit the stylet, because this is an FNB histological needle. And then what I usually do is we'll try to push it a bit just to keep it maybe here. And then what I usually do is you have to punch the mass and then keep it in the middle of the image. So now I think I'm inside. The 25 gauge needle you can see it very nicely now. But what you have to do is you have to see where your needle tip is. Sometimes you are like this, turned, and you don't see. And then you have to turn a bit with your body. And if you are like this, you don't see the needle tip. So you have to turn a bit. It's only slight movements. If you can see, you can rotate with your whole body, and that's the way you see your needle tip on screen.
Torching technique,
yeah,
which has been recently described.
Yeah. And then we will retract slowly the stylet, and we can do it's really hard actually, so it's a hard mass. And remember to keep your the needle tip in view. I'll try to go a bit deeper towards the hypovascular part, but please remember that you have the SMV and the SMA, the superior mesenteric vein and artery, on the bottom of the image. So you have to be careful with that, because it's a histological needle. Then if you release a bit, you can play with the up-down wheel, and you see that changes a bit the angle. So we'll do a bit of fanning right now. You can withdraw the stylet. It's a long discussion. If you want to put the suction on in pancreatic masses, we usually do the first pass after withdrawing the whole stylet. You can take it and place the syringe. So we withdraw the stylet, and then we also play the suction. So we prefer to do that for pancreatic masses still. Now we can release. So we have now the syringe, and if you see any blood in the syringe, then you can do the second pass without.
Yes, but perhaps here you are assured because you are in the hypo-enhanced region. So
Yeah.
I think it's even if you put the suction, you will get more material.
Okay.
So it's the best choice, I think.
It's okay. It's a very nice needle, as you can see. It's a bit. I think it's. If I'm correct, it's laser blasted because you see some slight horizontal areas on the needle. So that's for the visibility of the needle. So although it's a 25 gauge, it's very nicely visible in the image.
Professor, we have a question from the floor. Can we consider to send the patient directly to surgery without performing any biopsy, considering that on the EUS images they favor for adenocarcinoma?
Yeah, it's an interesting question. So there are several things to consider here. So first of all, the mass is it's really close to the SMV and SMA. So actually, I think I would say it's borderline resectable, this one. So probably, it's probably 180 degrees on the SMV. So if the surgeons are aggressive, they'll probably resect the SMV together with the tumor. But anyway, we still prefer biopsy before of the surgery. So you see, it's a long portion of the tumor that comes into contact with the superior mesenteric vein. So what I think it should be done here. So first we should do the biopsy because both the patient wants a confirmation and also surgeon wants a confirmation. Probably in 10 years from now, I'm not sure if we will need a biopsy. So once the imaging techniques become very advanced, we might have a diagnosis, and in some centers, resectable tumors are sent directly to surgery. But at least in this moment, I still think we need a final aspiration biopsy.
And this is a peculiar aspect because it's hyper-enhanced, so we cannot
Exactly,
trust exactly which type it is. So if we need neoadjuvant therapy, we should know before exactly what it is over there.
And I also think it could be useful for an eventual neoadjuvant therapy to have a specimen.
Yeah, exactly, and probably the current regimens will probably change, so we might end up sending even resectable patients to neoadjuvant therapy. So there are protocols like this, so you just send them for neoadjuvant therapy, you just repeat the CT and the imaging after 2 months or after several cycles of chemotherapy, and usually if the tumor reduces in size, if it's an adenocarcinoma, if it reduces in size, then there are greater chances of an R0 resection. So I think the management of these tumors will change, especially for adenocarcinoma. So here we're not sure for the moment if it's an adenocarcinoma because it has a hypoechoic part, which is also hypovascular, and it's hard on elastography. But there are also hyper-enhanced areas in the tumor, which might lead us to think that it's either an adenocarcinoma, which is quite aggressive because it's hyper-enhanced in some regions, or it might be a neuroendocrine tumor. Or it might be a mixed tumor, a combination of adenocarcinoma and neuroendocrine tumor. So we'll have to wait a bit on the pathology.
Adrian?
Yes?
I Andrade, just to continue the discussion about the borderline resectable upfront resection and so on, I can tell you what is done here at the Pancreas Center in San Raffaele. In all these cases, if there is a confirmation of adenocarcinoma, we are not going to resect the patient anymore as upfront surgery. We do neoadjuvant treatment. This specimen will go for genetic testing to see whether there are, because the lady is very young, so probably she has some mutation, and that can also guide us in the neoadjuvant treatment in the future. So I think that I do not know if our pathologists are ready with the results of your biopsies, but we can go in the pathology room just to ask them something about the quality and the adequacy of the specimen. Okay.
You want another pass or no? We cannot.
Yeah. So
can I ask you for a small cloth? Just I want to clean the scope.
So by now, thank you very much for this excellent procedure and discussion.
Thank you.
And we move to the pathology room to see the results of your Okay. Here we are.
Okay, so
okay,
here we
Federica.
are. Hello to everyone. Professor Arcidiacono, thank you. So now we have most of these specimens we have dedicated to Vivascope, but we have also something for the cytology smear for normal treatment, let's say, adequacy. So we will see what happens on the Vivascope now. So in the meantime, we can see what is there on the video. Okay. So the aggregates are diagnostic for adenocarcinoma. There are no pictures of neuroendocrine until now. Now we will see what is there on the Vivascope. Okay, now the VUL slide the VUL scan will be available to investigation. Okay. Okay, magari. Okay. So these are normal structures, still well organized, without atypias. On the other side, we have this single cell with this large nucleus and also this very hyperchromatic nuclei with poorly cohesive cell, which are for sure suspicious for angioplastic proliferation. So if we compare the two, I can say it's adequate for diagnosis. And we have no pictures of neuroendocrine tumors now.
So thank you. Thank you very much. Thank you very much. So
Thank you.
Peter, just one last question. With the specimen that you have obtained in the first pass, do you think would be possible to perform also some genetic testing, DNA and so on?
So I think we should ask for another one because the number of cells should be around 1,000 for DNA and 1,000 for RNA. So we should go for another try. We had some material also for formalin fixation, but I would advise another one. Since she's young, I think it's better to have another one, and the lesion is small.
So this is another important issue to present and to show, because sometimes you have an adequate specimen, but then you don't have enough material to perform other testing. And with the Vivascope, then you can use the same material also for genetic testing.
For sure.
Is that? Okay.
Yes, for sure.
Oh, great. So we we now, thank you very much.
Thank you.
We now move to the room number 7 to present the next case in room number 7. Thank you very much.
Thank you.
Okay, so the next case in room 7 is a 69-year-old female. Her medical history, she had an invasive ductal breast carcinoma at 4th stage, in good disease control under 3rd line of chemotherapy with capecitabine plus trastuzumab. She had one metastatic lesion in the onset process of the pancreas that underwent the first session of RFA in December 2022 with complete response. During the follow-up, she underwent an abdominal CT and a US in January of this year with a new evidence of a bilobated recurrent lesion in the pancreatic cancer process. In a multidisciplinary evaluation, we decided to do a new session of a radiofrequency ablation for controlled disease purposes under chemotherapy and possible consolidation with local radiotherapy. Here we can see the lesion at the US. Today's procedures: US guided radiofrequency ablation. The operators, Professor Palazzo and Professor Iglesias Garcia.
So, here we are. Can we go to room number 7? Okay, here you are. Laurent, Julio?
Yes.
Yeah.
You hear us? Okay.
You have your own microphone. Don't share both.
Yeah.
Yeah. Hello, welcome back. Live.
Yeah. So
which instrument are you using, Laurent, and what's your goal now?
So we have the Pentaxscope EG38 and UT G10 UT, and we have the Aluka Arieta Hitachi 850. And we have the processor of radiofrequency ablation, and I use 50 watts. So we are into the duodenum. The goal is to see what is possible to do.
So this is the first important information. You use 50 watts?
Yes.
Okay, great.
I use 50 watts. The lesion was bilobulated in 2022, and the recurrence is bilobulated, as you see on the screen on this freeze image. You have two lesions. One is 7 millimeter, and the other is 13 millimeter by 10 millimeter. You see them?
Yeah.
Okay. We are part is into the Ensenet process, but a part is also into the anterior part of the head, since we have both ecostructure, ecogenicity of the cephalic region, and as you know, the Ensenet process is always dark. If there is two ecostructures, the two different ecostructures are visible only in 80% of the population, but when it's visible, what is bright is the head, and what is dark is the posterior part of the head, and the Ensenet process, which is lower. So here, as you see, a part of the lesion is into the anterior part of the head. Okay?
Logan, one question. Do you, before doing the RFA, to try to assess afterwards the response, do you think contrast enhancement, vascular evaluation, do you think it's has any usefulness to evaluate just a way to measure the accuracy or the effectiveness of the ablation?
Yes. I never do RFA without image which show the vascularization. Usually I use before and after. Here we will do the same. Why? Because if the lesion is non-hypervascular, by definition, the result, we cannot judge the results.
Okay.
So unfortunately for us, usually the metastases are often iso or hypervascularized, so it helps us. So now I will do the DFI on the lesion. Okay. And there is not a lot of vascularization.
not really.
Okay, so it's a first information. Okay, and now, yes, you see, we see the two lesions, but they are hypo-enhanced, not enhanced, but hypo-visible on the FI. Okay, the small one and the big one. Yeah.
So, but maybe we need to go for contrast.
So now you are preparing contrast, and so I like, if it's possible, black and white, but we will say in sepia, it's not a problem. But I want to see something. So I will increase, if it's possible, slightly the mechanical index, because if, push more, because it's clearly hypovascular. Okay, it's okay. We will use 0.25 to try to see something, okay?
Okay.
And when you inject...
Are we ready? Do you want the injection?
Yes, I want the injection.
Yes. Just a stupid question, Laurent. Why do you prefer black and white instead of sepia? Is just because you're used to it, or because?
It's because when the AUS contrast has been used, it has been proposed by Masa Kitano in Japan, and it was. So you see, there is a takeoff of contrast. You see, there is one. Okay, so it's good. So perhaps we will have a lose of contrast after the efficacy of RFA, so we can compare. So Masa Kitano start with black and white, and he show us black and white. And me, I'm working on black and white. In fact, this sepia system is done by radiologists. The radiologists, they explain to us that in sepia, you have more possibility of difference.
Okay.
However, we are working in black and white.
Yes, for life.
In the US, and for me, it's more black and white. It's black and white. Okay, it's more easy for us on those sonographer. And the second reason is that the transducer on AUS are small, and it's not like the contrast ultrasound for the liver, because the transducer are very hard, big. You have a lot of crystals, and finally, it's not the same image. Okay. So perhaps sepia is good for the liver. But I don't think it's good for the pancreas.
Okay.
Okay. So we are finished. So now I will try to find which is the best way. So what I want to see if there's something which is not good. So the 10 millimeter.
10 millimeter.
Professor, how would you define the behavior following contrast enhancement of the lesion? How would you describe the behavior of the lesion following contrast enhancement? Is that hypo, iso, hyper?
Here it was slightly hypo, but more iso.
Yeah.
On that, but I use black and white. It was sepia, so I try always to work in black and white. But here it was, we have to change, so we have no time for that. So I use sepia, but okay, I'm not a specialist of sepia.
I use sepia. I'm a specialist in sepia, and I agree with Laurent that it's a little bit of isobascular, close to hypovascular. So I think that my impression is exactly the same that Laurent with sepia, that I usually use sepia in Santiago.
Okay. So here we are in long position, as explained to you, Pietro, yesterday. Long position in the duodenum is more stable. You have not to torque the scope with your right hand, and it's better if it's possible. However, in some case, it's not possible to use the long position, and you have to use the short position. When you have to use the short position, it's slightly more difficult. Not always, but and you have to inflate the balloon. Because when you inflate your balloon, you are more stable.
Yeah.
So I know that a part of the endosonographers in the world are not using balloon, and I don't know what is the interest to not using balloon.
Price. The price, Laurent.
Yes, but the price, I do not agree at all, since we have the same problem in France.
Yeah.
And since 30 years, we stopped using Olympus, Fujinon, balloon, and so on. We use the balloon which are created by a company which was primarily Netherlands, and they are very cheap. So nobody asked for the balloon of the companies, Pentax, Fujinon, Olympus.
But I think in the beginning, when we, at least when I started, we used to buy it from the companies, and it was quite expensive. So we decided the image was quite nice without the balloon. But it's true that it's two positions in which I think the balloon is extremely helpful. Sometimes in your beginning in the intubation, you inflate a little bit and the intubation is easier, softer through the throat. And to stabilize in D2, it's true that sometimes it's easier to stabilize the scope.
And the last thing, and the main thing, because it's responsible in a survey we have done from 25% of lack of sensitivity in pancreatic tumor less than 2 centimeters, 30%, is the neck.
Okay.
And to have the neck, through the stomach, you are more than 50 centimeters from the incisors, so you are tangential, and if the mass is big, it's okay. If the mass is small, you have to do a jab, and the jab is dangerous, so you don't do that, and finally, it's negative. There is a way to have all the lesion to obtain the results 100% in the lesion of the neck, even 5 millimeter. It's inflating the balloon into the bulb, really inflating, and you pull back and you tract your pylorus until less than 50. And when you are less than 50, you have strength.
Laurent?
Yes?
Laurent, sorry to interrupt your nice discussion about the balloon, but
I'm waiting for the needle.
Oh, great. Great.
I'm sorry of that. So I talk because I have not a needle.
Oh, great. So, but I hope that the needle is coming very close. Great. Thank you.
But okay. So the needle is coming. So I finished, since I have time, on the biopsy of the neck. The biopsy of the neck are responsible of a lack of important percentage of false negative accuracy of AUS-guided biopsy of solid pancreatic masses. And the reason is because the people does not know that to obtain the neck, you have to inflate the balloon into your duodenum.
Dobbiamo zoomare la telecamera ambientale.
Okay, so we arrive with the needle. As you know, so we use the 10 millimeter needle. You see here you have the PD. You see here? You see the PD? I show you. This?
No,
this. Okay. You see the PD?
Yeah.
Okay. So we have no problem with the PD. You see? Okay. So it's not an issue, and it's the best thing, because the PD is the main issue in this kind of procedure. So okay.
Yeah. You're setting up the machine at the moment?
Yeah.
Yeah. So 50 watts, do you comment on this choice? Because in many cases, 30 is the preferred choice. Where are you doing?
Yes, 30 is more active. Theoretically, you have more surface. But here we have a small one, which is 7 millimeter, and I prefer for this one to use less effective in terms of volume setting. And in France, we work with 50 since the beginning. And I'm happy about the complication, my complication rate. I'm very happy. And I don't know if it's because I work in 50 and not in 30 or not. I don't know. I'm waiting for studies. But I'm more confident in 50. Because I'm an old endosonographer, and everything I want first is avoid complication. So I will try to move in part of the big lesion, because the goal is to have the big lesion, and I think that perhaps I will need to do 2 shots. So I will try in one, and after that I will do in another. So you see, I'm working on the left, okay? So I see I'm not good at all. So I turn more clockwise, and I do the same. The goal is to be I'm not where I want. See, I'm too peripheral, so okay. So I'm not where I want. Here, if I burn here, I will have only a small part. So I will change.
So you try to access the central part of the lesion?
Yeah. I go to the same area. So, does I accept or not? So you see the tip?
Yes, we see it.
Yeah, so here we know that we need several shots because this position is not good, not the best. I will have only a part. I remove slightly to avoid to be against the tip of the lesion, because you know that the RFA will move on 2-3 millimeters after the tip. And now, so when I say stop, you stop, okay? So this is the first shot. Go. Stop. Okay. Only a small part. Now I understand that I have to puncture differently. It's better, you see?
Yeah. Yeah.
Julio,
Yeah.
what do you think of this?
Well, I think we are
Here, yes,
here.
we're here. And you think that yes, I think that the lesion stop here,
Yes.
stop here,
I think this is the area of the lesion.
yeah. Or do you think I must go there?
Yes, I think it should be. We can move a little bit more to this part of the lesion because it's maybe too much in the periphery, as you say. Okay, it's better now.
Yeah.
Yeah. No, I think it's better. I think we are more.
Yeah.
With a more security
Yeah.
part.
So we do a second shot.
That's it.
Stop.
That is.
Okay.
Laurent?
Yes.
Julio?
Yes.
Thank you for the demonstration. I think that you are going to perform another shot.
Yes.
Everybody can look at this third shot on the US Express channel, and we are going to present the next case in room number 6.
Next case is a 69-year-old female. She had new onset of obstructive jaundice in December 2023. At abdominal MRI, a lesion at biliary confluence with dilation of right and left biliary systems. Then was placed a left external biliary drainage in another center, complicated with acute pancreatitis. Another abdominal CT and MRI were performed in February 2024 with the peripancreatic fluid collections, 24 millimeter solid lesion at biliary confluence with the upstream dilation, gallbladder with the stones and with wall inseparable from a 7 centimeter solid tissue of the hepatic parenchyma. Multiple secondary lesions were found in the right liver. There was a dislocation of the external biliary drainage. Blood exams showed increased cholestasis and inflammation levels. This is the CT scan and the MRI. Today's procedures is use guide, FNA with rapid on-site evaluation, and ERCP with SAMS placement. Operators are Professor Lactakia and Dr. Larigno Noia.
Hello, Sandeep. Hello, Jose.
Hi, Jose.
Welcome back.
Thank you.
Welcome back. Thank you for being with
so,
us.
So we are in room 6, the most blessed room, and we have the right team ready. Livia is with us along with Jose. And as you heard the history, the patient has hilar stricture, hilar biliary stricture, which is causing obstructive jaundice. She had a percutaneous catheter on the left side, which got dislodged. She also has got ascites. So we have two problems at hand. One is to confirm the diagnosis. So we'll try to get some tissue. And the second is to drain the biliary system by placing bilateral or one-side stent. We'll decide as we see the cholangiogram. So I'm using a Fuji scope, Fuji EG74OUT.
And an Arieta 850 ultrasound device.
Yeah, that's right. That's even more important. And it's a beautiful image, as I can see it here. And my scope tip is in the duodenum in a long position. And I'm trying to evaluate the tumor.
We have to recognize that it's an intrahepatic mass, so it's not so easy to locate or make a good location of the lesion that seems to be placed intrahepatic. And even the suspicion is perhaps a gallbladder cancer, according to the previous test, but the gallbladder is not well seen.
Sandeep?
Yes?
We move for 1 minute to
Yes,
the room
please.
number 7.
Take your time.
Thank you.
See the contrast after the third.
So, Laurent?
Yes, you see the contrast after the third shot.
So also sepia is visible as black.
Black.
Yeah.
And you see, I think it's
Yes, it's very
good results.
Yeah.
Yeah.
No uptake. Just evaluate the response at the
Yeah.
same time.
You see?
Great procedure. Great
Yeah.
procedure.
Okay.
Thank you very much.
Okay.
Thank you very much.
Thank you.
Congratulations. And now we go back to room number 6.
To maintain the position. But this is a lymph node.
Mi mettete?
That's a CBD, very thin
Yes.
CBD. So not much
Yes,
space
in the
there.
distal part is very thin. Yeah.
Yeah, so it will not take two stents.
Yes, and even more is not a previous ERCP. I thought that it was should
That's a
perform.
bile duct which is
Jose?
quite thick.
Yes.
Okay, we are back with you.
Ah.
Okay, thank you.
Okay. So we are trying to identify the lesion that is intrahepatic, as I told you before. We are now in the ampulla area.
Bile duct is thick in
The bile duct is very thin, so it's going to be a difficult ERCP probably for the placement of stents. But we are with Sandeep, so I'm completely.
I'll spend some time here.
I'm very quiet.
And this.
So now we have the ampulla, the ventral pancreas with dorsal pancreas, and now we have to follow towards the epithelium, trying to identify the lesion, but you can see here.
So this area is abnormal here. This is the bile duct wall thickening, which Jose is pointing out. If I can make it a little bigger.
Yes.
So if we need tissue, we can target. This is one target we have. Let's put some Doppler there and see. But that's a very scanty material will come there. So I'll just look around for a node or any other mass lesion. It's going the bile duct inside the liver. You see it's gone up. Yeah. Or it's something else. No, that's a bowel which has come here. Then let's come back and see other areas. I'll turn around and see the liver. The ascites is very obvious.
We have ascites. We don't know if it's related to the gallbladder cancer or is it related to an acute post-PTBD pancreatitis that suffered the patient.
This is little abnormal looking area.
This area from here is completely.
Over here also looks
Also,
little.
yeah. So we have two areas with a suspicion of being not
Yeah, this
completely
looks
normal. One area from here.
I've actually slipped out into the stomach. I'll spend some time to look for the area of the interest. What's that?
That's one.
This
That one.
looks abnormal, yes.
Okay.
Let's target this one. Yeah.
Yeah. This is going
Yeah,
to be
yeah,
the
yeah.
lesion that we're going to target, perhaps.
Yeah, I think so. You're right. Let's get a needle.
Needle, please.
Yeah. 25 is okay.
I have it if you want. We are going to use a 25 gauge needle top gain from Mediglobe.
So this area looks abnormal. You agree?
And you give me some
Paulo?
glasses, please.
Or who's in the hall?
Okay.
I'm sorry?
It looks abnormal.
Yes.
Definitely.
So we'll target this for the tissue and then wait for the result and then plan a metal stent subsequently and by ERCP.
So, Professor, are you looking at the hilum of the liver from the stomach?
That's right, from the stomach, yes. Ready? Thank you.
Okay, the reason for using a 25 gauge needle is because the puncture, we are anticipating that it's not so easy to do this kind of puncture because we are very angulated and we are in a intrahepatic portion of the CBD, so it's not so easy to make this kind of puncture with a lot of structure surrounding the lesion, with ascites, with vessels, and with also difficulties to identify the limits of the lesion. You want me to do
okay.
something, tell me.
Thank you. I think now this is a target here. This is a target. Let's look for a blood vessel on the way, which we can avoid. That looks okay. My sheet is.
Oh, no. You can see the hyperechogenic part of the sheath of the needle.
I think we can switch off the Doppler. Okay. I have a vessel there, but that I can avoid.
Okay, we will.
I think I am inside.
Yes.
But I've not seen the needle.
No, me either. But we are very sure that
it's
we are
quite deep
inside.
in it. It's a little deeper in. I think I'm in, but let me see the needle. There's a different scope that I'm not used to.
Never mind, because I believe that
something is moving. I'll put it back.
Sandeep, Jose?
Yes, please.
Which needle are you using?
Microtech. Microtech.
It's from Mediglow. It's a 25 gauge needle. It's a top gain needle from Mediglow.
Mediglow.
Okay, great. Thank you.
As we anticipate, it is not an easy puncture.
It's a room 6 effect also. Now I see it, okay. Is it in? That grit is there. No. Why I'm not having that easy feeling? Inflate the balloon. Let me inflate the balloon a little bit.
Are you in the stomach or are you in the lung position?
I am in the stomach.
This is the most difficult because the stomach is very difficult to target. Yeah.
Something else is happening.
I don't know which is the plan with this patient after all the drainage that we are going to perform. If he's going to receive any kind of chemotherapy, or you use chemotherapy or some kind of immunotherapy, not in this kind of tumors.
In cholangiocarcinoma, we do
no.
the.
Oh.
Okay, here is a needle. Let's get the tumor in focus.
Yeah, it's
okay. Is it bent a little bit, I think? Okay. Why is it not following my path?
Oh, no.
I think it's
in.
Yeah. Yes, okay. Slow pull.
We are using the slow pull technique for getting the sample.
It's very deep in, yeah? Okay.
Yeah, you are deep.
Can we have a different needle for the second pass?
Yeah, we can change.
So Sandeep, Jose?
Yes?
Thank you for the demonstration of this very difficult fine needle procedure.
Very difficult.
So then we moved to Beirut, but your procedure will be on the express channel. Thank you and good job.
Thank you.
So now it's my pleasure to start this new connection, and it's my pleasure to introduce Professor Assad Sowaid from the American University Hospital in Beirut, one of my closest friends. Assad, can you hear me?
Well, but I'm waiting for the video signal.
Yeah. I hear you very well.
Okay, Good. So we're going to start. First of all, it's always a pleasure to be with all of you, our EuroUS family, though this time we're doing it remotely. And basically, we're going to start. We have a couple of cases. One of my fellows, Dr. Dima Malak, is going to be presenting the first case, a young woman with mediastinal lymphadenopathy. Can you go ahead, please, Dima?
Yes, of course. So this is the case of a 41-year-old patient with a history of breast cancer diagnosed in 2020. She was in stage 1. The patient had bilateral mastectomy. Her disease was in remission, and she received tamoxifen for 3 years. The patient was referred to us for investigation of mediastinal lymphadenopathy seen on PET scan, done as a follow-up of her disease. At presentation, the patient had no symptoms. She had stable weight. To note, we have a 30-pack-year smoker. The vitals were stable, and her physical exam was normal. She had no palpable lymphadenopathy and no palpable breast mass. The serological workup was within range, except for a high ESR, and as we can see, the tumor markers were negative. The PET scan showed a new highly active adenopathy at bilateral peritracheal, bilateral lung hilar, lateral aortic, and subcarinal space, with SUV max up to 15.9. This pattern can be related to either granulomatous disease, such as sarcoidosis. However, lymphoma and metastasis cannot be ruled out. And correlation to histological finding is highly recommended. And you can see the lymphadenopathy on the images in the PET scan we're showing below.
Paulo, you heard the introduction for the case. Hello?
Yeah? Hello?
Yes, you heard the introduction. Hello?
Yeah, here we are. We are hearing you perfectly.
You heard the introduction? The
Yes,
PowerPoint?
yes, we have heard everything.
So basically, I'm joined here by one of my colleagues, Dr. Yasser Shaib, who is a therapeutic endoscopist. We're going to be doing, again, this case. So we thought this case is quite interesting because usually the mediastinum is a part that is usually not well represented in EUS meetings. This part is usually ignored. So we're going to just go. We have a big audience. We have people who are following online. They would like to know basically about the mediastinal anatomy. The role of EUS is very important in the assessment of mediastinal lymphadenopathy, be it because of non-small cell lung cancer or mediastinal lesions, etc. And it's important for the beginners to know about the stations where we examine the esophagus. So now we can put the focus on the EUS image, and I would like you to tell me kindly, Paulo, if you can see the EUS image.
Yes, perfectly.
Okay, so, so what I'm doing now, I'm now at station 7. Station 7 is basically, I do have a very good view of the left atrium. The left atrium is on the left part of the screen. I'm going to magnify a little bit so you can see the left atrium, and under it you can see the left ventricle. So in this station, which is referred to as the subcarina, we can see the left atrium, left ventricle, and on the right side you can see the aortic arch and the right pulmonary artery. If you look carefully, you will see lymph nodes. These are big-sized lymph nodes, and again, I'm going to magnify a little bit. Lymph nodes are here in the subcarinal position. So these are the lymph nodes that lit on the PET scan, and you think they are, Dr. Shaib, what do you think? Do they look malignant to you? What do you think about their size, their echogenicity?
So again, of course, the biopsy, and especially if you do a FMB, is usually the way to go. But you always like to talk about criteria of malignancy, how the lymph nodes looks on EUS. So these are big lymph nodes, for one thing. However, they look triangular. They have a kind of a triangular shape, conglomerates. So these don't look typical malignant lymph nodes. They are more likely to be inflammatory. Lymphoma could look like this sometimes. So this is, again, probably similar to the differential they included in the PET scan. I will leave it at that. But the FNB will
give us the answer.
So basically, as you heard from Dr. Shaib, we cannot tell for sure without doing the tissue biopsy. But just for the sake of the discussion, I'm going to show you now. So we're now at station 7, which is the subcarina. If we torque the scope about 180 degrees, we will be basically looking at the aorta, the descending aorta. And this is the descending aorta. Or if you see lymph nodes in this location, that would be station 8. So that would be station 8. If we push further, these are now in the inferior mediastinum. If we go even further down towards the liver, and you can see basically the vena cava, you can see Dr. Shaib, and the right atrium. At this stage here, a little bit above, you can see a lymph node, and that would be station number 9. So these are what we call the pulmonary ligament. So moving upwards, again, we can look, this is the subcarinal lesions. If we go outside a little bit, and we have to look up and torque counterclockwise, we'll be able to see the AP window, which is the nodes in the aortic area. And this location, we can see the station 6 and the station 5. And that's one of the advantages of EUS over the EBUS, for example. So again, you can see them in this station. In this case, we have the aorta to the right side of the screen in this case. And if we move even further up, we can begin to see the station 4, which are the paratracheal. About 20 centimeters or 23 centimeters for the incisors. So with EUS, we can see a lot of the stations, namely stations 2 and 4 on the left side mostly. We can see station 5, the AP window, station 7, the subcarina, even 6, which is the para-aortic. It might be difficult, but lymph nodes are accessible by EUS. And again, the lower or inferior mediastinum that are station 8 and 9. So having said that, EBUS is also important. EBUS and EUS are complementary. I don't want the audience or any of the attendees to think that they are competing. In a way, EUS has advantages in certain stations. EBUS has advantages. Together, they would produce a total mediastinoscopy, which is a complete assessment of the mediastinum. So before I proceed with the FNA, I would like to just ask the audience if they have any questions before I proceed. Can you hear me?
Yeah, we can hear you.
Good. So Elasto does have also some uses. In this case, I can see the pattern is basically mixed. You can see kind of bluish discoloration. This is qualitative, not quantitative. You can see kind of a mixture. Usually, this is not what we see with malignancy. But again, the issue now, tissue. Tissue is the issue. So we want to get a core biopsy and look at it and see if this is sarcoidosis, if this is lymphoma. So the next question is, and I will go to Dr. Shaib on this one. Dr. Shaib, would you use an FNA needle in this case or an FNB needle, and why?
Again, this is a question that we used to talk about a lot. Now I think that the decision is clear. I mean, you have to go with FNB. First, it's a lymph node, and you need as much tissue and architecture as you can. It is easily accessible, so we don't have technical challenges that will sometimes get you to use the smaller FNA needle. So when you need tissue, and especially in a lymph node, FNB solved lots of the problem that used to face us in the past. We used to get good samples, but you'll always get that question. It's not enough for definitive diagnosis or for exact immunostaining of the lymph node to decide on the exact diagnosis. So FNB, and I will like to ask Asad, how do you prepare? How do you handle the specimen now?
Well, first of all, I completely agree that in this case, tissue, we need core biopsy, not an FNA. What I'm using now is the Acquire by Boston Scientific, and of course the scope is the therapeutic Pentax, the 3.8 channel. It is the EG3870 UTK, and the needle is the Acquire 22 gauge. So basically, the design of the needle is a Francine type, which is an end procurement. It's not a side, it's an end. There are different designs, but the Francine, as you can see with the acquired, can procure quite a bit of tissue. So I'm going to use that, and what we get the tissue, we're going to send it first for a frozen section so we can show you later on, hopefully when we stain it, the diagnosis, and we will put it in formalin because this is a tissue, not an FNA.
Are you planning to perform?
Would you like to evaluate?
Yes, please.
Yes, I'm hearing.
Yeah, are you planning to perform any cytofluorometry in the suspect of a lymphoma?
This is a very good question. Yes, usually we suspect lymphoma. In this case, our suspicion is not that high. But yes, we do flow, we do biopsies and core, because if we have enough tissue, then they can do a lot of the immunostains that the diagnosis of lymphoma would really depend on. So this is basically what we're going to do. We're going to get these tests done, and then we can move along and do what we. So now the needle is inside the lymph node, and I'm going to remove the stylet. So the next question is, do we apply suction or no? I do not like to apply suction in lymph nodes because of the fact that I'll get more bloody samples and I will not get better yield. So I'm doing basically the fanning, trying to get more tissue with the slow pull technique. And of course, we control it because we don't want to end up in a vessel. So negative pull, negative or capillary technique, no negative pressure, and we got the first pass. As you can see the needle inside the lymph nodes, and I'm going to get the first pass now. So we do not implement usually rows. Basically, that's mostly for cytology, but in this case, we get a core, and we're going to send it for a quick interpretation by our pathology department. Hopefully, by the end of our session, we should be able to give you a diagnosis on this.
So, Asad, what do you tell your technician to do with the specimen? Do you take a look or do you drop them formalin?
Yes, this is, again, a very good question. What I do if I have pieces, I like to look at them, make sure I do have a core. And if I want to do a frozen section, I put it in a wet gauze, send it immediately for reading. But if I want to just find that I do have a good core, I put it in formalin, make sure it's a core, and send it for pathologic evaluation. No, this one is, you can put it one in a core, in wet gauze, send it for pathology, for frozen section, and I'll get the subsequent ones for the...
And do you look at the specimen yourself?
Yes, I like to look at the specimen myself to make sure I have tissue. Again, I agree that the lymph nodes don't look the classic lymph nodes abnormal you see with lymphoma, big kind of round, hypoechoic. They assume different shapes, and from our experience, we've done a lot of those, and we've seen lymph nodes like this being a manifestation of sarcoidosis, and we've seen this many times before. So
we're evaluating the tissue here. It looks like a good core, and now we're going to send it down for a frozen section. Again, as I said, we don't usually do that, but just to get some answers and hopefully give you an update later.
Let's get the needle again. So again, if people want to ask, what is the advantage in the stations where EUS and EBUS can access lymph nodes? For example, if you have station 7, which is the subcarina, both EUS and EBUS can access these lymph nodes, but I prefer the EUS for two simple reasons. The field of vision is better, and going through the esophagus is easier than going through the bronchial tree with a cartridge. So that's one. The second thing is, in other places, the EBUS cannot work. For example, in stations 8, 5, there is a limitation on 5, the AP window. 8, 9, and another advantage of EUS is the adrenal glands. It can access the adrenal glands and parts of the liver. So in case we're suspecting metastatic deposits, especially from a non-small cell lung cancer, then it will be a big advantage doing the EUS in this case versus the EBUS. But both of them, again, are complementary, and would like to make sure we get them both done if we want a complete mediastinal assessment.
And our anesthesia colleagues
they say definitely they prefer EUS over EBUS. It's easier to manage the patient and the sedation.
So again, we're doing a second pass, and again, we're trying to do some fanning, which means 4 passes and then change the angle a little bit, and we're controlling the motion. This is what we call the shish kebab, which means going through 2 lymph nodes next to each other, but at the end of the day, we have to access different lymph nodes. So we're getting, again, slow pull technique and getting also some tissue and sending it again for pathological evaluation. Any questions from the audience on the mediastinal assessment by endoscopic ultrasound? Would be more than happy to address it myself and Dr. Shaib.
We have a question from the floor, and
yes, please.
yes, is there any role for 25 gauge FNA of a very small vascular lymph node, or just FNB?
I like unless the lymph nodes is too small, and I just want to make sure it's not a malignancy. For example, if I want to look at just malignant cells, then maybe a small may be better because it can penetrate better, especially for small lymph nodes. But the bloodiness is higher, and at the end of the day, I would like to get a core biopsy on a lymph node. So do I use it? Very occasionally. We had situations when we just wanted to make sure there is no metastatic disease inside these lymph nodes. So yes, we can use it, but in general, I definitely prefer to use the large core biopsy of lymph nodes with no negative pressure, just slow or suction technique, capillary technique, slow pull technique, and that's it. But occasionally we do use that. Hedy, this is for formalin. Any more questions?
Do you change your technique, like if the specimen in a way you don't like it, would you consider using suction, for example?
I can use suction, but my experience, Dr. Shaib, is that suction with lymph nodes get me a lot of bloodiness. I get a bloody specimen. I don't like that. When we do that, 2 days ago, we were doing a case, and I did get a core biopsy, and the specimen was black. So I was wondering what it was. I thought there was a problem. I took more, it's black, and the diagnosis was anthracosis. So we got this, yes?
Yeah.
So looking at the specimen, sometimes it's important to decide on a diagnosis, and to, of course, make sure you have enough specimen.
But probably if you have like a small lymph node in a difficult position where you're suspecting metastases, an FNA with a small gauge needle would be enough. But again, if you're looking for a diagnosis of lymphoma or sarcoid, where you need more and more architecture and more tissue, many times it's not enough. You have to go for the core, and that's a major advantage. Again.
So again, this is the lower mediastinum, is station 9 that I'm showing you now, and there's station 8, which I showed you next to the descending aorta here, and then 7, which is subcarina, moving out, up, looking up with the needle and torquing to the counterclockwise. Station 5, the AP window, and then the 2 and 4 are the paratracheal, which are in the superior mediastinum. By getting these lymph nodes, I mean, we prefer the subcarina because it's usually the bigger and the easiest, but sometimes we have to go with more difficult lymph nodes to work. Do we have good specimens? So we have good specimens. So again, I'm going to probably do one more pass just for the sake of...
we like to look at the specimens ourselves, and that's these are excellent cores, actually.
Maybe we can put the camera on the specimens, etc., in the tube. Maybe, not sure if you can get it close to the camera, then you can see it inside this tube. Yep. Can you see the sample? It's already in formalin.
Bromonas, up and down.
Yep.
Yeah, floating, nice pinkish white.
We have a nice
material. Not too bloody, which is always important. If it's too bloody, you might want to think about changing your technique less.
Okay. Any more questions for the audience? I'm going to go ahead and get the third pass, and I think that should be enough. Paolo?
Beautiful, beautiful exam. The may, Assad, can you hear me?
Yes, sir.
Okay.
Yes, I can hear you well.
Fantastic exam. Would you be able to provide the final results of the specimen for our next connection?
Yes.
Okay.
We're going to try to send it now for a frozen section, and then we will try to show it to you as an image at the end of this.
Okay, thank you very much. Fantastic procedure, fantastic demonstration of the mediastinum. So now we move back to Milan, and we are going to present the next case in room number 5.
So next case is a 68-year-old female. In February 2024, she underwent a US with an incidental finding of a lesion in the neck of the pancreas. CT and MRI scan confirmed the presence of a 45 millimeter lesion with a solid cystic aspect and with vascularized walls and enhancement of the solid part with no signs of infiltration. Laboratory tests revealed a CA 90.9 level of 178. So we will perform US with FNA and rapid on-site evaluation. Operators are Professor Sichan and Professor Sahai.
Okay, Andrade, Anand.
Hello, thank you.
Here you are.
It's a very nice case and challenging case. I'm here with Anand Sahai and with a great team. Thank you, all of you. So here we were looking for a lesion in the head of the pancreas, but when we passed by near the pylorus, we had a big surprise. You can see here that there is an ulcerated lesion in the wall of the stomach.
Actually can't see it because our names are in. Okay, there we go. Now it's better. Okay.
It's okay. So it's quite large, this lesion. So once we saw it, we changed to the US scope, and you can see here that there is a hypoechoic lesion in the wall of the stomach. See, and you can see that the normal stratification of the gastric wall disappears here. Yeah. So it's the hypoechoic region which goes beyond the muscularis layer. If you can show the muscularis layer, which is interrupted over there. And yes, and I will try. You can see it better if I move a bit forward. And as you can see here, the liver is moving quite a bit too much compared to the gastric wall. So there, we had initially, from the beginning, the suspicion of ascites, and you will see a bit later more quantity of ascites. So coming back, you can see that this architecture of the wall is completely modified over there. And if I turn a bit clockwise, you can see that there is this lesion with a necrotic part inside. It's a huge lesion. And we consider that it's more likely to be a lymph node here with some necrosis inside. Perhaps this was what they noted on the imaging. And there is some air inside. Perhaps it could be infected, yes.
Really bad.
So if I continue to scan, because here we are in the region of the neck of the pancreas, you can see that the PD is quite normal here. And if I go forward towards the tail of the pancreas, there is immediately we scanned before, there is another lymph node coming in. Like here,
celiac
just a bit.
Is back here, so it's going to be a celiac lymph node. You spent so much time in Lebanon, the nodes got larger. They weren't this big when we started.
So here we are. This is the adrenal.
Adrenal here, yeah.
And I come back.
Yeah, left aorta, left. There's the celiac.
Perhaps
and then
it's
the
down
nodes
there.
They were pretty obvious. There's one here.
It's the largest
same
one,
the
and
same
I
one.
think
You push
it's
back in, yeah.
yes, here, behind here.
There's some
Here
more
it is.
Here, yeah,
here it is.
here.
This is the second one. So these are, and ascites, as you can see, it's here. So this is more likely to be a tumor, a gastric tumor T3, and N2 perhaps,
Yeah.
or N1 at least, but N2. We don't know if there are more than 7 lymph nodes, and M1.
Yeah, and I would point out it is never normal to see free fluid around the stomach. You can see free fluid in the duodenum, just in the hilum, a little bit. It can be normal, especially people with biliary obstruction. But if you see fluid around the stomach, it's never normal, and you have to find a reason for it. And in this case, it's obviously a sign of carcinomatosis.
So we want to go back. If you can help me to go through the pylorus, just a bit to switch.
Yeah,
Thank you. And we will go down because we want to have a fully scanned pancreatic tissue, because it was that suspicion on imaging. So we are in the second part of the duodenum. We switch to EOS, and let's have a look.
So this is the aorta IVC over here. So it lets you know you're close to here's the duodenal lumen. So you're around the uncinate process, which is going to be on this side, or over here.
And the papillary region is coming.
It's going to be over here somewhere.
Yes,
right around
it's
here.
coming. Look here.
Yeah.
Here it is. So it's
this is a bit of ventral pancreas, a
yes,
little dark.
Very nicely. And let's have a look.
So periordic nodes here.
Here. Can we measure it?
Good question. Measure, hold on. Okay.
Freeze the image, please.
Freeze, okay, set. Okay. So it's
2 centimeters.
20.4 millimeters.
Yeah. So it's more likely to be a N2 here.
Andiamo di là un po'.
Okay.
Okay, so next we have to go for...
Actually, it's much bigger. It's getting bigger.
Yeah,
Anyway,
we have to go
it's
for...
not normal.
For biopsies, so to know exactly what kind it is, but we can go just to show here, to show some contrast in these lymph nodes. So which one do you prefer, Anand? This one?
Oh, I definitely want to see the contrast.
Yes, I like contrast.
I can't wait.
Just
can't wait.
Andrada, Anand,
Yes.
Andrada, Anand, just to ask you, what will be your goal now? To biopsy the lymph nodes, to biopsy the lumen, to perform endoscopic biopsy of the.
So I would do the biopsy. I would start with the node.
Exactly.
That way you can use the same needle to do the. And I would use the same needle. I wouldn't do endoscopic biopsies. I would do FNB of the gastric mass, because the results are excellent with FNB of these gastric wall lesions as well, and you save some money on the forceps and all that business. You could try and do the ascites, because that would really show that it's M1, but it's surprisingly hard to sample ascites, I find, and you have to find a zone where you're not going through any tumor in the stomach. So I tend to never really do the ascites, but there's at least one study from Y.T. Lee in Hong Kong many years ago showing that the relative risk of finding carcinomatosis was like 17 if you found ascites in a patient with gastric cancer. So it's a very strong predictor of carcinomatosis, and we just tell our surgeons to do laparoscopy if they're ever thinking of operating in these patients.
Great. So contrast is coming.
It's coming. You
Can't
can
wait.
see the arterial phase, and you can see that there are some microvessels, but very heterogeneous microvessels inside, and you can see them more and more.
It confirms that it's a malignant lymph node.
Exactly.
Yes. So while you are performing, I proceed to perform the biopsies. We move just 1 minute to room number 6, and ask to Sandeep and Jose.
Jose,
Sandeep, hello. Sandeep, Jose, hello.
Can you hear me?
So you managed to put 2 guide wires.
We underwent to the ERCP, and I have to say that it was a very difficult cannulation, but we got it finally.
Yeah.
Sandeep got it, and now we are negotiating, or we were negotiating with the stricture. As you can see here in the ERCP picture, I don't know if you can see the ERCP picture.
Yeah.
It was a tight stenosis that is placed in the pathihylum, and with all dilation of both ducts. So we first cannulate the left hepatic ducts, and after that the right ones. And now we are getting a sample, getting a brush for the diagnosis because the two previous punctures were negative.
Okay.
And we are doing a brushing that we're trying to get an
you
outside
hold it there.
diagnosis, because if not, we cannot place a metal stent. That is the idea.
Just hold it,
Okay.
I'll move.
Okay. So you,
I'll move the moment.
So you
we are
perform
doing a
the
brushing.
brushing and wait for the results of the brushing before putting the stents. Okay. Okay.
So I am controlling the brush.
Yes. Did you perform 30 through and
About
on?
10 to 15 rapid movements. There are several studies now on how many to and fro movements are required to get the adequate tissue, but it all depends on the scarring. These cholangiocarcinomas are very serous carcinomas. We'll also take a biopsy beside the wire.
So great.
Is it crossing? This is the brush.
Which brushing are you using
I have
actually?
to go up. Okay, you can close a little bit. Let me go up.
Sandeep, which brushing are you using?
Can you answer
Sorry,
that one?
Which brushing are you using? Which?
Cook brush.
The cook brushing. Okay.
It's gone up, I think. No?
So great. So we wait for the results of your brushing, and then we move back to room number 5 to see Andrade, to be back with Andrade. Andrade?
Thank
Okay.
you. We are struggling now because as you can see, there are some vessels over there, and I'm not very happy
She
here.
made the mistake of putting on the Doppler.
Yes, of
Yes,
course.
as always.
But I'm in Milan, and I don't want to remember me as doing a complication over here. So I would prefer to turn a bit. If I cannot sample safely, I will go for the large lymph node.
Yes. And are you using a shark needle?
A shark needle, yes,
Yeah.
and I'm quite close over here, so I have to be very careful. If I cannot succeed, I will go for the next one. Okay, here, can you give me the scope? I think it's okay.
Good. Okay.
Okay, I removed. Yes, remove it, and some suction, please. Please. Yes, I need
So it
some
looks
suction.
really soft inside.
Yes,
huh?
it is, and that's why I prefer some suction in such lesions. Thank you.
Oh, it doesn't connect. It's not the same. This is the Boston suction. It works.
If not, it's okay without.
That won't really make a difference.
Exactly. Yes, thank you. Thank you, Madhu. Keep my scope, please. I just want to be safe here. As you can see, it moves quite easily inside. I try to torch a bit here the scope just to sample from different parts. I have no blood inside the syringe, so I can say I am safe here. Thank you. So I always look around. There is nothing happen over there. And next we will go for the next lymph node to see what happens, and to biopsy also the primary tumor.
I mean, look at this.
Yes, this is very nice, yes.
But that's really, this air in this lymph node is crazy. It's really, really aggressive.
Let's measure it.
It's going to be 48 millimeters.
48? We'll see.
Actually, it's
I'm
probably
quite
even bigger.
curious. Okay. Let's
Keep
have a
going.
look.
No, if you put it here, it's going to be
Here.
48.
It's
There we go. I
40,
told
it's
you.
52. Okay. We wait for the second pass, and then we will go for the biopsy of
The primary.
the primary. And before
See
we
this little lymph node.
yes,
If you ask me, this might even be a better lymph node to do because it's going to be less necrotic than the big one.
Okay.
Sometimes the
We can do it
big
from
ones are
there.
too
But
necrotic, you know.
there is some necrosis over here.
Yeah.
It's important to avoid them, otherwise we will get not adequate.
But I'm sure you're going to
material.
get a diagnosis from the first lymph node.
I hope so.
Interestingly, these patients, have very advanced lesions, but they often don't have liver lesions. You know, I don't know if I've ever seen a gastric cancer with liver mets, maybe because they never get sent to us if they have liver mets already.
Is it adequate, the first? Okay, we will go for the second. So you want to sample this one?
This or
the small one?
I would do the ulcer.
The ulcer, but a second pulse from here, do you want? Or?
I don't think so. I mean, I think you got it on the first one.
Okay, we go for the first.
So instead of doing endoscopic biopsies, we'll just use the same needle to do FNB of the ulcer. And I find the yield of this is just as good, maybe if not better, than endoscopic biopsies. I think the key is to get in the same axis of the wall, so you can really sample a lot of tissue.
Can you remove the stylet, please? I have some air here, just a bit, please. And yes, thank you, Matteo. So we are in.
If we push the scope in a little bit, maybe you'll be up against the wall a little bit.
No, it's okay.
Sorry.
The tip is over there. We can see it. I don't want to go beyond the lesion. We put some suction. As you can see, the wall is moving, so we have to take care with our movements, but it's quite easy because it's an FNB needle, so I really hope we will have enough material.
Yeah, that's
okay.
good. You went all the way down. That was
yes.
good. That was good.
I hope we are ready here. So, considering this kind of lesions, there is no help for using elasto because we have just discussed before. And for parietal lesions also contrast is nonsense. So what we need here is just to have the biopsy.
The biopsy.
The positive biopsy.
Although the elasto could have been interesting.
You want to see it? Okay.
Nice colors.
You loved the grays today.
Oh, that's really nice.
It's some blue over there.
I don't know.
It's
she's in
not.
Charge.
It's not helpful. So, and next we looked into the mediastinum.
Yeah, some of these patients have mediastinal disease as well, which is also M1. So it's worth, when you see, especially with what looks like really aggressive disease, to take a look in the mediastinum because you may get a surprise. Particularly just around the diaphragm, just above, not necessarily in level 7, but just anywhere above the diaphragm, you can find little nodes sometimes.
So this is aorta, and let's go up, and here the heart, the subcarina should come immediately, and let's have a look. We don't see any lymph node here.
Maybe a little more. That's the left. AP window is there now. So AP window is right here.
Yes, it's
right here.
Yes,
this is the pulmonary artery, aorta, AP window. So this is level 5, and level 6 is on the other side.
Yes,
and then this is the left atrium, and if you pull back and torque a bit right, you'll see the subcarina.
And there is no lymph node.
Subcarina is right in here somewhere. We should see the pulmonary artery to be really sure it's the subcarina. If we torque a bit right, pull back, torque right. Okay, there's the pulmonary artery. So this is the subcarina. There's a very flat little lymph node here, but that's it. That's nothing else.
Okay.
It's good. We have the pathology.
Do we have any?
Anand, Andrade,
yes.
You're on the line for the pathologists because the first thing that the pathologists are analyzing is the biopsy that Sandeep has performed in the common bile duct, and then you will be the second on the line.
Thank
so
you.
first we move to the pathology room just to evaluate the results of the biopsy
So,
that,
Matteo, what do you propose
that
to,
Sandeep has
to
performed.
have a
Can we move to
endoscopic
the
biopsy
pathology
of the
room?
ulcer, or it's
Yes.
Professor Cigliacono, you're online.
But we did the biopsies of the
This is
lesion.
the
as a
processing
primary.
of the
Yes.
sampling with forceps, and I give the mic to our pathologist.
Thank you. Okay, so now we will go in detail with Vivascope. We are on focus, and now we see the bull slide, the bull scan. And in the meantime,
lo
also
vedo
the
qua.
brushing are almost
Ma
ready
loro lo
to
vedo,
be
no?
visualized.
Sì.
Okay. So here we have a fibrotic reaction, fibroblast. These are not enough atypical cells. These are not suspicion. Again, these are ductal cells, but they do not look like suspicion cell. Again, those one are regular with large amount of cytoplasm. Again, here we have good representative bile duct epithelium, which is still regular. This could be something interesting, but we need, yes, but they are just 3 cells, so here you need for sure immunohistochemistry to identify what are those. So also those one could be, but we need immunohistochemistry. I don't know if you see the different levels here, also those one, but fibroblast can become really monsters sometimes, so you need immunohistochemistry here to be sure what are they. They are not so hyperchromatic, so.
This is the biopsy.
This is the biopsy.
So
now we will see the brushing.
This is very important to show because you are
Yeah.
looking at the standard biopsy
Yes.
that we can obtain in the CBD, and you have stained that in 2 minutes, 3 minutes. So
Yeah.
this is very,
Yeah.
very interesting
Yeah.
and very important to show. But with these results, you suggest that you need to have more
Yeah.
material.
Yes, yes. Now we will see the brushing. Maybe there is something good there to make a diagnosis.
This is this one that you are analyzing now.
So here we have another level of the same, but of the same specimen, of the same biopsy. And the only thing that looks suspicion are these aggregates. But again, we need to confirm with immunohistochemistry because all the other stuff are pretty nice. There is a lot of inflammation, and that's a reason why also bile duct epithelium can become very atypical. So now we see the brushing, and then we'll see if we need more.
Okay, that's great. So we go back to room number
We are
6.
ready for the brushing also, Paolo.
Yeah.
If we move the camera on the screen.
And you already have the brushing?
In this moment, yeah.
Okay, so we look for the brushing results. Can we show them?
Here we have some aggregates, but they are pretty nice. Again, small cell, there is some bile. I hope you see them.
Pathologo.
Here we have normal aggregates,
Can we show the
normal,
pathology? Okay.
normal glands. Here we have some bile, some, again, also normal ductal cell. So until now, I don't have any diagnostic cells. These are nuclei which look nude, but they are not diagnostic because this is not enough. So, and here we have more bile, some amorphous material, and again here we have an aggregate of normal biliary cell. Okay, so I hope you are on focus now. Okay, so until now I don't see anything which is diagnostic for cancer, for adenocarcinoma.
So thank you very much. I think that we need other material from the room number 6, and then we will analyze the results of the room number 5. But while we do this, we move again to the American University in Beirut. Assad, can you hear me? Assad, can you hear me?
I can hear you very well.
Great. We hear you as well.
Paolo. So we're going to basically do the case presentation for the second case.
Okay, so our patient is a 63-year-old male patient. His past medical history includes hypertension. His medications include only amlodipine. Family history is unremarkable. And social history is a non-smoker, only a social drinker. Patient was complaining of recurrent epigastric pain radiating to the back. His first episode was in October 2023. The workup in outside hospital showed high lipase, normal LFTs, normal triglyceride levels, normal calcium level, normal CA19-9 and IgG4. Later in December 2023, patient had an MRI, MRCP done. It showed mildly increased signal intensity along the head of the pancreas that may represent mild pancreatitis, and there was a 2.4 by 1.3 centimeter cystic lesion in the head of the pancreas. No pancreatic disease noted. Back in 4th of February 2024, patient presented to our hospital with recurrent abdominal pain, a high lipase. Bladder ultrasound was done on admission, showed sludge, no gallstones, no ductal dilatation. Full CT scan was done, which during the admission showed inflammatory change at the pancreatic head and uncinate process suggestive of acute pancreatitis. Again, a cystic lesion in the head of pancreas measured 2.6 by 1.4 centimeter was seen, likely representing either a unilocular cyst or a side branch IPMN. Later, during the same admission, he had lap cholecystectomy performed. Again, on 26th of February, our patient presented with recurrent severe epigastric pain, high lipase, normal LFTs as well. A CT scan was ordered, and it showed interval increase in inflammatory changes at the pancreatic head and uncinate process, suggestive of acute pancreatitis. As seen in the picture, the red dot, an unshaded cystic lesion at the head of the pancreas measuring 2.8 by 1.8 centimeter, likely representing either unilocular cyst or side branch IPMN.
So basically, we're back with you from Beirut, Lebanon, and again, joining me is my colleague, Dr. Shaib. And again, this patient posed a diagnostic and management dilemma because he had smoldering pancreatitis, and over the past few months, anytime he's challenged with food, he gets inflammation and inflammatory changes and high lipase and pain. So the issue is, what is causing this pancreatitis? And as you saw, everything has been ruled out, and we are left with very few options. The patient even underwent cholecystectomy because of the presence of sludge in the gallbladder, but apparently it didn't really change his symptoms. Now, the plan was again to look at the cystic lesion because it was on CT scan, but I think now we're going to move in a different direction, and this shows you how the AUS can change management. In this case, the plan was, is the cyst the cause of pancreatitis? Although it's small, it's hardly 2 by 1 centimeter, it's kind of like a linear cyst, or is it like a pseudocyst? We don't really have the old record to see if he had the cyst prior to the first episode of pancreatitis, so we don't know that. But having said that, and looking at the images, I hope now you can go to the AUS image, and please confirm, Paolo, when you see the AUS image.
Yes, we can see the US.
Can you see it? Okay, so basically, again, the plan was to go in and to, if it's a big cystic lesion, put a needle, get amylase, get CAA, get glucose, even the next generation sequencing, etc., to try to see if this is mucinous or non-mucinous. But what I'm seeing now is different, and this is not seen on any modality before. Even, I believe he did have an MRCP in the past few months. If you look at the screen, you find an ectatic dilated duct. And this ectatic dilated duct is not actually, it's a branch of the pancreatic duct. And if you look here, it's about around 6 millimeters. And if you follow it, it goes into this area down. I'm at the level of the uncinate process that is even more dilated. I don't see a well-defined cyst, but I can see an ectatic dilation of the duct itself. Can you see it with me? Towards the right lower side of the screen. So, in this case, I think having this is suggestive of an IPMM. What do you think, Dr. Shaib? Do you agree?
I think this is very interesting because you go in planning something and then you're surprised with something which was not seen even on MRI. And again, if you see this dilated duct that's up to like, I think 7 millimeters, there aren't that many things that can cause that and also could be contributing to his pancreatitis. So we should include this definitely as high on the differential. Still the question is there something else associated with this dilated duct?
So basically, you can see that this duct is dilated as much as 11 millimeters, and it's basically at the level of the unsealed process. The MRCP did not show anything at the level of the body and tail, and his pancreatitis is predominantly, you can see even the changes of inflammatory changes in the head of the pancreas and in the unsealed process. It's very obvious here. So it's towards this part, and you can see some non-ectatic parts, as you can see in the middle of the screen of the pancreatic duct. So is this basically an IPMN that is causing this? In the absence of any other cause, I don't think we have any other explanation to his recurrent and smoldering pancreatitis. So in this case, I do not think that putting a needle here is going to make a big difference, because at the end of the day, this is not a cyst, it's a duct. What do you guys think?
What does the audience think? Any feedback from the audience on this one?
Yeah, actually doesn't look like a cyst. We can see some lobular pattern and some strands, hyperechoic strands and dots. So yeah. Anybody from the audience would perform any FMB or FNA?
Of course. But I don't think doing an FNA, he's still having smoldering pancreatitis. Doing this FMB, I don't think there is anything suspicious as far as a mass lesion. But this lesion that I saw is quite impressive. So I think this is the culprit. And again, to show you by color Doppler, that this is obviously not a vessel. This is an ectatic part of the duct, of the pancreatic duct, and it's localized in the head of the pancreas, uncinate process. You can see it very clearly. And this is probably the cause of his pancreatitis. I do not see any other thing. Everything else has been ruled out. So with these new findings that we just saw on endoscopic ultrasound, I think I'm going to change my mind about getting a biopsy or aspiration of this cyst, because this is not a cyst. I hope all of you agree, because I think this is the right thing to do at this particular point.
Yeah, the audience here completely agree. Nobody would go for biopsy.
Okay. So now the question that is the million-dollar question is what to do, because this man has continuous smoldering pancreatitis, and if this is the case, then obviously there is nothing beyond surgical management. There is nothing else, because he's been in and out of the hospital for the past 6 months, almost continuously, and there is nothing basically that is causing this except this abnormality. So I think what we're going to do is we're going to just consider surgical resection. Do I have agreement on that?
Any suggestions? We have to have an answer for the patients. You can help us.
How old is the patient again?
There is nothing else, Dr. Shaib. Yeah. How old? He is in his 60s, early 60s? 63. 63. Otherwise healthy, just hypertension, and over the past 6 months, almost pancreatitis on weekly basis. I would say that it's basically a continuous type of inflammation. And everything that could cause pancreatitis has been ruled out, except for what I'm seeing now on the EUS. So I believe that this added quite a bit of information.
Did you already test for IgG4?
Yes, IgG4 has been done twice, and it is negative.
It's a very tricky case. Thinking about surgery,
yes,
it could be an option, but it's quite tough.
Yes, I completely completely agree with you. But at the end of the day, look, I mean, this is not normal duct. This could be just, I would say it's beginning to look to me like a localized main duct type. Do you agree, Dr. Shaib? Look at it. This is not a branch. Just look how long it is.
Yeah. Would you, like, for example, I know no one mentioned, let's say, pancreatoscopy. Would you go and check it, see if there is a...
By spyglass.
By spyglass, something to biopsy, something to look at, find the extent, confirm.
I think doing an ERCP down the line is not a bad idea. Okay, I think basically we got our answer from this case, and we are definitely open to any comments from the audience. Paolo or anybody else?
Did you already answer about, I didn't get it. Someone here is asking for the possibility to place a pancreatic stent. Would you do that?
Not really. Pancreatic stents, in the case you're suspecting, basically, we're not suspecting a stricture. This is basically an ectatic, abnormal looking lesion. So I think I would confirm it by an ERCP and maybe look at the ampulla better. But it looks to me like an IPMN. I don't think putting a stent, you agree, Dr. Shaib?
I don't think putting a stent, but evaluating it, of course, if you end up taking a look with spyglass, you will end up putting a stent. But it's not like a case of, let's say, chronic pancreatitis, where you have a dilated duct and you're trying to alleviate symptoms and see what happens before you decide on surgery.
This is the most ectatic part of the duct. You can see it on the right side of the screen. This is basically, it's a continuum. So it is continuous. You can see it here. Yep. This is the part that is dilated up to 9 millimeters. And this part here is even more. Right here, it's up to 12, 13 millimeters. So that's a continuity. That's an ectatic abnormal. It looks to me like an IPMN.
I think the challenge here is twofold. One is what to do for the patient's symptoms and his recurrent pancreatitis, and the other thing is to completely rule out malignancy inside what looks like an IPMN, especially someone who's getting recurrent pancreatitis.
Yep.
Like offering him surgery.
So I guess we'll have to manage it based on this new, basically, information from EUS regarding this being most probably an IPMN. And I guess we can complement this by doing an ERCP. But at the end of the day, I don't believe that this lesion is amenable or should be biopsied at this point or aspirated. I think we can basically hold off any particular intervention at this point. Any final questions, please?
We have a question from the floor. What's the role of pancreatic sphincterotomy in this patient?
It's something that we might attempt depending on the results of the ERCP. And of course, I would like to look at the sphincter. I would like to see if there is some mucinous material, etc. But yes, it's a part of what we will do probably when an ERCP is done. Although I doubt that only if whoever asked the question is thinking about hypertension or of the sphincter pancreaticus is what you're thinking about. But because it looks more like an IPMN to me, but we will take a look when we do an ERCP on that.
Would you consider to have a look endoscopically to the papilla, looking for an eventual fish mouth sign that would be diagnostic in that case?
Unfortunately, this scope, yes, of course, that's during the ERCP. With this scope, it's kind of a 45 degrees, so it doesn't really take a look. We tried to look at the ampulla before, but it doesn't show the ampulla well. But with the duodenoscope, definitely, it's a good idea to look at the ampulla. And that's a part of what we're going to do when we do an ERCP on this man. Okay, I guess our time is up. So unless there are more questions, I think you can basically conclude the session.
Yeah, but it was very challenging case you choose. So
yes, it is very challenging, and that's why.
We are aiming for the results. If you want to send us the results of the final conclusion of this case.
Definitely.
So thank you very much again for joining us also from remote. It was really a great.
And the rest of the team, and best regards from Beirut.
Thank you very much. Thank you very much. A big hug to everybody. So we have closed the first part of our day, very busy day. So I think that we will have a lunch symposium, and then we will move to the first session of the afternoon before coming back here in the endoscopic department to perform the other cases of the afternoon. So thank you very much. Enjoy your lunch symposium by Pentax. It's a very tricky question because they are dealing with babies, with children, and so it's very important because nowadays if you are working in a big department of US, is more and more frequently you have to deal with children. So we are very, very glad that Pentax has organized this kind of lunch symposium. So I give you the line back to the auditorium. Thank you very much and see you very soon. I see. Okay.
Just want to inform you that for all Pentax medical participants symposium, lunch boxes are ready outside the plenary in front of Pentax exposition.
You're here for this? Okay, good. Yeah, it's the
morning again. It's my pleasure to introduce the next session, very interesting session. It's a Pentax Medical Symposium, as have you heard from Professor Arcidiacono, in something new. We are going to explore interventional capabilities with slimmer solution in the biliopancreatic field. And it's my honor to introduce Professor Sai from Montreal for the first lecture.
Okay, good afternoon. So can I have the first slide? Oh, no, I want to go up. Okay, so it's my pleasure and honor to be with you again this afternoon. We have a 1-hour symposium here, and hopefully we'll stay on time. Today our presenters are, I think, well known to everybody. We have Sham Varadarajalu, Carlos Robles, and Valerio Balassone, who all have an interest in using the new Pentax slim scopes, and they'll give us their various views on how it's influenced their practice. So just to give you an idea, I won't go over all these data, but I don't know if you've used these scopes, but you know, when we started out, the scopes were quite large. They had mechanical systems that rotated the radioscope, and I think we're really spoiled now because even the therapeutic scopes have become really quite easy to use, quite small. Even the therapeutic now Pentax linear scope, you can use even in pediatrics. I've done it in children down to about 3 years old now without a problem. And then they came out with the slim scope. The slim scope for us is very helpful because I use it primarily as a diagnostic scope. I call it the little old lady scope because more and more of our patients, as you know, are older and more frail. And this scope is, I find, very easy to pass in older patients. The bending section is shorter, which is the most important variable for actually intubation. It's not the diameter of the scope, but the bending section. So with this scope, even in older patients with osteophytes and difficult intubations, it goes down very well. The imaging is outstanding. It has a 2.8 millimeter channel, so it will take even up to a 19 gauge needle. So for diagnostic purposes, including all tissue sampling, even with a 19 gauge needle, it works fine. You cannot put down stents or use the Axio system. The channel is too small. As I said, we use it as our basically diagnostic scope for most basic EUS. I would add that in certain situations, for example, duodenal strictures, it's maybe not the best scope. In those situations, I prefer to have a therapeutic scope which is a little stiffer. And as you know, in strictures, duodenal strictures, for example, you don't have to get through the lesion. You just have to be able to wedge into the lesion, and then with the ultrasound, you can see beyond the stricture to get a better idea of what's going on and do sampling if you need it. However, for esophageal cancers, I find that the slim scope is really nice. It's very rare that you cannot get through a stricture with this scope. I personally don't do gastroscopy in those patients. I just go straight down with the slim scope because, again, with the linear scope, you can actually see in front of you. You can see the stricture with the ultrasound. And the scope itself is sort of shaped like a dilator. So it lets you pass through these strictures quite safely, really with minimizing the risk of perforation, because you can really see the architecture of the stricture, and you can really get a good idea whether or not your scope is going to make it through without actually doing a dilation. So for us, it's really become a really integral part of our practice. And then our speakers, I think, will explain to you a little more on this issue. Just one more slide here, just showing the pediatric duodenoscope and the dimensions here. For those of you doing pediatric ERCP, this can be helpful, although I think our ERCP people tend to use just the regular pediatric scope in most children down to, again, 3-4 years of age. But in certain situations, this scope may be helpful as well. So if our speakers are ready, and I hope they are, our first speaker is Sham Varadarajan from Florida. who will be discussing the impact of slim echo endoscopes in the practice of EUS. And I can tell you Sham is a major Olympus guy, but I was very surprised to see that he actually found some value in the new Pentax systems, particularly the slim scope. So Sham, is he ready?
We have some connection problems, go
okay.
for the, I think for the last presentation, and then we go back with Shyam.
So the next presentation is?
The last one with Dr. Balassone.
Okay, okay. So Valerio's there. Okay, so we'll move on to Valerio Balassone, and I just lost his the title of his presentation, but I'm sure he can tell you. Welcome.
Hello, thank you everybody for this kind invitation. I sometimes feel like a child between adults after what we saw today, but I will try to talk about our particular experience. I am a digestive surgeon with adult experience who moved to children's field since 2016, but still keep training on the adult center through a transition program. Our international fellowship to teach GI pediatrician, US and the RCP is supported by Pentax. I work in a group who pursue the aim of non-invasiveness since before I was born. We grew up and became more and more fighting against the same enemies, which are mainly represented by limitation of accessories, setting, safety, training, and endoscopes. Let's start busting a myth. Still in 2024, we have no dedicated tools for children, and this means that you need technical adjustment continuously and the experience to manage, for instance, the problem of the diameter of the cannulation tip, the space to bend the sphincterotome or the cannulotome, which has a single way, so you need to choose between contrast and guide wire. And we need to adapt stents that are not intended to be placed in a biliary tree of a child. We generally perform ERCP and US in a general anesthesia with the experienced anesthesiologist in an OR setting, and we try to keep attention to avoid long position in order not to compress surrounding strictures. And for children under 7 years is mandatory the endotracheal intubation because of the tracheal compressibility. And CO2 is employed for all procedure. Concerning about safety, we need to be very careful because we not only have the problem related with the comorbidities of the children or the complexity of the case, but also because we could not be available to pass an overstitch, an over-the-scope clip, or a self-expanding metal stent. So we need to adapt customized solution to manage a possible complication. Training still represents a bottleneck of our capability to provide, to teach our colleagues in this field. About the volume, for sure we now overcome US volumes, so we performed 200 cases last year in our center, and we are trying to promote training program, especially for teaching the therapeutic field, but still it's really difficult to maintain the skillness, and this is why we need to work strictly with adult center. Talking about the endoscopes, which represent the core of my presentation, we recently break the rule of 10, so we now have the chance with this scope we mentioned before to perform a diagnostic and therapeutic ERCP, which may represent a simple task, just a sphincterotomy, but that can change the management of the patient in favor of a more conservative approach. Let's move on to clinical cases. This was a 5-year girl of 15 kilograms referred to us for recurrent pancreatitis. An MRCP was strongly suggestive for a choledochal cyst associated with maljunction, because we found dilatation, kinking, and multiple stones, and a dysmorphic gallbladder. But when we attempted an ERCP with a standard duodenoscope, we failed to cannulate the papilla because of an associated duodenal stricture. A CT scan confirmed an associated annular pancreas. So in the previous mentioned setting, supine position, intubated patient, we reached the papilla with a slim scope with a really uncomfortable position, but was enough to make the cholangiogram, confirm the maljunction, plan the surgery, and pass a guide wire to perform a sphincterotomy in order to prevent further pancreatitis before the surgical procedure. The girl underwent a minimal invasive choledochal cyst resection with a Roux-en-Y gastrojejunostomy together with a pancreatic incision performed by our group. She was refeeded in the second day and discharged after 6 days, and she is proud and fine at her follow-up. This is another girl of 4 years with 15 kilograms, referred to us for an unexplained jaundice despite an extensive workup with an intra- and extrahepatic biliary dilatation. An MRCP showed a right biliary dilatation with an aberrant anatomy. An ERCP with slim duodenoscope was performed. We had a cholangiogram that showed a polypoid obstruction of the main biliary duct, and we could perform a biliary sphincterotomy and left in place a nose biliary tube for cytology, but was not contributive in the suspect of a rhabdomyosarcoma. That was confirmed by the CT scan, showing a mass of 4/2 centimeter in the right biliary duct, involving the gallbladder and the common duct. So we decided to perform a direct cholangioscopy in order to obtain a mapping of the biliary tree and to confirm the histology and to prepare a tailored neoadjuvant chemotherapy according to APSSG protocol, and also to confirm the response to the neoadjuvant chemotherapy 3 months after the starting, and that the left biliary duct was always free. So she could receive a right hepatectomy and spare the left liver. And she is doing well at the multidisciplinary follow-up. The last case is a boy of 6-year-old, 13 kilograms, referred to us for a cerebral malnutrition related to a cerebral palsy with spastic dystonic disorder, and he was candidate to surgical correction of a severe scoliosis, but at least 20 kilograms is required by the orthopedic. He had a severe malnutrition, depending on artificial nutrition, enteral and parenteral, together with gastric decompression. He experienced repeated PEG-J dislodgement with prolonged hospitalization and central vein infection. So we came back to PEG and decided a new plan. As a single endoscopic gastrojejunostomy was preferable because of the unfriendly anatomy and the expected difficult management of double stomas, we decided to place a LAMS-assisted gastrojejunostomy just to reroute the J tube. As you can see, passing the scoliotic bulging to the esophagus was not so easy. We used X-ray, but we were able to pass a guide wire and a diagnostic catheter in the jejunal bowel loop. As we saw before, we fill the jejunal loop with the contrast, blue methylene blue, and saline. And we performed a LAMPS gastrojejunectomy with a standard technique. Distal flange. Intracannular release of the proximal flange. We use the guide wire, and you can see the contrast going back in the stomach because there is no stricture to keep the contrast in the bowel loop. And close to the anastomosis, you can see the PEG bumper. 3 weeks after, we could remove the lumps and replace and reroute the PEG-J through the anastomosis. The guy could tolerate well jejunal nutrition, improve his weight, receive orthopedic surgery, and became progressively independent from parenteral nutrition. And now we have 2 years of follow-up and no more dislodgement. So to conclude, slim scopes with improved therapeutic capabilities offer new minimally invasive option for children. Biliopancreatic in children is expanding, and there are growing indications and volumes. But the training and referral with tertiary center is strongly advocated. Thanks for your attention.
Thank you, Valerio. You have a fantastic experience with this because I know a lot of people are very unfamiliar with doing these procedures in children. Are there any questions for Valerio before we move on to the next presentation?
In the slim duodenoscope.
Can you just repeat the question, Valerio?
He asked about the difficulties with using this slim duodenoscope in children. We have to say that it is not an endoscope for newbies because if you don't have a very good position into duodenum, you can experience some latency of the elevator. So this is important to tell to the pediatrician that approaching to this field without a big experience, that could not be the first try duodenoscope.
Any other questions? Is there any hope of the companies making pediatric accessories?
I'm sorry?
Is there any hope that the companies will make pediatric accessories?
We have even less pediatric accessories recently because some patents were withdrawn. So we still have no dedicated tools, absolutely. Even less than before. That's, for instance, we had a different plastic stent, was really useful for us. We called it Viaduct. It was like a star profile. It was very useful for a peri-stent drainage, but is now retired. So we need always to adapt different concept to our field.
Okay. And what size lambs did you use in that patient?
It was 10x15.
Okay, okay.
Not that big, but for our purpose was perfect.
Yeah.
The problem is when you remove the stent, the anastomosis closes. So you always need to keep something inside, and was very nice if the PEG is there, but if you remove the jejunal tube, you need to put something inside, otherwise it completely closes immediately, as always.
Mm-hmm. My experience with children is that they always have weird things. It's a lot of congenital You know, the differential diagnosis of adults doesn't often apply in children. Has that been your experience? That it's usually things that you really will never see in adults?
There are two words. Sometimes don't speak enough together, and for sure, as you mentioned before, it seems so weird, but actually these children has a life expectancy that is comparable to an adult. So we have to communicate more. Otherwise, you will receive sooner or later this patient with a completely different anatomy or physiology, and it will be very difficult to handle if you don't have this collaboration. In US, last year was published a paper about transition, and there was more than 500,000 patients requiring transition every year. So it's a thing that we can accept and do something for, or it will go over us, for sure.
Fantastic. Okay, any other questions? Okay, well, thank you very much, Valerio. Maybe just come and sit here, and one more round of applause in case there's any more questions. Okay, so Sham is ready? Okay, so our next speaker is Sham Varadarajalu from Florida. Some of you may have heard of him. He's an up-and-coming EUS person. So Sham will give us his insights into his use. Sham has, as I say, moved a bit to the dark side of Pentax, at least for this limb scope, and I'm very curious to see how it's influenced his practice. Welcome, Sham. Oh, we can't hear you. Still can't hear you. Nope. Nope. Can you hear us? Okay, so we just can't hear you. Carlos, can we hear you? Nope.
Yes.
Oh, we can hear Carlos. Maybe we should do Carlos, and then you can work on your sound. Okay. So let's move on to Carlos then. So welcome, Carlos. Long time no see, and we're very interested to hear you again talking today about the utility and clinical applications of the SLIM scope for EUS and ERCP.
Yes, so you can see my presentation?
Yes.
Perfect. So, well, thank you so much for this kind invitation. Here is it's early in Ecuador, so I'm here with my technicians preparing everything for live cases after. I will talk about the utility and clinical applications of the SLIM scope for EUS and ERCP. So the advancements in technology allow it for the development of SLIM scopes and subsequent evaluation and intervention in the pediatric population in cases with narrow anatomy. Despite ERCP and EUS has become indispensable, mainly in the pediatric population, ERCP and EUS were not implemented in 20% and 51% of facilities, respectively, of 68 facilities in the North American Society for Pediatric Gastroenterology, Pathology, and Nutrition, in all pediatric gastroenterology programs. So this is some of the characteristics of the scopes, and one of the very interesting things is that the insertion tube diameter, for example, for EUS, the SLIM EUS, is around 11.6 millimeters with a minimum working channel of 2.8 millimeters. And for the SLIM DEC duodenoscope is 12.5 millimeters of diameter with an insertion with the minimum instrument channel of 3.2 millimeters. So giving us the opportunity to use in patients with less than 10 kilograms. I can say between 7 and 10 kilograms. And this is a very interesting approach that can help us not just in pediatric population, but also in patients with very thin stenosis. So this is a little bit the characteristics. You can see the difference between the scopes and the diameters. Here, you can see here the slim deck duodenoscope. You see 12.5 millimeter of diameter insertion compared with the 13.6 millimeter of the standard scopes, duodenoscopes. And here you can see the image of the slim scopes that is really thin. It's almost like using a standard gastroscope. And this is the comparison between other manufacturers and showing the big difference between working channel and distal and diameter. What are the clinical applications? So this is the first paper published in 2015 from the group of Dr. Iglesias Garcia in Spain, showing us the safety and feasibility of using a slim scope in different situations in 87 patients that were submitted to this technology, showing that it's feasible in almost all the cases. Just in 2 cases, 2 pancreatic lesions accessed by D2 were not allowed. This is another paper from the same group of Spain. So they also showed how in around 537 US procedures, just in 128 cases, in around 23% of cases that they performed, they needed to use this kind of technology because of the stenosis or some kind of alteration in the anatomy of the patient. So showing that we can have better intubation and access in some cases with good maneuverability and good quality image compared with the standard scope until that time, the UK technology. So this is a very nice paper from the group of Cheyenne. I believe he's showing us the real impact of in his clinical practice now that the examination with the slim linear scopes was technically successfully in 98% of cases, especially in those cases that were using the standard US scopes were failing. In almost 2,000 procedures, 23 cases were necessary to use it. In of these 23 cases, 22 patients were successfully achieved the treatment and changed the diagnosis and the treatment of these patients. What about the slim deck, the duodenoscope cases? So I will show you some cases in real practice. So this is one of our cases, a 53 years old male with history of jaundice that come to our unit because of suspect of ampullary infiltrative tumor with invasion of D3 involvement. So in this case, we needed to change to the slim duodenoscope because we didn't achieve it to see the papilla with the standard duodenoscope because of the stenosis. In this case, we arrived to have a good position. So we performed a balloon dilation of the stenosis, and then we achieved also we arrived to perform the pass through the stenosis, and then to perform a good cannulation of the biliary tract. So the outcome was clinical and technical success with symptomatic relief with not procedural complications. We arrived to perform biopsies, biliary cannulation, sphincterotomy, and to put metallic stents. And finally, we solved this infiltrative ampuloma using the new duodenoscope, the SLIM deck. Some cases with linear US. This is a 3-year-old male patient with medical history of esophageal atresia, managed surgically, and with esophageal dilations, with last dilation sessions during the last 2 years. With the patient still had symptoms of dysphagia, for solids, and fluid intolerance. So the patient is coming because of stent migration and has been treated with fully covered metallic stents. So what we do in this case was trying to target a better corticoid injection using US. I has been using this in some cases when has been the patients had failure for the treatment. So we achieved to inject the corticosteroid not just in the mucosa but also in the muscular layer. And you can see here when we apply the treatment guided by US. So in these cases, after the treatment and balloon dilation, the patient becomes better. So this is another case of a patient, a pediatric patient, a 4-year-old male with a history of jaundice and abdominal pain. So the patient had a failure ERCP in another center before. So the patient was sent to us, and we didn't arrive to have a cannulation. And because of the size of the patient and the kilogram of the patient, we used a SLIM US just to perform a cholangiogram guided by US. What we saw was a post-surgical biliary stenosis, and this patient was sent to surgery after the diagnosis. This is another case of pediatric patient with caustic ingestion in 2019, and we come to a unit for balloon dilation and stent placement. But what we start to perform was using the linear SLIM US. We achieved to pass through the stenosis and allow it to use triamcinolone injection directly, not just in the mucosa but also in the muscular layer. This is my last 2 slides. So the take-home message. So the formal indications or possible indications for a SLIM deck duodenoscope is the pediatric population for sure, and esophageal or duodenal stenosis. Advantage are appropriate maneuverability, reduced risk of perforation. We have also a disposable end cap, reducing the cross-contamination and easier reprocessing, precise therapeutic performance, especially in ERCP procedures, and allows accessories for therapeutic procedures with HD plus image quality, with a small anatomy detailed visualization. The disadvantage of DEG of this SLIM duodenoscope is that we cannot use a cholangioscope more than 9 French. Stents of more than 9 French cannot be used, and could have less stability sometimes in some cases overall in patients with stenosis, in adult patients with stenosis. Regarding the SLIM linear echo endoscope, it's a good option for using in anatomic variation of cervical spine, for example, pediatric population with less than 2 years and less than 15 kilograms, but not less than 7 kilograms. Please take care about that. Esophageal and duodenal stenosis and complex structures, navigation through post-surgical bypass anatomy, and doing edge technique in gastric access temporary for endoscopy to avoid the need of endoscopy suturing. Advantage, appropriate maneuverability, reduced risk of perforation, appropriate visualization of the region of interest, thinner distal end with shorter bending section, and disadvantage, the limited to diagnostic procedures, and just we can perform some cholangiogram as therapeutic or neurolysis. Thank you so much for your attention. So this is our events that we will perform this year in May and August. So you are invited to join us. Thank you so much for this kind invitation.
Thank you, Carlos. So, are there any questions for Carlos while he's still here? So I think we'll let you go, Carlos, unless you want to stick around for any more questions after. And Sham, thank you very much again, Carlos. And Sham, is your audio working? No, it is not.
Can you hear me?
Okay, now we have you. Okay.
All right, got
Great to have you, Sham. Go
Thank
for
you.
it.
Just a technological challenges. Let me share my screen. There we go. Okay. Can you see me, Anand?
Yes, yes.
Okay, so I've been asked this morning to talk about the impact of the slim linear scope on the practice of EUS. So, we all know a simple way of looking at it is if you have got a tight stricture and a regular scope will not pass, just use a slim scope. There's no scientific rationale to it. But I think it's always nice to identify places or circumstances so that we can be planned and we can procure this technology for our unit if we encounter such patients. So that was the objective of the trial that we did, and these are my disclosures. So for background, I think we all know that perforation is more common with upper GI EUS than an upper endoscopy. And this primarily is related to the design by which the EUS scope is constructed. It is not a forward view scope. It's oblique view, and it's got side view optics. So every complication such as perforation and interventional EUS in particular have been problematic because of the technology. I don't want to go through this, but all that we know is compared to all the linear scopes that are available in the market, the Pentax Slim J10U scope has got a distal end that is approximately 1 to 2 centimeters smaller, 1 to 2 millimeters smaller than what is available conventionally in the market. And the insertion tube is small as well. It's about 11.6 millimeters. The downside is the channel width. So it's got a 2.8 millimeter channel width. So we can pass smaller accessories, a 7 French stent, but we cannot deploy metal stents and so forth using this technology. So we did a prospective study. It was from a single referral center. We took all the patients who came for an EUS who are aged more than 18 for over a 1 year period. We performed 2,000 procedures, and we wanted to see under what circumstances the slim scope will be available. So everybody will start off with a regular EUS scope, and if they cannot undergo the procedure successfully, then we would use a slim scope on these patients. And the main outcome measure was how do you study the impact, which is establishing a new diagnosis on the patient, or if use of the slim scope altered subsequent treatment plan. And we look for adverse events. So these were 2,000 procedures that were done. In one patient, we could not perform the procedure because the patient had a laryngeal stricture, had a radiation, and the stricture was too tight even to pass a standard gastroscope. So that didn't work out. In everybody else, we were able to pass the scope. Some required dilation, others did not. And in 22 out of 23 patients, or 95%, the procedure could be done successfully. And we identified 4 circumstances in which the scope will be useful. Primarily, there's an increased application of bariatric procedures, which is a Roux-en-Y gastric bypass. In these patients, it's very easy to have perforation when a side view scope or a linear scope is passed. And that's why majority of these patients these days are being sent for PTC or you will just perform an ERCP without an EUS. So we were able to place an Axios stent, suture it, and then advance a slim scope through the Axios stent to perform interventions such as a fine needle biopsy. The second were patients in whom there was a stricture on a CT scan or a MRI in the upper GI tract. So these are patients primarily, they fall under 2 categories. Either you have a duodenal stricture that will preclude passage of the scope through the pylorus, or you will have an esophageal stricture or a gastric cardia stricture through which a regular echo endoscope will not pass. So in these patients with limited dilation, we could advance a slim scope and procure tissue diagnosis that enabled them to get chemotherapy or made them non-operable candidates so that we can choose palliative options. The third group of patients are elderly patients who have an enlarged cervical osteophyte. So there has been a paper from Mohammed Yalubidi at UAB who has given us actually a frequency with which this can occur. So you don't see actually a mechanical obstruction, but what happens is when you pass a scope, there's increased stiffness of the neck region, and perforations are common in this area, and these patients don't do well. And what we found in those patients is very, very useful. And also in patients who have undergone a tracheostomy, across which it's very difficult to get a regular scope, but a slim scope will pass. And last but not the least are patients with lesions adjacent to the duodenum. And these are patients who will have masses close to the third or the fourth portion of the duodenum, in whom a regular scope will not pass. It will go up to the second portion and you have to retract it. Whereas a slim scope can be pushed even further, the disadvantage being that you're literally having the handle of the scope at the mouth of the patient, but you will be able to navigate these scopes with relative ease. And what we found is that with this outcome, we were successful in about 95% of the patients. And I will just go through some cases which are pretty easy cases. The first is a 65-year-old patient who was referred to us with nausea and vomiting, and the patient had a malignant duodenal stricture. A tissue diagnosis was desired, and you can see here, you can't advance the scope very easy, but you will be able to nudge the tip of the transducer into the duodenal bulb across the stenotic pylorus, and you see a mass that is very ill-defined, and what you're seeing more proximal to that is just inflammation from the associated ulcer. So this patient had about 3 upper endoscopies and multiple biopsies that showed only inflammatory cells such as neutrophils and macrophages. Now you see the mass, there's a small cutaneous vasculature. Here is a regular 22-gauge needle being advanced, and with multiple passes, you can find tissue cells, and this was actually adenocarcinoma of the duodenum. The pancreas in this patient was completely normal. So this patient, after 3 negative upper endoscopies, had a tissue diagnosis. Then the next patient is a 56-year-old with obstructive jaundice and a dilated bile duct and pancreatic duct on a CT scan, and this was the patient I discussed about. So this patient has got an altered anatomy, and we had difficulty passing a regular EUS scope in this patient. So you can see the remnant stomach. We installed saline that is mixed with contrast and methylene blue to inflate the gastric lumen. And once this is done in this patient, this is a regular scope, EUS scope. You pass an Axios, which is 20 millimeters. You use then your Apollo device, which is now owned by Boston Scientific, to just put in 3 sutures so that the stent is anchored. So this patient had 2 problems. The patient has got jaundice, not a surgical candidate according to imaging, but we need a tissue diagnosis. And we know that ERCP with brushing is unreliable. And you can see how easy it is to pass your side view, your slim scope. So you don't even require dilation because there is no stricture, and as soon as you deploy, the stent expands in these patients because there is no stricture that is compressing on the lumen of the Axios stent. And once that's done and the scope is passed, you see a bile duct mass, a mid-common bile duct stricture that is seen. And then you perform your fine needle aspiration, and then once that is done on rampant on-site assessment, this was proven to be adenocarcinoma. And now, since the same manufacturer, Pentax, has got a slim ERCP scope, once again, there is no need to dilate the lumen of the Axios stent. You can pass your ERCP scope, identify the papilla, and then cannulate, and you can place your 8 millimeter stent without any difficulty in this patient. So the slim scopes, I think, are very useful in our math in about 1.15% of patients. So if you ask me how will you narrow it down, I think in centers that have provide high oncological services such as cancer institutes, and for centers that cater to a lot of bariatric population, which we do in the southern United States, the slim scope is important because these are referred cases, and I think we should be able to manage them. And if you can procure the scopes, then I think we can perform 95% of the procedures without any problem. So this will be a useful addition to quaternary centers that specialize in cancer patients and for patients with bariatric diseases and other complex pathology. So thank you.
Thank you very much, Shyam. So it's sort of lunchtime. Is any questions? I think people are anxious to get to lunch, and I guess you're anxious to get to breakfast, John.
Okay.
Yes. Oh, sorry. Question. It's Matt.
So we see a shift an approach in the U.S. of using slim scopes, either a slim echo endoscope or a slim duodenoscope on all patients, unless you know you're going to do something more involved with that particular patient. Do you see yourself doing that? I know you can pass up to a 19 gauge needle in the slim scope. Do you see you using that slim echo endoscope more often, and then just using the larger therapeutic scope when necessary? Sort of that pediatric colonoscope approach to general GI. You know what I'm talking about?
Could you hear that, Shyam?
Yeah, very, very well, actually. I mean, that's a very good question. So that is true. I mean, we've got 2 slim scopes, and we've got about 3 or 4 regular scopes. And I don't, I expect my technicians to give me a slim scope in all elderly patients over age 80, all pediatric patients for sure, patients with gastric bypass anatomy, patients with esophageal stricture, patients with gastric outlet obstruction. So these are 5 indications, and that unfortunately covers a large number of your patients undergoing EUS. If you ask me, if you've got 5 scopes in your Pentax room, and how many you want them to be slim scope, I would prefer them to be at least 3 or 4. I want a regular scope, your regular EUS scope, only for performing therapeutic interventions, primarily for placing an Axios. Otherwise, I think the slim scope is a fantastic scope. It might be a little unsteady, but that is my go-to scope. And your analogy with comparison with a pediatric colonoscope is very, very true. It's very true. The slim EUS scope is indispensable. My partners don't use Pentax, but when they have these patients, they preferably come into the room only to use the slim EUS scope for these kinds of indications.
So I can tell you we have, I think we have 11 scopes. We have 10 linear, 1 radial, and I think we have 5 slims and 5 therapeutics. And basically in the list in the morning, I look at what cases absolutely need a therapeutic, so anybody who has jaundice or something like that. But basically I use the slim scopes until we run out, and then use the therapeutics once there's no clean slim scopes. So it's become, yeah, it's true, it's become basically the workhorse for us for just basic US. I do find that 19 goes through, but even for neurolysis, for some reason I still prefer using the therapeutic with a 19 gauge needle. It's just a little bit easier to manipulate. And as I say, in patients with strictures, esophageal strictures for sure, I use the slim. But for duodenal strictures, I actually prefer the therapeutic, because a lot of those patients have a somewhat dilated stomach, and the slim can be a little floppy. And so I actually prefer the therapeutic to get really into that stricture and be able to image it properly. Any other comments? Valerio, any comments on that?
In our experience, we have both. We have the therapeutic and the slim. If I have the chance, of course, I prefer the therapeutic channel, even if I just have to put a plastic stent, but I can inflate and suck before better. But in particular situation, that millimeter made a difference.
The bottom line, though, is even the therapeutic scope is actually quite small now. But as you say, the patient population we have is older and older, and it's just an easier scope to use, particularly for intubation, getting around D2. You get a bit of a better view of the papilla as well, because you can back away from the papilla a little more than with a therapeutic scope. So for that as well, it's quite interesting. It is a little bit less stable in the bulb. We don't use a balloon. But still, even though it's less stable, it just takes a little bit of getting used to. But once you're used to it, it's really not an issue. Any other questions, comments? John? So I think we're pretty much right on time. And I will thank our speakers for their fantastic presentations, and everybody else for being here. It's a long day. And I hope everybody got something out of this, and we'll look forward to another exciting afternoon of live cases. Thank you very much.
Thank you, guys.
Thank you. All right, so I think the live is starting again. I am assuming somebody will show up and tell us what to do. Live connections. Yeah, at 2 o'clock the live should be starting in about 6 minutes, so people can have a little bit of a walk around, and then I guess it'll be starting quite soon. I have no info though from the bosses. Definitely, definitely. But you know, I'm thinking, you know, as I come towards more of the second half of the career, I should maybe try and get
Hello, everyone. I'm Wafa Hanoussi from Morocco. I'm very happy to be here today to share this wonderful session. This is the last session of our extraordinary EUS complications journey. It has been very impressive, the talks, the videos, the procedures, and the life. So we will talk with this session about EUS-guided fluid collection drainage, and we have three outstanding experts with us today. And I will call the first expert from Spain, from Compostela. And Jose, it's your turn to talk about EUS-guided drainage. Jose Lariño.
Thank you for the presentation. Good afternoon. So the topic of this year at the EUS is the complications of both diagnosis and also therapeutic EUS. And I have to recognize that when Paolo proposed this topic, it was a great challenge for me. And this was a great challenge not because of the fact that we are not having complications in our daily clinical practice, that of course we do. The problem is that when we are in the middle of a stressful situation, in the middle of an interventional EUS procedure with complications, we are not always recording all the things that are happening, and we are not taking all the pictures to document the case. So these are important measures that we have to highlight, that we should record, or we have to record all these cases of interventional EUS in order to document well the case and to try to solve this complication. Anyway, I would like to present you a case that is a very simple and stupid case of a misdeployment of a lumina pouching metal stent. The misdeployment is a complication that is not so uncommon as you can guess, and is published about 2% of the cases when we are draining an EUS-guided pancreatic collections are related with a misdeployment that is affecting the technical success of the technique. And this was a case that we have in the past, in a few years ago. And perhaps the most important point that I would like to highlight here is that this case took place during a meeting, during a live demonstration in the context of a Spanish meeting that we performed a few years ago. There was a case of an infected necrosis, or a supposed to be infected necrosis. And the first point is that the moderator of this session was pushing me all the time in order to rush with the procedure. So we lack of time. We have only 2 or 3 minutes for doing the drainage of the collection, so please rush with the procedure. And so we went directly to the point to drain the collection with the lumina pouching metal stent. You, of course, know that device, that is the hot access stent, that we decided to drain with lamps of 15 millimeters in this case, because it's not a huge collection. And so the first pass of the first step, that is the perforation inside the collection, all the things were doing well. We hadn't got any kind of problems. And we deployed the proximal part of the stent, as you can see here, inside the collection without any kind of problem. And then we, to deploy the intrachannel, the proximal part, we are going to do the position by removing the stent. But at this point, here start all the problems to me. And at this point, I didn't know what was happening. I didn't realize what was happening, but I wasn't able to deploy the stent. And I became a little bit nervous because I didn't know what was the reason for that I wasn't able to deploy the stent. I remind that I was answering a lot of questions. I was talking a lot with the audience, talking about the design of the stent, talking about the indications for doing an EUS-guided drainage. And the fact is that when I was talking, I wasn't able to do the right position to deploy the stent, and I was all the time pulling back with the inner catheter, trying to deploy the stent. And I forgot a simple and stupid thing, that it was that I didn't deploy the stent. So I didn't apply the 4th step of the device in order to deploy the stent. And when I was pulling back with my inner catheter, I finally brought all the stent in through the stomach. So this was a completely a disaster. This was a mess. I was completely embarrassed with this situation. I was completely ashamed because the technical success was affected, and the procedure was completely a disaster. So the problem is that I had to fix it, and I decided to, okay, I'm so sorry because of this situation, and I removed the stent of the stomach, and I decided to place another stent. And for this, we didn't use the same hole because we have some blood in the stomach, so we decided to make another access, another approach, and off the record, we decided to replace the stent in this case without any kind of inconvenience. It was a very easy
as you can see here, and in the left side of the picture, you can see how the purulent material is coming back through the stomach without any kind of problem. But the problem here is a single and stupid thing, that is, if you are not deploying the stent, it's impossible that the stent is going to be deployed. So please, one of the most important things when you are, and this is one of the most important conclusions or take-home messages that I would like to highlight when we are doing interventional EUS procedures at all the time, is please, we should be very concentrated in the things that we are doing. So the life of the patient is more important than the live demonstration. So please pay attention when you are doing an interventional EUS procedure, because if not, you are going to have problems. If we have problems, or if we have a complication, please don't get panic. You have seen a lot of procedures today about complications that can be solved endoscopically. And in this case, of course, the majority of the things that we are doing and we are performing, the mistakes that we are committing endoscopically, can be solved in an endoscopic fashion, as you can see very well these days. And this is the main important conclusion. We should try to fix endoscopically the problem whenever possible. And if this is not possible, we have also the surgical team in order to help us. Anything more? Thank you very much. Any kind of question or commentary about this topic? Thank you.
Any questions from the audience? Extraordinary presentation. Thank you, Jose.
Thank you.
Very humble, very honest, very to the point. I think it's very important, as you said, to keep your concentration and focus. Sometimes in the room you have other people, you are training other people, and a lot of questions around. So to isolate yourself and keep the patient in the center of all what you're doing is very important. Thank you very much for this message. Okay. And respect the steps of deployment of the stent, as you said. I had some questions maybe, just regarding the size of the stent. You used 15 millimeters. Maybe this is not the topic here, the complication, but just a question. How to decide? Is it 20 or 15? It was a necrotic collection and the fluid is very thick?
Yeah, we do usually use 20 millimeters in all the cases, but this case the collection was not so high. The patient was an outpatient care, was without fever, was very well, so we decided according to the size of the collection that is not more than 4 centimeters, and the availability that we have in that moment, we decided to place a 15 millimeter. But a message, an important message, is always in infected necrosis, 20 millimeters is the best one, of course.
In order to perform necrosectomy maybe later on. Of course. Okay, perfect. Any other questions from the audience? Thank you very much, Jose. It was an excellent presentation. And we move now to the next presentation with Professor Seichan from Cluj, Romania. And he will tell us more about complications of fluid collection drainage.
Thank you for the kind invitation. The next, I will present 2 cases. The first one is quite easy, but I will start with the risk of bleeding as side effects when we drain pancreatic fluid collection. And in the literature, the percentage is up to 5%. Before it was told that it's up to 10%, but now the last publication, last meta-analysis says that this is the level. And we should pay attention. In the first week, it could be an early bleeding due to the touch of the parietal vessels, and that's why it's important when we pick the place for placement of lamps to have a distance at least 1 centimeter is the ideal, and we should be very careful because sometimes we have collateral circulation. And the second situation is the one which is the delayed or late bleeding, which occurs when the vessels around the collections could be affected. And in this situation, the best solution is the arterial embolization. And this is the first case. It was a patient, a male with alcoholic pancreatitis and with this kind of bilobar pancreatic fluid collection at CT scan. And after we placed the lamps, we had to go, due to infection of the collection, for necrosectomy. And during necrosectomy, what we saw, it was this parietal bleeding. You can see that it's important quantity of necrosis. It was below the collection, so we still have a cavity after this part, after this first part. So we tried to stop the bleeding, because otherwise the quantity of necrosis increases over here. And what we did in this situation, we went for local coagulation by using old probe monopolar coagulation 30 watts, and everything went well, and we could continue our procedure, and everything went well. The LAMS was removed several weeks after, and this was a very rapid, elegant situation. Sorry. I'm sorry, but I cannot move. And this was the last part of the patient. The second case, it was a very interesting case. It was quite the opposite of what Jose presented before. In the literature, there are 28 studies showing that 2% of misdisplacement could happen, and it's more likely to be into the distal flange than in the proximal flange. And the treatment is also an endoscopic treatment. We should refrain ourselves to call the surgeon. So this was our patient. As you can see, it was a huge, large collection, necrotic collection. The patient was septic with important level of leukocytes and CRP, so he was very, very sick. In this situation, we decided to go for LAMS drainage, but we said, oh, it's better to have a 20 millimeters LAMS here. So what we did, as you can see, if you can see the first movie, we opened the LAMS, and for the distal flange, everything went well. But for the proximal flange, we tried to deploy it. It was inside the working channel, but we could not succeed. So I pushed too much, a bit the catheter, the electrocautery inside. And as you can see during the movie, it disappears, the image in a way. So I tried to push a bit, and I pushed too much. So here you can see there is no LAMS in the view, in the US view. So in that moment, I knew that I was inside the cavity with all the stand. So what I did, I decided to put a guide wire, and on the guide wire, we dilated to 20 millimeters, because the initial diameter was 20 millimeters, because the patient was very sick. We had to solve that patient in the same day. So this was the endoscopic view. It was a long procedure, because you have seen the cavity was a complex weight of necrosis, and we went in this direction and we looked for the LAMS, and it was nowhere, and it was so much pus and necrosis, we could not find it. And I realized that the LAMS was just beyond the wall, so I came back, and here was the LAMS. And we tried I wanted to push it out. And first of all, I repositioned it in front of the opening. And as you can see, the first, I couldn't pass the opening, the stoma. Then we changed the device. We looked for the largest snare that we have. You will see immediately. And with this one, we tried again to go out with the LAMS. It was 20 millimeters, so it was not very easy. We had some bleeding, of course, because life is like that. So, but it was parietal bleeding, and we said it's no problem. We can fix it by coagulation. We tried to go out. We did not succeed, as you can see. It was impossible for us, although I wanted to have only the proximal flange and not in the middle of the LAMS. I could not succeed, so I said this is the last attempt. I have to do something, and everything happened in about 8 minutes. And you will see that finally we succeeded to push it out. And the geometry, hopefully the geometry of the lamps was intact. And you can see that inside the stomach we had a lot of pus and blood, but we continue with the necrosectomy and washing the cavity the same session, and everything went well. The patient had 4 more other sessions of necrosectomy in the next few weeks, and after 4 weeks we removed the stent and we put pigtail stents, and the CT scan done 3 months later was very, very good, and we were very happy with the outcome of our patient. So, dear colleagues, everything cannot be done by one person. I have a large team. I have good colleagues, good friends, good nurses, and thank you very much for your attention.
Thank you very much, Adiada. Impressive demonstration. Any questions from the audience? The collection was impressive in terms of size, and it was 4 weeks after the onset of pancreatitis. How far was it?
Yes, yes, 4 weeks. Yes, but the patient was very sick, was with fever, high CRP, leukocytosis. It was
all around the pancreas, actually. It
was
completely around the pancreas.
Exactly.
Okay, excellent management. Okay, thank you very much. If there are no further questions, we'll move to the next presentation. Michel needs no introduction, so it's up to you, Michel, to tell us your experience with the EOS drainage, collection drainage.
So I'm going to present a case that happened during Skyline. It's a real-life case. And, you know, 80 to 90% of the fluid collection, 80 to 90% of the fluid collection we drain, they go very well, you know, especially now with the device we have, the Coterie Enhanced Lumina Post-Middle Stand, etc. So it's actually interesting to see the cases that don't go well. They are the minority of cases, but those things happen. So this is the case that we did during Skyline, and things didn't go exactly as we wanted. It was a patient that was referred to us from another institution with pretty nasty pancreatitis, had a developed fluid collection. Fluid collection took some time to become mature. At the beginning, it wasn't very mature. We just started the patient on enteral feeding, and I want to show you the CT. Let me see where I can see the CT here. There it is. That's the CT. There it is. So you can see it's pretty big collection. I think the big problem is the CT that we had was without contrast. We should have repeated the CT, but the patient didn't go so well. By the time he got to us, he was pretty septic, so we decided to drain him pretty fast. Enteral feeding was started, as I said. So by the time he became sicker, it was time to drain him. So you can see here by EOS, it's a pretty nasty fluid collection, and the big problem with those fluid collection, the wall, as you can see, is actually pretty thick. So those are the kind of cases, but you want to really first access with a needle and get a wire, because if you try to get the access directly in a difficult position, you may be pushed on the side, and you can go sideways. So those are the few cases what we still do with a wire. And it's very important to have a nice wire, and then you can then follow, you see, with the hot axios over the wire. And you can see here, we're really having a hard time going through the wall. The wall is extremely thick, and you can see we're struggling. You know, we pull in the wire, we try to advance the more we can, trying to get a stable position of the axios into the fluid collection. And we start realizing that we underestimated the wall of the fluid collection. And here I don't know if you noticed, we're starting to open well, this is not what I wanted to do, obviously. We started to open the lamps, and you can see it doesn't open fully. So that is a sign that you either still within the wall, or you're in so much debris that the LAMS is not opening. There's only two solutions there. There's nothing else. It's either you're still into the wall of the fluid collection, or if you're really bad, with a bad luck, you're in the wall of the stomach, or you are in the fluid collection and you're dealing with so much debris that it's not gonna open. So this is where you don't wanna lose that wire. That wire is your safety net. So it's very important to remember that. And this is where, you know, what you want to do at this point is you gotta keep on going. You're gonna deploy the second flange, and you're gonna keep access with the wire, and that's exactly what we did. So you see here we deployed the second flange in the stomach, and we're still not satisfied with the decompression. So this is where you want to dilate. So here we are placing the dilation balloon, and we're gonna dilate. Here it is. This is a dilation. You can already see the angle is not an optimal angle. And this is where we realize that that wall wasn't as clear as it was. And looking at the relationship between where the axios is and where the liquidy part of the fluid collection, it's clearly that we were at the very periphery of the fluid collection. So it doesn't matter, at this point you're committed, you have to dilate. So we're gonna dilate. And so remember, this is going on live, we're transmitting during Skyline. Here it is, the dilation is done. We are gonna remove the balloon, and you see we start noticing a little bit of red material coming out. So we're not very happy with that, obviously. So this is where you have to make sure that your anesthesiologist is doing okay. You know, you have to ask him if he's fine. And the way we deal with this, if you go back to the original literature, is to do a balloon tamponade. This is what the people that trained us used to do. Like they will put a balloon in the tamponade. Well, we just dilated, and we know that we are at the periphery of the wall, so we decided to directly place another stent through the stent. So the idea here is, by placing another stent, an esophageal stent, the radial force that we're going to create will be much stronger. So whatever vessels are in the vicinity of that fluid collection, we should be able to control better and tamponade with the stent. So the balloon is not going to do the job here, we just dilate it. So the other thing is, we need to get deeper into the collection. So that is an obligation, because by going deeper into the collection, not only will we be able to drain the infected materials, but we'll be able to realize a better bridging, because a stent that is stuck into the wall of the fluid collection is not going to do anything. It's going to keep on bleeding. It's going to probably facilitate an infection. But if you stand the stent and get deeper into the collection, two things happen. First of all, you're going to obtain finally an efficient drainage. And number two, you're increasing the radial force at the level of the axios, so you can finally control the bleeding. So you can see here we are really struggling to get a nice wire to be able to deploy the TTS stent. When you place a TTS stent, it's a very stiff stent. The delivery system is not at all flexible. So you really need to have a nice wire to be able to deploy this, because otherwise you're not going to be able to advance your stent and deploy it. That's probably one of the biggest problems of placing a TTS stent in those situations. So you really need to struggle to get the best wire you can. So you see, this is what we're doing here. And then finally, you can advance the stent deeper, and you can start deploying. And only then, when you have a deep deployment of the stent into the fluid collection, bridging the stent all the way into the stomach, you have successfully realized the two things that we couldn't achieve from the beginning. One, appropriate drainage of the fluid collection. Two, tamponade of those peripheral vessels within the wall of the fluid collection. And this is the kind of thing that we need to remember, specifically when we're dealing with those kind of problems. So you can see here, we struggled with quite a few to get that wire the way we want it. But eventually the fluid collection is so big that we were able to do this. And here we are deploying the stent. And we have achieved bridging. You can see the nice waist at the level of the axios. You can see how deep the stent is. And you can see finally some pus coming out from the TTS stent, confirming the good position within the fluid collection. Here it is. So, as I said, 85 to 90% fluid collection are very easy to drain. Is this little minority of cases that are much more difficult. I'll be happy to respond to any questions.
Thank you very much, Michel. Any questions? Any questions in the room? Maybe the three presenters can come up here, just to keep the discussion. We still have some time. Michel, can you join? Jose? Yes, Adrianda, you had a question, I think, for Michel.
I have a question for you. You said that the best wire you have. Which wire do you prefer?
So typically, most of our access are done with the VisiGlide, because the VisiGlide has this very long hydrophilic part, which we really like to get into wherever we want to be, duct, fluid collection, whatever. That's our favorite wire. But if we have very difficult stents to push, like into biliary tree, we will probably go with the Hydrajack, because the body of the Hydrajack is extremely strong, so it's better to push thick stents. But in this case, it was a VisiGlide.
And for maybe the audience have a question. Meanwhile, maybe Jose wants to say, yeah.
Yes, I would like to ask you, how are you completely sure that the guide wire is in the right position? Because in the video, you remove the guide wire and then introduce again the guide wire. And you know that it's inside the collection. It's not possible that the guide wire is in another place.
Yeah. So this is actually a great question, because this is where you need a very good assistant. So that wire was actually manipulated with our chief nurse, who is an amazing wire person. And she could tell you, I just don't feel the wire. I don't feel where we are. And the fluoroscopy, I don't know if you see, was turning right and left, making sure that we were encompassing the direction of the wire within the fluid collection. So what we can do also, we don't do that often. We didn't do it in this case because, the patient was bleeding, we were going fast. We have the ability to do what we call a 3D reconstruction live by using the different imaging. So basically, we can take the CT, we can take the fluoroscopy, and we can then put them together and create an artificial image combining those two in 3 dimensions. So we could do that.
Do you think that ultrasound machine in the room can help? I use a lot ultrasound in the room, so sometimes when I'm lost, even in the biliary tree, to know in which segment I am, I can use ultrasound just to check quickly.
Yeah, I mean, in the United States, we don't do much percutaneous ultrasound, but I'm sure that it can definitely help. The problem in this case is it's necrotizing pancreatitis. So, the image were not very good, you can see, and the wall, we totally underestimated the thickness of the wall. And this is a very good lesson for the fellow here. We should have got a contrast CT. Like looking backward now, we get the transfer, the patient was sick. We should have just taken an extra hour, get a contrast CT, PO and IV contrast. So this could allow you to see exactly the thickness of the wall and the content of the wall to see if there's any vessel. So you see, you learn from your own mistakes.
For the young EUS specialists who want to start this type of procedures, what would you recommend to keep in mind when you are getting into it? And what's the toolbox that you need to have ahead? Because we have seen the probe, the gold probe, you have it easily. I'm coming from a place where the closet is not filled with everything that you can imagine. So maybe there is a toolbox, emergency toolbox that you need to have. Just once you start doing this type of procedures, you know how to manage each type of complication that you anticipate.
So I always say to my fellows, it's very important to go back to the fundamentals. What are the fundamentals? The fundamental of drainage, any drainage, is a needle, a wire, and a balloon. Those are the 3 most important instruments. You have to be able to place a needle into your target. That is something that is very important, because They are very difficult collection. You don't want to go with a Lumina polymetal stent right away. You won't be able to. It's too stiff. It doesn't have the flexibility of a needle. The wire, if you cannot manipulate and master the wire, you're going to have a problem. It's very important to use wire in our field. Nothing that we want to achieve will be possible without a wire. So mastery of the wire is key. When I was a fellow, my mentor made me spend 2 months just doing the wire. He wouldn't let me touch the side view scope. I was drooling, dying to touch the side view scope. He wouldn't let me. He said, you need to master the wire. And I realize now how much he was right. You need to master the wire, absolutely. And the balloon is very important. The balloon is going to allow you to create, in an atraumatic fashion, fistula, communication, open your stent, bring things that have migrated the wrong way. So mastery of the balloon is crucial. Those are the 3 things that used to be in your toolbox when you travel.
And also for bleeding, maybe the balloon could help.
Yes,
to
absolutely.
tamponade,
Tamponade. I mean, as I said, our mentor taught us when you have a fluid collection that is bleeding to always tamponade with a balloon. Now, let's be clear. If you hit a very big vessel, the balloon is not going to work. You're going to need to send the patient to interventional radiology. So the big question is, this is the question that my fellow always asks me, how do you know that you're dealing with a vessel that you can control versus a vessel that you cannot control? Well, if you have a wire, you have to try to do the balloon. If you have a very big vessel, the balloon is not going to work. You have a vessel, you need to go to IR. You could still try to temporize with the balloon. A really big vessel is going to give you what I call a tsunami. What is a tsunami? A tsunami is when your screen becomes completely red. When you see that, that is a sign you need to call your interventional radiology friends. There's no other way around. You have to accept that. It doesn't happen often. But if you have a wire, do not lose the wire and use the balloon to tamponade.
Just at the top of my head, hemostatic powder would not help in any way, do you think? I don't know.
I mean, if you have an arterial bleed, if you have the bad luck of touching a vessel, arterial bleeds, it's not going to work, unfortunately. Venous bleed might actually work. Variceal bleed, there's data on this. And inside a fluid collection, if you have a small vessel bleeding, that definitely can work. But if you have an arterial bleed, unfortunately, the only thing that works is coiling.
And in terms of position of the endoscope, the procedure you have shown us, it's very complicated position. You are not straight. So you expected definitely that's going to be very hard to position the stand, or even the salvage therapy you did was going to be complicated.
Yes.
So I think that having the probe as really straight as possible could really help to
Absolutely.
be comfortable at the beginning to start this type of
Absolutely.
procedure.
And I think in this case, as I said, the wall was so thick and the collection was not as homogeneous as the non-contrast CT fooled us to be. So the endoscopist was trying to basically aim the transducer towards the most juicy part of the fluid collection, because you don't want to get in an area where there's only debris and very peripheral. Your stent's not going to be stable there. So you're going to try to be into the center of the most liquidy part of the fluid collection. This is where you're going to be able to later on come back and do debridement.
Sorry. When did you remove the 2 stents?
So we left this for like approximately 10 days. After 10 days, we removed the 2 stents. We got into the collection. We cleaned up the collection. And then we went back and we placed a brand new, longer, the 15 length Axios into the collection.
Did you have any other bleeding?
Not that day. Not that day. That obviously that was one of our concerns, but that day was a good day.
And you consider it was gastric vessel or a collateral circulation over there?
It's a very good, I think based on the location, we feel that it was from the wall of the fluid collection. And as I said, what we should have done is a CT with PO and IV contrast. This is definitely something we should have done.
Sometimes with wounds, you have a very thick layer of the wall is very thick. And sometimes when you are starting, the cystotome is already freaking you out and you are pushing with the cystotome and you don't succeed actually to get the hole actually done. And do you have any tips? I know that we should really put your your foot actually on the pedal way before, so you heat actually the ring before you get in. But do you have any other tips for the beginners maybe in this?
I think the way I always see it is when you have a difficult access into the fluid collection, you got to go back to the fundamentals. Nothing beat a nice needle. If you have a nice needle and you get it into the direction, in the position that you want, into the collection, and you have a wire, you can do whatever you want. You can advance a cystotome, you can advance the lambs, you can even dilate and place a plastic stent. You can do whatever you want. That's the beauty of gaining access with the wire. So always go back to the fundamentals. Like if you look at all the US Gallup procedure, originally they all start with a needle and a wire. Originally they all start with that. That is the fundamental. So you need to really, as a fellow, one of the most important things is you have to focus and try to make sure that you always see where you put in that needle. Like my fellow always say, oh, it's just an FNA. I said, no, this is not an FNA. This is an opportunity for you to understand how to put the needle exactly in that spot and see the tip of your needle. Because one day, you want to put that tip of the needle into a pancreatic duct that measures 2.5 centimeters. So every FNA that you do is an FNA that's going to allow you later to do a more complex procedure. See it as a step-by-step procedure. Every procedure you do by US is going to make you stronger and better for the most complex procedure.
We have seen a lot of complications for lamps. Any complications that you have experienced maybe with plastic stent, double pigtail plastic stents for pseudocysts or other types of drainages?
It's very rare to have major issue in terms of fluid collection with a double pigtail. So whenever you want to place stent in the fluid collection is a double pigtail. The double pigtail act as a buffer. Like we have to use it actually in most of our fluid collection, because when the fluid collection is collapsing, you don't want the wall of the fluid collection to rub against the metallic part of the lambs. So we like to place double pigtail to act as a buffer. So it's extremely rare to have issue like that. Now, if you push a double pigtail against the wall, and there's a small vessel, you're going to have a bleeding. That's going to happen. And those bleeding typically are not major bleeding, so they should be fine. Another time when you should worry about bleeding is when you're using hydroxyl peroxide that hasn't been diluted. So you always have to make sure, and you have to talk to your nurse, if you want to use hydroxyl peroxide, it has to be diluted at least 10 times. Because if you use hydroxyl peroxide into a fluid collection that is not dilated, you're going to have a lot of problems. So always double check. It has been happening more often than you know, where a nurse forget to dilute the hydroxyl peroxide, and then you have a disaster.
Any other comments or tips you want to share with the audience? Okay, any question in the room? I don't see any hand raised. Okay, thank you very much for this excellent session. Thank you.
Thank you for having us.
Thank you very much.
It was a good session.
Andiamo, dai. Okay. Mettiamoci. Dai Daniele, su. Oh, okay. Here we are. Good afternoon, everybody. We are ready to start the last session of this EuroUS 24. So we start from here, from Milan, and then we will move to other hospitals along our journey through Europe and USA. So the first case that we are going to present is the case in room number 5.
So the patient is an 82-year-old male. She was admitted in November 2023 for onset of a slight abdominal pain. He underwent an abdominal US that noted dilation of the main pancreatic duct, an abdominal CT scan noting an endoductal alteration of the pancreas head with a dilation of main pancreatic duct, 50 millimeters. He underwent an US that found in the pancreatic head a small apoechoic area of 8 millimeters in size with contrast enhancements after injection of contrast agent, Ilsonaview, with dilation of main pancreatic duct. The cytological examination was inconclusive. The blood test was normal. Here we can see the dilation of the main duct of pancreas. Today's procedure, US plus eventually FNA, the operator, Professor Sahai and Professor Iglesias Garcia.
Hanan?
Hello.
Here we are.
All
so,
right.
how it looks like? A nice case to do?
It's a very interesting case, like all the U.S. cases. Okay, so again, in all these cases, I find the pancreatic duct dilation are probably the most interesting cases.
Yeah.
Because the CT never really shows what's going on, you know. So unexplained PD dilation is always quite interesting. So I always start the same way. I start at the liver. The pointer is here. Okay, I'm gonna be in the middle of the liver. I'm gonna torque with my left arm. So the vein is disappearing, but it should reappear under here somewhere. And this pointer is not very mobile, okay? But I'm just gonna keep torquing. Okay, so the vein is here. Then here, this is the pancreatic duct.
Yep.
It's a very large pancreatic duct. It's very suspicious, if you ask me, looking PD. Some people get much more pancreatic duct dilation with malignancies than others. And when you have a very large duct in somebody with an obstructed looking duct at the same time, you can always suspect a malignant transformation of an IPMN, of a main duct IPMN, okay? So whenever you see a dilated duct, you have to find out why it's dilated, okay? You have to follow the duct to where the dilation starts. So I'm going to try and follow this duct backwards here and go back around the genu. I'm not getting a great view into the head of the pancreas here, but you can see that the duct is dilated all the way around the genu, okay? So this is a system, this is a limpid system. I'm not really super used to using this system. So I'm going to go into the bulb. So the second station, into the apex here, go left, look for the portal vein, okay? And I'm just trying to stay in the apex. So I think the vein is under here, and then, sorry, this is the vein, and then this is the PD right here, okay? So I'm going to follow it to see what happens to it. And see, it just disappears. Right here, it just disappears. And usually, in the easy cases, it disappears and you have like a mass. This guy, it disappears and there's nothing. And you have to be careful. Sometimes people like this, they will have a small stone that is really hard to see and that they never see on the CT. So when I get here, I look, and what I try to do is I also give it a little bit left on the left-right, because sometimes the stone only shows up in certain perspectives, you know. So it can be hard to see in a standard. You have to kind of just look and carefully just try and look. But I'm looking here and I'm not seeing a shadow. Sometimes all you see is the shadow, and then when you work on it, you finally can find the stone. Like I'm wondering, like right
That
here,
white
see?
spot there.
There's a little bit of maybe a calcification right here, okay? I'm not 100% convinced, okay? So here, yeah, but see, you look at this stricture, like, I'll tell you right now, in a case like this, if you don't see a mass, you might want to still biopsy just where the stricture is, okay? But in this case, there's no mass at all. So now I'm going to take another look at it. I'm going to go into D2 and get the view coming back from the papilla. So this guy, you can see that his pancreatic duct is not dilated down to the duodenal wall. So we're not going to see a fish mouth papilla, okay? We're just not going to see that. So I'm going to shorten up.
You try to see the papilla to see because how many times have you seen the fish mouth pattern in an IPMN?
Yeah. It happens. It happens quite a lot. But at the same time, it's surprising how many clearly main duct IPMNs, you know, it's not a complete fish mouth. And you can also see the fish mouth by EUS as well, right? Because you can see in a fish mouth, you can see whether the pancreatic duct is open right to the lumen. Now, look at this guy. So this is really important here because now I'm showing you that his pancreatic duct coming out of the papilla is basically normal, okay? So it's coming back here. So I'm going to try and follow it back to where this dilation starts. and see if now from here, now where's the focus on this? The focus is way down. Can we move the focus up? Can I use the non-smart focus? I just want to get it more. So I'm trying to really so from this view, see it just gets really it gets really dark all of a sudden. This is where the duct starts getting dilated. So I'm really trying to focus on this area right here where the transition zone is, to see if I see something that I can biopsy. But you see the duct is normal, normal, normal. It's still normal. Still normal, like here, okay? And we still haven't gotten to the dilated duct. Still normal, no dilated duct, coming back. The problem here is I'm getting to where I'm going to fall into the stomach. You can, by the way, see the long view of the bile duct up here, okay?
Yeah.
This is, with the linear scope, this is how you get a long view of the bile duct for the stones coming back from the papilla. So still gently pulling back, looking for this trend. And see this, there's a little zone here. Right in here, I'm starting to see maybe a shadow. Maybe I'm just trying to make myself happy.
That seems the place where it starts the dilation.
Yeah, and then you can, So now you can see there's a tape, there's a stricture here. The lumen is kind of almost still there. The resolution here is not, oh, and now I slipped into the stomach. Okay, but now I'm still in a position. So here's the stricture, okay?
Yeah.
Right here. It's kind of actually a tapering stricture, but there's nothing in it really, okay? So we could definitely biopsy here, okay? But in a case like this, my feeling is that it's probably better to do, a brushing by ERCP. If I biopsy here and then I give him pancreatitis and bleeding and blah, blah, blah. Here, maybe even just a pancreatoscopy to see what's going on right here. But now with this finding, okay, and the appearance of his duct, this seems like it's a really chronic stricture that he's had, for years and years and years. I don't know if I can't remember, he had symptoms, this guy? He had pancreatitis or abdominal pain? Okay.
Do you think here, and I'm sorry, that in this part of the PD you see like a little bit of enlargement of the wall, or is just because I want to see?
I think this is just a normal. I mean, it could be maybe a little bit of thickening there.
I mean, just in the transition.
I see what you mean. It could be the walls are getting a little thickening. Yeah.
And then becomes the abscess.
So
this was a stricture here.
Yeah, and it could be like an autoimmune something like that. You get the railroad track kind of signs. I think we're kind of at the limitation of the resolution of this system. Okay, but it's like, to me, it would be very surprising for a malignancy to give you this big a duct with such a small lesion, But at the same time, we've had cases of patients who had really suspicious-looking lesions, ductal obstruction, multiple biopsies, always negative. Then on the 5th biopsy, they come in and they have liver mets.
Yeah.
So,
Anand?
Yes.
Julio? I asked for the two of us, of you. I know the answer by Anand. Do you think that in this case, sonoview or elastography could be of any help to determine if this area that you show perfectly with this suspicion of thickening of the wall could be?
This could be the only case where sonoview is useful.
Look. I get the point. I will.
You are so polite, and thank you very much.
No, I don't care. Let's do it.
I think some of you may help. The problem of elasto in this case is that we need to do elasto with the tube in the middle. So whenever we have any kind of tube, any duct with any content, liquid content, elasto is going to be a misunderstanding. And elasto is very good for solid lesions and for diffuse disease, for chronic pancreatitis. But if you want to focus on an stenosis in the PD, when you need to have the PD in the middle of the evaluation, there's going to be a lot of artifacts. So I don't think this is the role for elasto, but I believe this is more the role for contrast to see if there is any kind of different uptake.
Let's do it. But you can almost see the lumen is almost still preserved even right into the stricture. But this is, I'm saying, so what I'm saying is, if this was a young person, you know, I would do the pancreatoscopy, whatever. But if it's negative, I think you have to give consideration to surgery anyway, because these things can become malignant with time, you know, and it's just a consideration. I've seen at least 2 or 3 cases that, you know, sort of suspicious strictures that one day just all of a sudden were like metastatic, you know. So if you want to do the contrast, we're in good position, I think, anyway, you know.
So
I don't want to move because it's kind of an unstable position.
Okay. Okay.
Anand, Andrea from the auditorium. Just a question, because
yes.
Do you think that there is enough evidence for sending this patient for a pancreatectomy?
There's no evidence. It's completely anecdotal. But certainly somebody who's, I mean, I think probably for sure, there's still some work to be done here. You really have to do the maximum to, what do I do? To diagnose, to exclude a malignancy in this stricture. My suspicion, as I say, is that this is not malignant at this time, but this is the kind of thing that can become malignant. Just one day, it'll just become malignant, you know? So that's what I worry about, but I have certainly no data to justify just routinely doing that. But I think it's something that should be discussed with the patients. The problem here is you're looking at like a Whipple, you know, which is...
We go for the contrast now?
Yeah, I'm trying to keep it in view.
Yeah.
There.
And we will try to focus with the arrow in this area here. This is the one that is doubtful.
Yeah.
So let's see what happens. So if it's thinking on a malignant, we should have some hypoechoic area here. And if everything uptakes homogeneously contrast, we can theoretically more in related to thinking on an inflammatory process. But the problem again is that we need to see not really the mass, but the behavior of the duct, because we can see if there is no uptake, of course, as we expected in the PD.
Yeah.
But it's quite difficult to understand what is going on in this tiny place here. But it seems, Sanan saying here, this ductal area here.
That's why I lost it a bit.
But it's very...
I sort of, okay, I'm just trying to get it back in view, sorry. It's a bit of an unstable position. There.
Yes. Well, this is very complex to try to interpret it.
And also we're losing all the image below.
Yes, below. So I think there is uptake in the wall. If uptake in the wall, it's more related to if we trying to exclude pancreatic cancer, that is the idea. It should be an hypovascular pattern here. And we see there is a little uptake in the wall, so there is very more linked to an inflammatory process, as we were discussing. But I think it is not helping as much as we would love to.
This is the one case where contrast wasn't helpful.
Yeah.
Okay, so I personally wouldn't do a biopsy here. If you want me to, I can try, but I would recommend more doing it by pancreatoscopy or something. I think it would be safer and actually more, you know, just more really more helpful. You know, more to really look at the stricture, see what it looks like from the inside.
But it's great how you see the stricture.
Anand?
Yes.
Julio?
Yes.
Yes.
We are wishing you to perform what you think is better for the patient. So if you are not going to biopsy, for us, it's okay.
Yeah, and you can really still see the lumen, just a little bit of lumen. So I would not biopsy, and I would recommend the pancreatoscopy.
We are going to discuss multidisciplinary team this patient, and then we will decide how to deal with it and the next steps.
And Paolo, Anand, really, are you interested in the opinion of the auditorium? How many would perform?
Always.
How many of you are going to perform FNA or FNB or just follow up? For FNA, raise your hand.
Not follow up, just discussion and then maybe another approach.
So how many tissue sampling? Please raise your hand. Few. How many just discussion and?
Just discussion.
Of course, a few of them.
It's nice.
Just coffee and discussion.
I agree with Hernandez. I think probably with the pain, it's an ERCP, brushing, probably stenting while we discuss.
Okay. So thank you very much. It was a fantastic,
really nice case.
And
interesting.
Fantastic demonstration how to deal with
that. Thank you very much.
You're welcome. See
All right.
you. Bye bye.
Everybody.
And we go to room number 7.
Next case is a 56-year-old female. She was admitted to the ER due to a new onset of jaundice. Abdominal CT and MRI scan revealed diffuse dilation of the intrahepatic ducts associated with multiple intrahepatic stones, and also a dilatation of the common bile duct upstream of a lithiasic aggregate of 2 centimeters located just above the cystic duct. The gallbladder was regular with no stones inside, and also the pancreas was regular. We are going to perform a US with ERCP and eventually cholangioscope-assisted lithotripsy. Operators are Professor Calais and Professor Schall.
Michel?
Good afternoon.
Good afternoon.
Yeah, thank
Can you hear us?
Yes.
Perfect.
Thank you for having us again. I'm very excited to have this fabulous team with me. I feel, as I said, I'm flying on first class, not business, but first class. So not only it's first class in terms of team, but in terms of examination. So we have an MRI showing most of the details. You know, there's a lot of places where all you have is EUS. And so here I am, I'm doing really the fundamental of EUS here. I inflate the balloon, and then I'm floating myself into the small bowel from the bulb going down. Patient is coughing. Yeah, the patient is coughing. Can we give anti-cough medication, please, for the patient? And so you can see that once you inflate the balloon, the vision in the vicinity becomes really, really clear, you know. And here I am. I think we need to first make sure the patient stops coughing. So here I am into the small bowel. I'm turning the small bowel very gently. Patient is still coughing. Okay, we're going to aspirate the patient. Always make sure the patient is stable, airway is under control, saturation fine, blood pressure. You know, most EUSs, diagnostic EUS, can be done under, you know, gentle sedation or maybe a little bit of propofol. I think if at any moment the patient become unstable or you have issues, you need to secure the airway. So that's very important, you know, to work with very strong anesthesia. Here we have 2 anesthesiologists making sure the patient is stabilized. In the meantime, I'm going to help them. I'm going to suck the stomach, try to get rid of as much possible of air. Those are basic maneuver that we have to do as advanced endoscopists so that, you know, patient is stable, anesthesia is happy. Because if anesthesia is not happy, then you are in trouble. So you tell me when you guys are comfortable. Are you guys okay? Yes. You're good? Okay. So anesthesia is happy. Now I'm going to go back very gently. So I'm going to do the floating technique. Here I'm entering and inflating the balloon very gently. And then with the balloon inflated, here it is, I'm inflating it. My vision is going to become much better. Remember, air is the enemy in the US. Water is your friend. You know, a balloon full of water going to help you a lot. Sometimes you have to actually flush water into the small bowel to look at lesion, etc. We won't need to do this here, luckily. So here I am, very gently, trying to position myself. Reposition myself into the small bowel. A little bit too much of a balloon. Here it is. So you can see now, you know, facing my transducer with the balloon inflated, you know, what is probably the common hepatic duct here. I'm going to try to follow it down all the way to the common bile duct. Here it is. You see there's something in that common bile duct, tiny little stone. You know, there's nothing much there, and I'm going to follow it up here very gently. You see, now I'm at the level, I'm getting close to the common hepatic duct here, and you can see that it's much bigger at this level. So that kind of shows, we're almost at the confluence, right below the confluence here. So Giuseppe was saying very appropriately, there's no shadowing. There's definitely a fitting defect, but there's no shadowing. So maybe this thing is a magma of sludge, you know, which will make our life much easier during the ERCP portion of the procedure. Okay? If it was shadowing, then you're talking with the real stone, and then you have to start thinking about lithotripsy. So I was, you know, already thinking if, you know, what are we going to do in terms of lithotripsy? And I think, you know, there's a trend now to resort to spyglass and lithotripsy earlier on, like we used to do it in a pyramidal system, a sphincterotomy, a dilation, a stone extraction, a stent placement, and then we'll come back and we'll do spyglass. And then we reverted the pyramid, realizing that sometimes it's better and most cost-effective for the patient to just be very aggressive from the beginning and basically do lithotripsy right away instead of like, you know, giving the patients many sessions. So I think,
Michelle,
yes.
question. Well, in this case, it looks like all of us, we agree this is a sludge. How can we tell the difference between sludge, because it's not shadowing, versus intraductal mass?
Yeah.
And then if the wall of the bile duct, any comments, can we say if this is inflammatory or malignant?
So I think this is a very, very good question. And this goes back to the fundamental of how does an intrabiliary lesion present. So obviously, if it's a mass, you'll see the mass. There's no mass here. Everything is fine. You know, there's no lymphadenopathy. There's nothing. But if you're thinking about an intraductal neoplasia, typically you should expect at least to see a thickness of the wall of the biliary tree. That is something that is very important. And sometimes if you're lucky enough and you zoom, you can actually see within the wall something growing, okay? And it doesn't necessarily to be a real mass, but just the simple fact that the wall is abnormal should raise your suspicion of a lesion that is cancerous, especially in the absence of inflammation or infection.
Yeah.
Because that's obviously the differential.
And the Doppler.
Yeah, and the Doppler actually obviously to make sure that the vessels are clear. So we can do a little bit of flow here to look at the vessel. You can see the vessels are really nice here. There's really nothing going on with the vessels.
And no flow inside the bile duct.
And nothing is flowing inside the back duct. She's thinking about anything that is vascularized. Oh, and of course we have luxury. Dual, if I don't have that in my unit. Thank you, Giuseppe, for showing me this. Yeah, this is beautiful, obviously. Thank you, Giuseppe, for making this remark. So yeah, as I said, we work in a business class environment here. I don't have all this. I have Elasto, I have the microbubbles, but the file is beautiful. You use that often, Giuseppe, in the unit?
Sometimes, yeah.
So, I mean, unless there's any further question, I think we can proceed with the ERCP at this point.
Michel, just a question from the auditorium. The MRI described a gallbladder with no stones. Can you check for it or see?
Yeah, well, actually, you can see here the gallbladder, and apparently there is something there, you see? So one more time, this shows you, and you go back to those very early studies from the late 90s comparing EUS to MRI. When it comes to finding small stone or sludge or anything, EUS is superior. And this is why in country like, you know, in Mexico, for instance, Colombia, or in Latin America, an institution will invest much more in endoscopic ultrasound than MRI, simply because there are studies that show that those studies are more accurate when it comes to those little details, those little percentage of precision, if there or not a stone into the biliary tree, can you see it, yes or no? This is where actually EUS is probably superior. And oftentimes, when we get a patient referred with pancreatitis, when there's a very, very soft indication for ERCP, what we try to do is start with an EUS. Because the EUS can actually give you the indication for an ERCP in case you're doubting. Those young females you wonder if there's a stone or not. Those pancreatitis that are labeled gallstone, but you're not quite sure that there's gallstone. Those are the best patients that will benefit for an EUS. EUS will guide the eventual ERCP.
And we are going to find in a few moments during the ERCP. But you think that there is a stricture with above stones and sludge, or there's a stone causing an inflammatory stricture in the middle of the Goldman bile duct?
It is a very legitimate question. There may be a stricture right there, absolutely, which might explain why there's sludge being stuck. Why do you have sludge being stuck right there? So, I mean, this is definitely a possibility. And this is obviously a double indication now for ERCP, because not only ERCP can allow us, one, to extract whatever this is, probably some kind of a sludgy material, but obviously it's going to allow us to treat and confirm the stricture that we're going to see on the cholangiogram. So this is really here a very good demonstration of EUS guiding us to do an ERCP.
So Michel?
Yes.
So I think that was a fantastic presentation and the diagnosis of stones in a first-class room with Pentax instrument. So while you are moving the patient prone, then we move to present the next case.
Next case is a 52-year-old male. He had polyuria for several months and weight loss. For elevated glucose levels and confusion, he started insulin therapy. In January, he underwent abdominal US and CT scan, which showed a subsected 26 millimeter lesion in the pancreatic neck with arterial hyperenhancement. Adenomyosis of the gallbladder was also found. At the 68 gallium PET, it was found an intense uptake in the pancreatic neck. This is the imaging. To these procedures is US with the FNA or FNB with the rapid on-site evaluation. Operator are Professor Camusi and Professor Fusaroli.
Hello, Pietro, Professor Camusi, here we are. Can you hear me? Hello, welcome back, good afternoon. Before you start, I just remind the people in the auditorium that they can follow the case in room number 7, the RCP, on the Express channel. So please, now, thank you for waiting and go ahead in your case.
So we are expecting probably a tumor, a neuroendocrine tumor, and the PET gallium 68 is positive. So we have spent a few minutes now with Pietro looking for it. We have a patient with more than overweight, and I would say obese patient, and there is a lot of intervisceral fat, and the pancreas is clearly fatty pancreas. We can see here the body of. We have adjusted a lot the image to be able to delineate the parenchyma, and we can see the parenchyma here. I'll go and scan for the rest of the body and tail and show you. It's there actually. Okay. Okay, so I'm just turning to my right towards the tail of the pancreas, and you can see here the splenic vein and artery and the splenic hilum. It's pretty homogeneous, but very hyperechoic, very reflective parenchyma. We could have seen the MPD in several places, but it's hard to follow in some places. And we were focusing all our attention on the area just in front of the splenic vein here on the neck. The lesion is 25 millimeters in diameter. We were expecting something more hypoechoic, but it seems that we couldn't find a hypoechoic lesion typically as a EUS image of a net. But we are suspecting a lesion here, just in front. Pietro is showing you because he's the one who spotted it. It's not easy. And we were discussing if there is maybe an additional value to have elasto or contrast here, just to delineate better, because it's kind of challenging to see it. It's a 20 millimeter supposedly lesion here, just in front of the splenic vein.
This
20,
this could be a chance.
Yeah.
But before we do any further enhancement,
Yeah.
what do you think if we went down to the duodenum and
We have already
try to
took a look.
take a look completely at pancreas exploration? Sometimes also when coming back from the duodenum with a straight scope, we get a different perspective. I always recommend that both techniques should be used to explore the entire pancreas, both in advancement and in retraction of the scope.
Okay, we are in front of the hilum here.
You're sure you are doing a really complete
evaluation.
It's like when you, in the stomach or in the rectum, evaluate in forward view and in retroflexion. It's the same with the US. You should evaluate while going in and while going out.
So here we are in front of the hilum, liver hilum, and we see some ganglia that have no significant pathological significance, I think.
Yeah.
And we will follow the CBD here. You can see it clearly.
CBD.
The wall is very well
Pancreatic
identified.
duct. Yes.
Biliary pancreatic duct, the biliary. Okay, we are in front of the papilla right now. We see clearly the CBD and MPD all together. So the idea is to complete the scanning of the pancreatic parenchyma. So we have here the head and part of it. And when we are following the MPD towards the neck, hoping to see the lesion. MPD is down there. Yeah, here. Okay. Here. MPD is here.
Pietro, Andrea.
Yes?
Just to make Professor Arcidiacono upset, what do you think in case of the impossibility of finding lesion to switch to a radial scope?
Yes. Yes.
It's a good question. Probably it's the last time I will come in Milan.
Well, we've used the radial scope. Sometimes it's easy to use it in the esophagus and in the stomach. In pancreas, it's sometimes challenging, but it gives us really nice view of the whole MPD at once, almost all MPD in the body and tail.
Yes.
It's very nice view, and the neck we can see it very well with the radial.
It's a very good point, Andrea. I'm glad at least you have taken this from the old generation. By the way,
you are glad just because he had the chance to put this question and not you. But anyway, I think that we have just for this meeting a radial scope, because usually we don't have any radial scope in the unit.
If you want, we can really do that.
But my feeling is that you do not add anything with the radial.
Yeah.
And then in case you find something, and then you need to go then with the linear scope to take the biopsy. So take your time, because sometimes there is no lesion,
So I think we should now, Wafa.
What I was aiming for here is to see the splenic vein again and see around the splenic vein, because we have seen on CT that it's facing actually the vein. And just again to have another vision here. But I can't no.
So Wafa is still doing her scanning through the bulb, duodenal bulb.
You are pretty much convinced with the lesion you have measured before?
I'm not pretty much convinced. I mean, I think you are now completely in the exploration how it should be done.
Okay.
And now...
What do you think about the gallbladder here?
Gallbladder? Yeah, nothing in particular.
I think that there is something
maybe
on the wall.
Some polyp here.
Yeah, there is a small polyp.
Some cholesterol polyp.
And
okay, now the scope is in the stomach again.
Yeah, I'm just
so
following the
we might follow
okay.
the pancreas
we have a
again.
polyp and maybe some... Okay, let's go back to the pancreas from the stomach position, from the cardia. two ways to go to the pancreas for the beginners. It's either through the celiac trunk. You identify the celiac trunk and just move forward. So it's scope pretty straight, and you face immediately the body of the pancreas. Or, this is a beautiful view. We have the splenic vein and the body of the pancreas, and you can move from there, just turning around slightly to see the rest of the pancreas. Or the other possibility is to go to the liver, follow the portal vein, splenic vein, and just there you will find again the neck and body of the pancreas. And that's what we did earlier, but it was very challenging to first identify the parenchyma really clearly, and second to find the lesion we are looking for.
Pietro Canuzzi, we leave for 1 minute,
okay,
and then we will be back.
Okay.
Michelle, go back to room number 7. Michelle.
Okay. So yes, so as you can see here, I was able to get wire cannulation of the biliary tree. I just did a sphincterotomy, and I have all the signs of a good sphincterotomy. You know, I can see epithelium, I see bile coming out. You see, I see air X-ray.
Can we see also the fluoroscopy image in the room, please?
Exactly. So we have air in, bile out, we see epithelium, and there is another sign called the echo sign. When you say hello, hello, it does back hello. And then if I can have the balloon, please.
The large fluoroscopy and maybe small endoscopy, please.
Okay, can I have an extraction balloon?
Can you project this
maybe
first
like
picture,
9
the
to
first
12?
photo picture? Yeah, that one, yeah.
Thank you so much. You see, this is when you have Giuseppe in the room, you don't even need to talk.
So,
it's like telepathic communication.
Michelle, you want to
Yes.
talk about the fluoroscopy image we got the first
Yeah,
time?
so the fluoroscopy image, why don't you talk about it, please?
So, I mean, you can see the distal common bile duct is narrow in caliber, multiple filling defects. Right at the cystic duct insertion, a little bit above it, for about a centimeter, there appears to be a stricture. And then above that duct is again dilated. You see filling defect extending into the tertiary radicals you see going into the left system. So it's an extensive lithiasis, both intra and extrahepatic, with a stricture in the middle.
So, as I was saying, you know.
So Michelle, what's your plan now?
So my plan, I'm gonna first take care of the distal stone, the one that are close to the ampulla. I want to get rid of them, okay, first.
And then?
And then I'm gonna get another injection of contrast and understand exactly how nasty is the stricture and how big is the stone, and then we're gonna decide what will be the next step. Balloon up, please.
Okay, so the audience can continuously follow you on the X channel, and so we move back to present another case in room number 5.
So the next patient in room number 5 is an 80-year-old woman. She was admitted in February 2004 in emergency department for acute abdominal pain. The blood test shows no significant alteration. The abdominal CT scan showed dilation of the main pancreatic duct and mild dilation of the CBD, no adenopathy and no focal liver lesion. The abdominal MRI showed pancreatic body cystic lesion of 29 millimeters in size, associated with dilation of the main pancreatic duct, 10 millimeters, and dilation of intra and extrahepatic bile ducts, 12 millimeters. Today's procedures, US plus eventually FNA. The operators, Dr. Petrone and Professor Saftoio.
Dr. Petrone, can you hear me?
Yes, perfectly. Can you hear us?
I can't hear you.
Okay. So the probe is in the second portion of the duodenum. I'm looking for the mesenteric vessels just now. We have head of the pancreas from left. And now...
Mara, we cannot hear you from the auditorium.
Can you hear us, maybe?
Can you hear me, Andrea?
Not so much.
Not yet.
Okay.
It's on.
And now it's better?
Yeah, absolutely. Thank you.
Okay, thank you. So those are the mesenteric vessels, the vein and the artery below, the head of the pancreas, and with a rotation very gently of the scope, we are on the papillary region and we have the pancreatic duct below. That's a little bit dilated with some branch duct that are visible. We can measure the duct just behind the papilla. Thank you, Adrian.
So if it's a bit confusing for the audience, that left-right is
the right way to perform US?
It's maybe. It's debatable, but I think we can do it both ways safely.
Okay,
so it's a 4.5, I think.
So
almost 5.
It's not so dilated. The patient is 80 years old, so probably the dilation is not so important. In any case, we have some cystic lesion between the CBD and the pancreatic duct that are small with regular wall. Now I try to follow our.
Try like this. Maybe
yes,
it's a bit
okay.
better. So I've just placed the tissue harmonic imaging with resolution. The frequency now is, I think it's 7.5. So you see it's a bit better now. You don't see artifacts inside the fluid parts of the cystic lesion.
We can see better the pancreatic duct just inside the papilla.
Until here.
And also some branch duct in communication with the small cystic lesion.
Adrian, did you use any preset on the ultrasound processor or just changing it manually?
Yeah, we have some presets, so it's set up in a similar way with the Arietta. So you have a routine view, then we have a FAR. So this increases the penetration like this, and we have a pancreas setting, which is like this, but it's set up left-right, so I have to do it like this. So I don't think it's a difference. I mean, you can work like this. If you want with left-right, you can work like this. So I don't know if it's too much different. You can even set up a dual image with the left-right on both ways.
It seems that you can follow the PD into the papilla and look at that. It looks like having a fisheye or something like that. It's very dilated.
We checked before, but we don't see any fisheye sign. But for sure, we can see very well the duct inside the papilla. So seems to be a main duct, IPMN.
But it's clearly communicating here, so you can nicely see the communication between the main pancreatic duct and the cystic lesion, although it's a small lesion, but you can clearly see the communication.
In any case, the wall of the PD is absolutely regular. We don't see any small nodule or something else, so for sure there is a dilation.
So by now it was a fantastic examination. I will go back to room number 6 to ask Pietro and Professor Canussi if you managed to find out the lesion.
Yes, we have a suspected lesion. Let's say you have found a guilty area, and you look at it. It's hypoechoic. It's heterogeneous. It's in the shape of an arc. It's not round. It's not. We have an extensive discussion here. Is it the lesion we are looking for? Anatomically, this is the area we were interested in. It's in the neck. The parenchyma is from both sides, so it seems it is in the parenchyma, not outside. And it is in front of the splenic vein and the portal.
This lesion here is hypervascular. We can confirm with E-flow and DFI. At least it's a nice spot to demonstrate the DFI, you see. Although I'm not convinced 100% that this is the lesion we're looking for. It could also be an intrapancreatic lymph node. We sometimes see them with neuroendocrine lesions. Also, it's 16 millimeter in diameter, so it would be a little smaller than the expected one, but at least it's something.
We got some help from eFlow and DFI to identify this lesion, so it was very helpful.
Are you going to perform Sonoview?
Sonoview, we want to find the right lesion before injecting Sonoview. So yes, if we think it is, there is no other lesion we can think of, it would be, yes, the Sonoview time. To confirm, and then we will perform an FNB. We are, maybe we have already scanned the whole parenchyma.
Maybe we can ask the help of the auditorium, who is convinced that this is the lesion we were looking for, and who thinks this is another thing. And we also have Anand here helping us.
Can you freeze? Can you freeze?
They can look like IPMNs.
Okay.
Someone wants to comment?
Yeah, we cannot hear you, Anand.
Anand is saying it could be the neuroendocrine tumor we're looking for, correct?
We think it is. It's not a regular shape. Usually they are very round, very hypoechoic. And this one is a bit smaller than we expected on the CT and the PET.
For sure, the vascularization is 100% confirmed here.
Yeah, it's like an arc. Oh, maybe bigger than. Okay, you're right. You're right. You're right. It's okay.
Wafa, Pietro, just to confirm me, in the history of the patient, there is a suspected syndrome from hormone secretion from the neuroendocrine tumor?
No, there is no signs of functional net. It's maybe,
sugar.
but you didn't, yeah?
Glycemia is high,
Okay.
300.
Okay.
So let's
So
shoot
could convince from
Sonoview.
a lymph node metastasis from a really small functioning neuroendocrine neoplasm?
Yeah. Okay, let's go and do Sonoview and see what you think of. So it is supposed to enhance very early and wash out early. Yeah, we can go for the injection.
Yes.
It's very nice to have
So now,
behind me Sandeep and Anand, and
of
by
course,
me Pietro.
hyperglycemia can come from a very rare glucagonoma or from a very common pancreatic ductal adenocarcinoma.
The injection is Sonoview is coming. Yeah, we are ready.
Yeah.
Go ahead. Yeah. Yeah, go ahead.
Sonoview has been given.
It's
Counter.
injected. Okay, we have clear evidence of hypervascularity here.
Yeah, very nice.
Very, very much.
Could you please
intense,
comment on the
enhancement?
ultrasound processor and also the setting on CHUS, please?
Yes. You want the camera to be on the screen? We are using actually a Fujifilm Arietta 850, and it's a very, very nice ultrasound image.
With a linear,
with a linear
Fuji
740
echo-endoscope. Yeah.
new endoscope. It's very thin.
The mechanical index is 0.18,
Yeah.
which is performing very good in this case.
You can see that there is still some
So this
inflow.
lesion has no sign of a pancreatic ductal adenocarcinoma, according to eFlow, DFI, and contrast harmonic enhancement.
Yeah.
So
Pietro, what's your next step?
I think we should
We should
proceed
go for an
and
FNB.
do a biopsy,
Yeah.
take a biopsy.
There is no clear washout. It's,
So we have an Acquire S needle,
Yes.
22 gauge needle, ready for this
yeah, we can take out
for this occasion.
the Sonoview.
It's time to have it
Let's position
out
better.
of the box.
Yeah. Oh, nice. You can see the DFI just after the Sonoview.
It's
And
enhanced.
you see very much enhancement also in the DFI.
Kurt from Fuji is helping us
Very nice.
nicely. And this is a
Very,
nice
very
way
nice.
to demonstrate.
And did you try
Enhance the
also
DFI.
Elasto on this lesion just to assess the...
Yes, we can. We will switch to Elasto. We discussed before if it helps to detect, but we agreed it was not helpful. But now that we have it in front of us, yes.
I was quite interested in looking the performance of the new needle with the a new stylet.
Probably, if we take a look at the lesion as we see it now, it's probably even a little larger. Yeah.
Pietro?
Yes?
Sorry, we move for 1 minute to room number 5.
Yes.
Okay. Thank you.
Maybe this could be the
Mara?
real...
Mara?
Yes?
Can you hear me?
More or less?
Yes.
Okay, now better.
We were looking at your endoscopic view.
Yeah, we were looking for the papilla.
We were discussing about the papilla, how it looks like.
I can tell you something about who... So, what about this papilla? What's your feeling?
Looks almost normal, I
Wow.
would say.
I would say that there is mucus and something that is
Mucus,
flowing outside.
Now we suck a little bit more, probably.
A bit
Oh,
of,
yeah.
of a
Thank
cap. Yeah. We were discussing that it might look like a fish mouth, but it has a small cap on top of it. So
And what about this small polypoid lesion?
Papillary
projection. I think it was visible by EUS. We were discussing that before.
We don't want to take biopsies.
No,
that's the plan.
definitely. But fantastic images. We now thank you for this fantastic view, both EUS and endoscopic view of this probably main dark type MN. So now we move to all over Europe, as you know, and this year is my real great pleasure to be connected with Newcastle University, with the Freeman Hospital in Newcastle. Professor Kofi Opong, one of my friends on the permanent faculty of EUS. Kofi, can you hear us?
Hi, we can. Can you hear me?
Yes, perfectly. Welcome to EUS 24, and thank you for joining us.
Thank you very much. You're obviously having a great time in Milan. It's been a fabulous meeting from what we've been able to watch, and we're really pleased to welcome you to Newcastle. So I'm just here with my colleagues Manu Naya and John Leeds, good friends and great colleagues who will be doing the cases, and Manu's going to start with the first case. But before we do that, our fellow Dr. Storon's going to present the case.
Yeah, hi there. Hopefully you can hear me okay. So the first case we have today is a 71-year-old male. He presented with weight loss, nausea, vomiting and loose stool, with a background of hypertension, type 2 diabetes, and previous cataract surgery. He underwent laboratory testing initially with normal liver function, normal renal profile, and a normal CA199. His amylase was also normal. He proceeded to have a CT scan performed in a regional hospital, which showed a soft tissue density at the tail of pancreas. They recommended a repeat CT locally 3 months following this, and that was performed, which showed no interval change. He was then referred to our tertiary center for further assessment and for EUS-guided tissue acquisition as necessary. Next slide then. So his scans were reviewed by our expert pancreatic radiologist, and you can see his initial CT here on the left, and his 3-month scan later on the right, and he's got this ill-defined soft tissue lesion at the tail of his pancreas. So the learning points from this case, characterizing an indeterminate lesion, the role of contrast-enhanced EUS, and tissue acquisition techniques.
Good afternoon, everybody. Can you hear me?
Yes, perfectly.
Oh, hello, everybody. So I think I'm using the Arietta 850 Olympus workstation with the UCT 260 Olympus echo endoscope. I've had an opportunity, in the interest of time, to do a quick examination of the pancreas, and I'm now going to focus on what I've seen so far. So
on the screen, I'm showing you the arrow. This is the body of pancreas. You can see it's a little bit hyper-echoic, and we feel that the whole of the pancreas is probably involved with fatty infiltration. The head and the body of the pancreas look normal. So I'm going to do a nice clockwise rotation to go into the tail of pancreas, which is where the abnormality was seen on the CT scan. So as we rotate clockwise and put the big wheel down and move towards the tail of pancreas, you can see, I'll show you with the arrow, you can see that's the body of pancreas moving into the tail, and then you come up with this abnormality. Now the abnormality, how would I describe it? There are a few sort of hyperechoic areas which is causing an element of post-acoustic shadowing. In addition, as I rotate further clockwise, I think the abnormality just seems to increase in size. Now, because of the acoustic shadowing, I'm not able to see the sort of the deeper part of this particular area of abnormality. What do I think this abnormality could be? You must have heard from the history. He presented with a bit of pain, a bit of weight loss. Bloods were normal, including serum amylase levels. So we're not sure whether this is only pancreatitis. He's well at the moment, so my differential still will remain, is this an inflammatory lesion? Is this a very unusual EUS appearance of a neuroendocrine tumor? But then primary ductal or primary pancreatic carcinoma seems unlikely. I would like to know what the chairs think about this lesion. Hello?
I start with my personal opinion. Difficult pancreas, difficult lesion. And inside the clinical presentation of the patient, we cannot give enough information just on B-mode EUS and clinical history. And from the auditorium, someone has a clear diagnosis on this lesion? Not so much.
Not so much. Okay. So I guess you agree, and the auditorium agrees, this is an indeterminate area of abnormality in the tail of pancreas. Do we think we need to characterize it a little bit further before we yeah. No, would the chairs consider doing a contrast EUS in this patient?
So I personally, in every single solid lesion with no clear diagnosis before tissue sampling, I try to have any possible information from elasto and contrast harmonic EUS. I think that the fatty infiltration of the entire parenchyma of the pancreas could impact on the result, on the reliability of the result of EUS elasto. But of course, I should do it, and of course, I will test the performance of the Arietta coupled with the Olympus scope.
Okay, so we'll try and do some elasto on this lesion. Strain ratio. I think first of all, before I do the strain ratio, you can see that clearly we're not able to capture the stiffness across the whole lesion, because we've got this area of no image.
Yeah, complete shadowing in the middle of the lesion. Yeah.
Exactly, and in this scenario, I don't know whether strain ratio or histogram will be useful.
I think that no definitive diagnosis could, or suggested diagnosis or hypothesis could be drawn by the Elasto, and I think that I will do in my personal unit contrast harmonic US after Sonoview injection, but also in this case could be difficult to interpret the results due to the complete shadowing in the middle of the lesion. And the diagnosis could be also a rare lesion, like a teratoma of the pancreas.
Yeah.
Could be?
Yeah, no, that is a certain possibility, yeah. So I think what we're probably going to try and do is do some contrast EUS, if you're okay with it, and clearly it appears from what you're saying we need to acquire tissue in this lesion because, you know, we don't know what we're dealing with.
I'm personally enthusiastic
so I think
to see.
we're going to the contrast.
Yeah.
1 second, Joe. 1 second. Cool.
In the auditorium, who would perform contrast or go straight for tissue sampling? Raise your hand for contrast, please. Most of the auditorium would do contrast, so please.
Would do contrast. Okay, perfect. So we put the contrast setting on. My colleague John is ready to inject the contrast. And John, do you want to go for it now?
Yep, go for that.
And I'm going to start the counter.
Okay, that's the contrast in and big flush.
As we all know, when you're trying to do contrast, you've got to keep the lesion of interest in view as much as possible with very, very little movement. So we are now 17, 20 seconds into the injection. We see some uptick, as you would expect, in the periphery of the lesion. But again, that very dark area in the center. So now we've gone past, we're getting into the arterial phase now.
From here, the most difficult part is to depict the border of the lesion.
Correct, yes.
And the shadowing really impacts on the CHUS result.
Exactly. So I think we'll do an accumulation mode, but I'm not sure again whether contrast is added any more information than what we have so far.
And in your report, would you define this lesion as a non-enhanced or an unreliable contrast harmonic US?
I would say unreliable because there might be tissue in this very dark area here, but we are not seeing any uptake. So I would classify this as a poorly enhancing lesion, or I would say an unreliably enhancing lesion, because I'm not able to see the whole lesion.
I agree.
Yeah, and it's coming up to 2 minutes now, so I don't think we have seen any new, or we've found any new information. We're just going to do so when you do the accumulation mode, maybe there's some peripheral enhancement, but not much information, I'm afraid. So does everybody agree?
Who agree with the diagnosis of poorly reliable contrast results? Okay. And who think that this lesion is non-enhanced on CHUS? I think no, you convinced us.
Okay, thank you. So I think we've all agreed we need to acquire tissue here. So what we will be using is the Charcot needle from Medtronic. It's a core biopsy needle. It is built on the old Covidien platform. You may have seen it in some of the other cases, but this is the standard needle we use in our unit. So I think John would be happy to take any questions while I get ready to do the biopsy.
And which technique you use? Slow pull, dry suction, wet suction?
So my preference is fast pull and dry suction. Then I assess the tissue, and if in that first pass, in spite of the dry suction, I haven't got enough tissue, then in the second one, I would consider a slow pulse.
And do you have the availability of rapid on-site evaluation? Do you trust on the evaluation macroscopic on the SMER, or what do you do usually?
So our policy here, we used to have rapid on-site assessment by a cytotechnician rather than a cytopathologist, and we published on this data, and it didn't show a big difference whether they were here or not. In terms of the macroscopic evaluation of the tissue, yes, there is increasing data, increasing interest, but we tend to put all our tissue samples into formalin rather than do a smear and then put into formalin.
Again, like Manish says, we've published a randomized trial looking at the FNA versus the FNB of this, which showed extremely good values for sensitivity and accuracy. The addition to that was actually how long it took for the samples, one, to be taken, but also to be reported by the pathologist. And they found a significantly shorter time with the FNB samples over the FNA.
So now I'm going to go ahead with acquiring the biopsy. So it's a Covidien platform, as I mentioned. I've put the stillet back a little bit, looking for any major vessels, not the smaller ones, in the path of my needle. I think I'm happy with that. And I'm going to push the needle out. Are you able to see the needle? I haven't punctured the stomach yet.
A really clear view of the tip of the needle.
Okay, thank you very much. So I'm going to introduce the needle into the lesion. I tend to not do a very fast jab. I try to go in slowly if possible. But here, as I'm going in slowly, it's actually pushing the needle away. So I suspect this is quite a hard lesion. So I'll have to use the jabbing technique here to try and get the needle in.
There you go.
Now again, because of the post-acoustic shadowing, we are not able to see the tip of the needle here. I'm only able to see the needle up to this area here. So I think we have to accept that we're not going to get that view on EUS. I've tried to turn the echo endoscope clockwise and anti-clockwise, and that's the best view I can get. I then push the stillet back in, take it out, and my lovely Lindsay is going to pull the stillet out and put the dry suction on. Thank you, Lindsay. And then I'll do some throws within the lesion.
Do you feel much resistance from the tip of the needle?
Not really, not really. I think the resistance was the initial puncture. You saw how when I was trying to do it slowly, it pushed me away. But once the needle is in the lesion, I'm not feeling that much resistance. No. Just trying to see if I can see the needle, but I can't. I just can't.
It's very difficult, isn't it? It's quite difficult to see behind where the end of the needle is here.
So I think
some movement there.
Yeah, so Mohs assessment here will be very useful to decide what I do in my second pass. There, I can see the tip there. Right, so then I take my suction off, take the syringe off, and hand it over to Lindsay. The needle comes out of the lesion. And this is where the Covidien platform is quite useful in the sense you still leave the main needle in and you just take the inner sheath out. And John is going to express the sample. Can we actually move the camera to where John is going to express the sample, please, Amit?
Come around. Do you want to go over that side, Lindsay? So it has a special needle guard on the end, which you have to be careful of and pull that back. We then place this directly into the histopathology material. So Lindsay's just using the stylet there to push that in. Let's see if anything comes out. Not much so far, Manu. Oh, here we go. Yep, got a nice bit of tissue there. We'll see if we can show you in a second. Yep.
And Kofi, how many passes are you performing independently from the final diagnosis on the rapid on-site evaluation?
Rapid on-site, I think when we compared the two groups with and without, the median number of passes for rapid on-site was 2.1, and for the ones that were without Rose was 2.5, 2.6. So there wasn't a significant difference between the two. I don't know whether we can show the tissue that we have acquired, John?
Yeah, we've got several cores here. Quite long pieces of string. They've also got quite a lot of architecture amongst them. One of them particularly has got some whiter bits in it, so that's promising.
Is everybody able to see that from the audience?
Yes,
clearly.
clearly.
We see perfectly. We see perfectly. So the voice, in your feeling, this visual is positive. You find?
Yes, yes.
Are you going to perform another pass just to be quite sure of that?
I think so. I think so because I think Mohs is not a new concept. There was some publications a few years ago.
Yeah.
But this is an indeterminate lesion. We need to get as much tissue as possible so that our pathologists can do all sorts of different stains if required to rule out, as you rightly said, teratomas, lymphomas, benign lesion, or some very odd cancer. Malignant tumor.
Okay.
So I will do, in this case, I will do at least a minimum of 3 passes.
Great. So by now, thank you very much. Very nice demonstration and very nice biopsy. So we'll see you in a while for your second case. Thank you very much. Thank you very much to everybody. We move back to room number 6.
Went to homocity, but it's fine.
Pietro, Professor Canussi.
Yeah, I'm here.
Okay.
Pietro had to go
to another room. Yes, I know.
So can you see the ultrasound image now?
Yeah, we see the ultrasound image. Have you performed the first pass?
Yes, we performed the first pass.
Okay.
And the lesion now is more visible and clear. I don't know if you can see the whole area.
Yes.
It's bigger than we measured at the first part.
So
it's 22, 25 millimeters bigger diameter, and it's it's.
So now we move to the pathologist room in order to see whether your biopsy is positive and what about the diagnosis.
Okay.
So here you are, Federica.
Yes, thank you,
Professor
Professor
Federica.
Archidiacono. Here we are. So we had a lot of material. It was very bloody, but there were the cells, and so we have a material for the Vivascope, and here you can appreciate the material that we have prepared. So we have adequate sheets of cells with the salt and pepper chromatin. The nuclei are very monomorphic, and the cells definitely look diagnostic for a neuroendocrine lesion. We got the same also in the smear. It's more difficult to have the cells when it's so abundantly bloody, but we have some aggregates, and they again are visible also in here on our desktop. And so we had the diagnosis, and there is still material also for fixation. So both the part of the Vivascope and the other material that is already in formalin will be used for chromogranin confirmation and Ki-67.
So do you think you have enough material to perform Ki-67 and whatever?
Yes.
So thank you very much. Thank you very much for this diagnosis. So we go back to room number 6. Professor Canussi, as you heard, your first pass was absolutely adequate and positive for neuroendocrine tumor.
Yes.
And with enough material to perform also Ki-67. So thank you very much for this fantastic presentation and exam. And so we move to room number 5.
Thank you.
The next case is a 62-year-old male. He had a new onset of steatorrhea and weight loss, but blood tests were remarkable, except for anti-nucleus antibody, which were positive. At the last abdominal CT in February 2024, a 23 millimeter lesion in the pancreatic uncinate process and a 10 millimeter lesion cranially to the previous one, which poorly defined margins. Remaining pancreatic parenchyma is diffusely hypodense with loss of volubulation. In the liver, cystic lesions, the maximum is 35 millimeters, and smaller lesions of unknown nature. This is the imaging. Today's procedures is EOS with the FNA or FNB with the rapid on-site evaluation. Operators are Professor Fusaroli and Professor Sai.
Pietro Nan,
Yeah,
welcome back.
Thank you.
I don't want to put you in a hurry. You have only 7 minutes, okay?
7 minutes, okay. We have
7 minutes? That's a long time.
We have just started the case, so we are right in front of the head of the pancreas. I'm glad that Hananda is here with me because it looks like a difficult case. So we're looking at the head of the pancreas right now, and we get the immediate impression that this parenchyma is far from normal. You can see it's largely hypoechoic with a lot of hyperechoic strands and some lobularity. So if I turn to the uncinate process, I find the superior mesenteric vein. Up to now, we haven't seen any focal lesions yet.
So this is the bile duct here?
That's the bile
So
duct.
it's interesting that the bile duct is not really compressed, even though there's a kind of a mass-looking formation here. But I was telling Pietro, you see the space between the vessels, there's a wide hyperechoic space, which suggests that it's an inflammatory process to me. And the PD is not obstructed, from what we can tell, which is also it goes very much against a malignancy. This looks like a poorly organized kind of a pseudocyst to me in a setting of what could be like autoimmune pancreatitis.
Of course, this is a nice chance to perform a contrast-enhanced EUS, but before doing that, I'd like to complete the exploration of the pancreas. You see we're now following the superior mesenteric vein, and we're looking at the pancreatic duct, which is non-dilated.
There's a little stricture over here. If you go this way, see it disappears. So there's a pancreatic duct stricture, so alternating, and also you see above the stricture it's not dilated, which is also another kind of sign of autoimmune pancreatitis. If it was a malignant stricture, there would be like usually dilation.
We would expect a pancreatic duct dilation, cephalad. So still here we see a pretty abnormal pancreatic parenchyma. What do you think?
It's very swollen,
and,
but at the same time, the PD is not really visible in several segments, which is very typical of autoimmune as well.
This could be investigated with image enhancement techniques like elastography. We would expect a strain ratio higher than normal in chronic pancreatitis cases. But you see this sausage-like pancreas, can we call it like that, in front of the left kidney. And
all the way out to the tail.
Oh, yeah.
Sometimes they can have focal zones with strictures and a little bit of PD obstruction or even obstructive-looking pancreatitis, but it never gets as big usually as a malignant obstruction.
So if you can get some of you ready, please, we can go back to the duodenum and try to take a look at this mass-forming area of the pancreas. Of course, we don't want to call it mass-forming pancreatitis because we don't know it yet.
And you see the inflammation of the bile duct walls. That's also
here.
kind of a sign of autoimmune pancreatitis.
This is the common bile duct, which is not thin but not dilated. You see these duct walls are a little thick.
Yeah.
Here we tend to lose the pancreatic duct a little bit. What do you think, Anand?
You can see it going towards the papilla here, but then it disappears here. So there's another, he has multiple little PD strictures, but without any malignant dilation above.
But definitely this is the area of biggest interest in this case. The fact that we don't see cephalad dilation of the Wirsung duct is not ruling out pancreatic cancer completely.
No.
We could see signs of a chronic inflammation of the body and tail, but this can also be due to cancer.
But in those cases, the duct it's obstructive pancreatitis, so the duct shows what I call a malignant obstruction. But see, his whole pancreas is completely engorged, which really, to me, goes with a benign process.
So let's look with contrast here. So, Davide, if we can go to a nice setting of contrast, give me your best one. Don't keep it for you. Okay. Let's. The mechanical index is 0.21. The focus has to be adjusted manually. Maybe you can bring it up a little bit, like at 4 centimeter. Okay, that's enough. Okay, iniettiamo 4 secondi. So we take 4 seconds to complete the injection. Now, we can start the counter now. So now we expect to see the truth, if it's a focal pancreatitis or a cancer. If it's focal pancreatitis, we expect an ISO enhancement, like what we're seeing now.
I told you.
I told you. But I know you don't like contrast. In Canada, they don't sell it because you don't use it. But, so now when you go back to Montreal...
But I would have come to the same diagnosis without the contrast.
Yeah. At least you have to do something that demonstrates your theory.
Well, we would be doing a biopsy.
A biopsy.
Yeah.
So I'm not pretty sure that a biopsy would be necessary, either necessary or safe here, because there's a risk of cutting the pancreatic duct and inducing a pancreatitis. So if this imaging is reassuring, but I'd like to hear also the opinion of those sitting in the auditorium, we might conclude that this is focal pseudo mass-forming autoimmune pancreatitis, or...
So if the patient doesn't have like recurrent pancreatitis or jaundice or something, or any potential indication to move to a more serious treatment like immunomodulating drugs, oftentimes we don't biopsy. But if the biopsy will help justify something, a more serious treatment, then we'll do it. But I agree in this case, if he just has this appearance,
yeah,
and he's not jaundice, sometimes also you can tell them if he's got, some pain, just give him some steroids and do the EUS a couple of weeks later.
Yeah.
And they respond very quickly to steroids. And if the pancreas totally deflates on steroids, to me it's very convincing. And you do the IgG4 systemic, and
yeah,
that's
steroids and also pancreatic enzyme replacement, and see how he behaves.
Anand?
Yes.
Thank you very much. I think, Pietro, you didn't convince Anand also in this case, but I agree with
Surprising.
you.
You mean I didn't convince him in using the contrast?
Yes. I agree with you that the contrast in this situation is very, very helpful to make a good decision.
It's very nice pictures. Yeah,
So, thank you very much, guys. It was a fantastic procedure. And we move back to Newcastle because we know that they are waiting for us. Coffee, can you hear us? Professor Opong? Professor Opong, can you hear us? So we're waiting for Newcastle. While we are waiting, we can spend these 1 or 2 minutes to say that by B-mode, in this case, beautiful case that Pietro Fusaroli and Anand Syed has performed, there were a lot of signs of autoimmune pancreatitis, the thickening of the bile duct, the fact that there were no dilation of the PD, and there was also a thickening of the arterial wall, and so very nice case of acute pancreatitis. So now we can move to Newcastle. I see the slides, so Coffee, can you hear me? Coffee, can you hear me? And wow, you have 10 minutes to get the patient ready. Is this problem? Okay. Yeah, I reached that. Okay, so we need to spend some more minutes with Pietro and Anand, so we can go back to room number 5. Pietro, Anand, you have some more minutes because Newcastle is not ready at the moment.
Okay.
So Pietro, I have a question.
And then we need them to hurry up. Very well.
This is a surprise. You caught us off guard, but it's okay. We're still here. We were dedicating a few more minutes in performing a complete pancreatic exploration. And Matteo has also asked me to take a look at the liver, which I will do in a second.
Pietro, do you think there is a space also for MRI to assess the anatomy of the pancreatic duct, or you get enough information from EUS to rule out anatomic variations such as pancreas divisum or more rare anatomic variations?
Yeah, I think this is a great point also because when we come to difficult cases and we want to be as adequate as possible in ruling out a cancer, we can take advantage of all the procedure we have. And so I see no point in saving an MRI when the task is so important as to differentiate a cancer from a benign disease. So while they are treating the men with steroids and enzymes, why not also addressing the situation with an MRI? That's a good point. Here there are some lymph nodes you see along the superior border of the superior mesenteric vein, some benign looking lymph nodes. And so if Davide can now set a penetration mode for the equipment, we can take a look at the liver as requested from Matteo, who is the owner of the room. So when we use B mode, the focus is automatic, so we might assume that all we are looking at is in nice focus, and we see a liver cyst here, for instance. There were some liver lesions seen at CT scan. Yeah.
Yes, but they didn't.
There's some a small echogenic lesion here, which can represent a small angioma. Nothing worrying. Anand has gone away. Okay, so I'm all on my own. We're looking at the segment 2 and segment 3 of the liver, separated by the left hepatic vein, and they converge in forming the inferior vena cava, which you now see under the probe. And from inferior vena cava, you can come to right atrium and then left atrium here. But I remain inside the patient as long as Paolo is asking me to do so.
From a steroid treatment, if we are going to perform another US?
Yeah, Matteo is asking what do we expect from steroid treatment. I think we expect a significant clinical benefit. I'm not sure if we also expect a change in the imaging. The imaging might remain somewhat more or less the same. So since we didn't see this much sort of derangement of the normal anatomy. Sometimes when you also have involvement of the biliary tree and you have a lot of biliary duct wall thickening, then in that case you might see a significant change, a significant improvement. But here we have the whole gland, which is hypoechoic and lobular. So the first
Pietro, Matteo, of course,
yes,
the
Andrea.
positivity of ANA serology move us to the suspicion of an autoimmune pancreatitis together with the EUS image of EUS B mode aspect of the pancreas. But the presentation with steatorrhea and weight loss, is it typical for an autoimmune pancreatitis in a 60-year-old man, or we can check for other causes like heavy smokers or alcohol or other concomitant factors? I'm
So
asking
you
to Matteo
mean,
because he's one of the most professional pancreatologists I met in my professional life. So.
You mean for looking for other types of chronic pancreatitis, or you're not still convinced that there's no cancer here?
I'm convinced that there is no cancer.
Pietro, Andrea, thank you very much for prolonging. So the Imola team has done a great job. Thank you very much. So now we have shifted the cases, so we are moving directly to Ecuador, to Guayaquil. Carlos, can you hear me? Carlos, can you hear me? Okay, just one more seconds to connecting.
Hola.
Hola, hola, ¿todo bien?
Retorno.
We can hear you, but we don't see you at the moment.
You don't see me?
At the moment,
Okay,
no.
So we will.
Okay, now you see. Now we see you. Thank you very much.
Okay, perfect.
Thank you very much for connecting so quickly. Thank you very much, Carlos. Go
We're
ahead.
almost ready. I am wake up from 5 a.m.
Yeah.
because I have to my lecture 7 a.m.
Ah, yes.
So I am early. Wake up.
Great.
So it's
Great.
okay.
So thank you very much, and
Thank
go
you so much.
go ahead with your case. Thank you.
Okay, so Daniela will present my case. Please, Daniela, go ahead.
86 years old male patient with no important past medical history, presented in our unit with jaundice, pruritus, and weight loss. Laboratory findings, important cholestasis, and a total bilirubin of 29 milligrams. The cancer antigen is up to 150 units. The MRI showed dilation of intra and extrahepatic biliary tract with distal abrupt obstruction due to an ampullary lesion. We are going to perform today US-guided choledochoduodenal anastomosis with lumps.
Hello. So I want to just, I don't know if you hear me now.
Yes, absolutely.
Okay, perfect. So I want to just to win a little bit of time because I know that always we have some delays. So this is the first image that I have of this patient. This patient was sent to us today to solve this case. But what I saw at the level of the liver, for example, there is ascites in this patient. And also here, if you can see here, so this patient have already ascites, and there is a dilation of the main pancreatic duct. This is the body of the pancreas, you can see here, and here. So, and in the head of the pancreas the same. You can see here the dilation of both ducts. So, this is an ampuloma with infiltration, and I believe there is already carcinomatosis. So now, the patient have jaundice and cholangitis. And this patient needs to be treated by drainage of the biliary tract. So in those cases, when we have ascites, in theory, this is a relative contraindication to make a biliary drainage guided by US. However, you can do it in some cases like this. If you have a very good window like this one that I have now, I see the ascites, I prefer to use always to perform the biliary drainage using lamps for bile duct, an 8mm lamps. There is a Boston Scientific hot axios that I will use today, but I will use it using the guide wire. For me, it's better. It's more security for the patient also. So I will try to go in this position and try to go ahead. So when you don't have ascites, you can go directly. I don't have the same skills of Professor Quejela, for example, that he already showed me how to do it without guide wire. But in this case, I will use guide wire. So first, I pass the needle. I confirm that I am inside the biliary tract, and then I pass the guide wire, just to have the security because of the ascites. I don't know what do you do in cases of ascites when you have to perform a drainage. I understood that this patient already had they attended in the other hospital at ERCP and was failed. So now I pass the guide wire. You can see here very well the guide wire. Okay, so it's a big dilation of the bile duct, the common bile duct. Okay, and now I will change. I will remove my needle and I will use the hot axios of 8mm. So I believe this patient is not more resectable.
Professor
now
Robles Medranda, please a
because
question.
of the findings.
Do you use the choledocododenostomy over the wire to keep a stable position during the LAMS insertion, or to have a safety alternative approach in case of misdeployment?
Yeah, I think it's both situation. First, when you do it over the guide wire, you have more security because you can, in case of misdeployment, you can remove the axios, or you can recover the axios, and or you can pass another stent, and you can solve the problem, the adverse events that you can have when you are putting some lamps. On the other hand, it's for a security reason also now. In this case, we have ascites. You saw the ascites. It's not a small ascites, so I don't have any other chance now to perform a drainage of this ascites, because this patient is not inside my hospital, it's outside my hospital. So I need to avoid a complication because of the ascites. So with the guide wire, I will have more stability to go inside the bile duct using the lamps, even if there is ascites. So I am inside.
And which guide wire do you use?
Very well. 0.035, Boston Scientific. You see? Now my lamps inside the bile duct is opened, and now I can perform the traction like this. Think again.
Can we come back to the EOS image from Ecuador, please?
Imagen de ecografía, por favor. Are you looking at the US image? Because I am looking
In a small picture, so please, from Italy, move to the...
No, en grande. No, ecography. You want to see the US image of the
The US, but it's, I think, a matter from Italy. Okay, great, great.
Ah, I'm sorry. Yes. Okay, so you can see here.
And which lamps, which sides of the lamps?
My guide wire. This is the common bile duct lamps inside.
A
Open
6
it,
or
already
8
open it.
millimeter?
This is my guide wire. Yes, 6 by 8 millimeter. And then I start to deploy. I always love to deploy my second part of the lamps inside my working channel because I have better, no sé si podemos ver la imagen endoscópica ahora, pero no en grande, en pequeña. Quiero la imagen ecográfica. Okay, perfect. So now, I don't know if you see the luminal apposital stent opening.
Yep.
In the gastric lumen, in the intestinal lumen. So now I have my lamps inside the bile duct. The other part is inside the lumen of the intestinal lumen, you see? And now I am sure that I have a very good deployment. And it's already finished.
I think that you demonstrated that in specific cases like this one,
yes?
the direct approach for EOS guided biliary drainage could significantly increase the technical success rate and reduction in procedure time dramatically.
Yes, and this is a big discussion now. Huh? A lot of papers showing less radiation, for the patients, for the physicians, but also a very good successful. You see here the ascites. Look the ascites. So this is very important. This is why I always say that it's a relative contraindication. We have ascites here. It's moderate ascites. It's not a small ascites. Huh? It's moderate ascites. And even if you are in the bile duct, in the duodenal wall, you can do using the guide wire, and it's safe, and you can, do faster with a lot of security.
Carlos?
I don't know if you have any other question. Yes?
Thank you very much, Carlos. It was a fantastic procedure. So we now move back to Newcastle, and then we will back to you as planned. Thank you very much to be so quick and effective. Thank you. So, Kofi, can you hear me?
Yeah, we are here.
Okay.
Yeah, we can hear you.
Back with you.
Thank you. So I think Dara, our fellow, is going to present the case before we show the EUS.
Yeah. So our next case is, hopefully you can hear me okay. Our next case is a 77-year-old male. He's got a history of recurrent acute cholecystitis. He has a background of COPD, previous AAA repair, previous PE on a Pixaban. Was deemed not suitable for cholecystectomy due to high anesthetic risk. So did have a previous attempt at an EUS guided gallbladder drainage, which unfortunately was unsuccessful. He then proceeded to an attempted transpapillary drainage, but that was also unsuccessful. He has been managed conservatively, but presented recently with a localized perforation. And now he's attended today for a reattempt at an EUS guided gallbladder drainage. This is his recent CT scan. You can see his gallbladder is inflamed and there's a pericholecystic abscess. It's quite close to the duodenum, so potentially amenable to endoscopic drainage. And the learning points for this case would be endoscopic ultrasound assessment of the gallbladder and EUS guided gallbladder drainage technique. So if we pass over to the room now.
Noi andiamo alle 40.
Well, can you hear us?
Yes? We can hear you,
Marvelous,
but
thank you.
now we cannot see you anymore.
Can't see.
You should activate your video.
Video. Yeah, we need the video activated. We'll sort that out in a minute. Yeah.
40. Cosa faccio?
We've got a message to say that the host has stopped the video link. Is that correct?
Aspetta di qua.
Can you hear us?
Yes, we can hear you, but we cannot see you anymore.
I think we are getting a message here that the host has stopped the video link.
Okay. We stop the video link actually now.
Just let us know when you can see.
We're trying to save something. Okay, now you're back.
Excellent.
Thank you. Thank you.
Thank you.
John, you go on. Yeah.
Okay.
So in this case, it's a gentleman who we were looking to see how we could treat his gallbladder. What you normally have to do is try and find the gallbladder first. It's probably the most variable structure in the upper GI tract. So I often start from just before the pylorus, which is where I am here. And if you look anteriorly and kind of tilt backwards, you can see his bile ducts here and his liver. And actually, he's got a little bit of air in there. He's had a previous ERCP and sphincterotomy, so you can see a bit of air there. We couldn't actually make out his gallbladder at all. He's got a little cyst in his liver just here. So if we go down then into the duodenum, just pop in there. Should then be able to see the bile duct. Of course, is up right in front of us here. And then often if you can't see the gallbladder easily, the trick is to follow the bile duct until you see the cystic duct take off, which is just happening any point around here. Just at the bottom there, quite small. It's actually a really big turn to try and find it. So using my little wheel, and there's his gallbladder in the distance, which has some debris and things in it. The wall here doesn't look very happy, I have to say. And I think the first and most important thing to say is that this distance here looks really quite large. So we'd normally want that to be as small as possible, and if ideally them to be a. I don't know if the panel has a particular length that they prefer or distance that they would rather have. This at the moment looks a bit large for me to go for. That's 11 millimeters. Take that.
So what do the chairs think? Is this, we've tried very hard to get the most ideal position to drain this gallbladder, but the distance seems to be at least sort of 12 to 14 millimeters. Can you hear us?
Yes, yes, we were looking at your pictures. I think everybody here is thinking how to solve this problem. We can discuss about that.
If you come up with anything, let me know. Yeah. I've tried going a bit further in, which you can't really get further down there. Try pulling back and straightening up and see if that gets us any closer. There's just quite a lot of adipose tissue between the duodenum here and the gallbladder. And it's not hugely distended either, as you can see. It's not particularly large. Because you're always looking for, you need what I call a landing zone. So when the lambs comes in, there needs to be enough distance within the structure for you to be able to actually open the distal flange safely. There would only just be that, but I'd want this to be a lot closer.
Do you usually prefer to find an access from the duodenum, or then you can also try to find that from the stomach? Which is your first choice?
My first choice is whichever's the easiest. But the data I've seen is that actually duodenal drainage gets more effective palliation for the patient, whereas sometimes stomach is easier. We seem to prefer stomach. We think stomach is thicker, more tolerable for if there's a problem than the duodenum. But for patients, it's often better in the duodenum. But when you come back to then have to go back through the lambs or take any stones out, stomach is again easier, but it's not impossible in the duodenum. But my preference is wherever is the easiest place to find it.
Because I think 90% of the times the position of the gallbladder is from the antrum, and you would have easy access to the gallbladder, but in less than 10% patient it could be posterior, more inferior, which makes it difficult to drain it from the stomach or from the gastroesophageal junction.
I'm just going to go down to D2, see if that straightens us up and gives us a different view. Well, I did that before we fell back a bit. We might need a bit more sedation then.
Yeah, I'll do that.
So occasionally, if you pull back and straighten up in the duodenum, I think I may have fallen back into the stomach already, actually. Yeah, I have. So normally from the bottom of the stomach here, which is where we'd started from, you can obviously make out most of the other structures, but I really can't. I was having a good look earlier to see if I could see a gallbladder from here, but the answer is you really can't. I initially thought that cyst was it, was very excited, but obviously that's just a hepatic cyst. And it really is one that, as you follow up here from the bile duct, and he's also got a bit of a thickened bile duct. I think he's obviously had some episodes of cholangitis. And we certainly, let's say, he's had a previous ERCP sphincterostomy and stone removed many years ago. And we tried to go transcystically. So it might be a chance for us to actually look at why we couldn't manage the transcystic approach and why we might actually think of that again. Because there's a cystic duct just there, reasonably tight. So a cystic duct, I think you can see, this is the main bile duct. As I rotate, you can see a cystic duct here. It's quite small, quite thin, and then kind of heads up towards Hartmann's pouch as I rotate across. I have to use a little wheel to show that. There you go.
That's where you see the gallbladder.
Yeah, gallbladder comes in there.
Yeah.
I was going to see if there was a stone or anything in the way. It doesn't look like it.
No.
So you wonder whether we might be able to have a further attempt at transcystic approach for this. Again, I don't know what the panel feel.
May I try to summarize?
It looks that you have a patent cystic duct.
Yep.
Yeah. So it could be that the ERCP approach could be helpful in this case.
Yeah. We've tried that and failed in the past. We ended up having a small perforation of the cystic duct.
I see.
But it does look here like it's patent. So that may be the next best thing to try, I think.
Yeah. But this
the
is...
EUS has been very helpful here for seeing this, I think, because we couldn't quite work out why we failed when we tried the transcystic approach before.
I see.
So now we can see a very nice patent duct, which is quite useful.
So is this your first approach? Usually is to perform ERCP and cystic duct drainage, not going directly with EUS?
I would usually go for EUS, particularly if the gallbladder is near enough and easy to get to. It's a one-stage procedure. It doesn't have the risk of pancreatitis. So I tend to prefer that as an approach as long as there's no contraindications, such as, we had a patient the other week with severe clotting abnormalities due to liver disease, and therefore the transcystic approach is much more preferable in those patients.
Sir, may I ask you? Of course, the microperforation of the gallbladder and the partially deflation of the gallbladder hampered the approach. Did you consider the possibility of inject saline inside the gallbladder lumen to inflate that and try to reduce the distance from the duodenal wall?
Yeah, I did think about that. My worry is the angle here is horrible. And also, even at this point, if we measure where we can get it the closest, which is probably here, that's still, from the outside of the wall of the gallbladder to the outside of the wall of the duodenum is still 10 millimeters. And it would have to get really quite big to be able to have enough room in between, to get in between both of those lumens for me to be happy that this isn't going to slip. But that's quite an amount of adipose tissue there, isn't it?
And try with a percutaneous drainage, and then in a postponed situation and approach, try to convert the percutaneous approach to an internalization with the EUS drainage?
Yeah, or we could even get them to get the wire down the cystic and put a stent in transpapillary. Yeah, I think that might be the way to go. I don't think I'm happy to attempt a drainage here with the risk of perforation, misdeployment, and adverse event is a bit too high.
So your approach now, so your algorithm now, what's the next step in your algorithm of this patient, for this patient?
Well, he's currently not admitted to hospital. He'd recently been in because of the perforation. So we could try and get him back for a further attempt at transpapillary drainage. And if that was successful, then great. But if not, the alternative, like you say, is percutaneous drain and then extension down into the duodenum.
So, great. Okay. So I think this is something that happens when you try to, probably the microperforation has also changed the shape of the gallbladder, and this big inflammation has changed the possibility, has hampered the possibility to reach a good view and a good position. But then this is real life, so
yes.
Thank you.
Sorry, no drainage, but hopefully
we've
been able to demonstrate a good assessment of the gallbladder, where to safely try and look, and actually show some of the contraindications for this.
Absolutely, the most important thing in many cases is to know when not to perform. Then, in case when it is not indicated, then to perform a very easy procedure. So it's very important also to show to the auditorium and to the audience when is not possible to perform something. And so you need to have another point of view, another possibility. So guys, thank you very much for being
Before you sign off, I just wanted to say thank you to our nursing staff, Shalina, Paul, radiographer Laban and Dara, and Lindsay, and thank you to Kofi and John, and thank you very much for the invitation.
Thank you very much from our side, and thank you very much, and probably we'll see you next year as well. Thank you again. Bye, Kofi. Bye. So now,
bye, Kofi.
Now we will move to the University, Johns Hopkins University in Baltimore. Hello, guys. Welcome back to US. You are not Moen Kashab, I can imagine.
I am not Moen Kashab. Thank you.
Hello. Goodbye. Welcome to EuroUS 2024. So we are very, very proud having you with us also this year. So go ahead and present your case, and looking for you.
Sounds good. Thank you for joining us. So we're presenting a case of endoscopic ultrasound transgastric ERCP. So this is a 38-year-old female with a history of Roux-en-Y gastric bypass and a previous cholecystectomy for gallstone disease. She's been having a recent history of recurrent attacks of right upper quadrant pain associated with transient liver enzyme elevation. She got a CT abdomen with intra and extrahepatic biliary dilation with tapering towards the ampulla. There were no obvious colorectal lithiasis on the CT scan, and there were no obstructive masses. So overall, her picture is concerning for small colorectal lithiasis versus a picture of sphincter of Oda dysfunction type 1. She is in the hospital right now with another episode of abdominal pain associated with liver enzyme elevation. So in this setting of her Roux-en-Y gastric bypass, we're planning a NEDGE procedure for access of the biliary system, and then we assess for colorectal lithiasis versus do a sphincterotomy for SOD type 1. We're good.
Moen? Can you hear me?
Okay, hi. Yes, hi everybody. Can you hear me?
Yes, perfectly. Welcome.
Okay,
Welcome back to EuroUS.
Yeah, thanks for having us back. Pleasure to be here. So we have an exciting case for you to demonstrate the EDGE procedure. It's a patient with, I suspect, SOD type 1. Of course, type 2 and type 3, we don't talk about them anymore. But this patient has episodic biliary type abdominal pain with associated significant increase in transaminases in the hundreds and dilated biliary system. And her LFTs normalized between attacks. So it's a good case for biliary sphincterotomy. And also, of course, we have to rule out small stones that are missed. So let's go for the EUS view, please. All right, so this is the $10 sign. typically this is how the remnant stomach looks like. And find us on fluoroscopy, please, left upper quadrant. Very nice. So it will be nice to have both the EUS view and the fluoro view. And we see that this stomach is completely collapsed. So now we want to get to the lumen of this remnant stomach so that we can inject fluid and distend it. So we're going to use a 19 gauge needle for access, and we're going to aim to the middle of it. And it can be a little challenging here to find the lumen. And there is a little feel to it. You're going to feel like you're in kind of an empty space because there is really no dilated or no fluid fill component. So I'm pushing the needle in and out. And what we're going to do is, I don't think I'm in. See here, I pull back. I am not in yet. So I'm gonna probably cross the stomach and pull back. And what we can do is also do a test injection. I'm gonna pull back here. I don't like it. I'm pulling back and I'm gonna repuncture.
Which kind of needle are you using to do this procedure?
So this is a 19 gauge flex needle from Boston Scientific. It's good to use a 19 because you're going to inject a lot of fluid. And let's see if we are in the right place. So what I'll do is I'll do a test injection. And the key here is to see the contrast flowing in the stomach. If it's staying in one place, it means you are intramural. Give me fluoro, please, live. So you see here, I already know I'm intramural. So it's not flowing up. We don't have to complicate it more and inject more here. So we're just going to pull back and move around to see if we can see a better pocket. It doesn't matter where you puncture from, the remnant stomach, the jejunum. Here I'm pulling back. This is better here. See here, we see a little bit of lumen. So likely better. So I'm gonna go here and see if we can. So that we're gonna puncture and pull back, and here we're good. Yeah. It looks good here. Live, please. And you can see can you come towards me, please, center the image? Can we give a glucagon 1 milligram, please? Off. So now we are in the lumen, and as I showed you first, when this contrast is not moving, that's intramural. So you stop because it can complicate the picture. So now I'm attaching the needle to a pump.
Professor Kashab, do you puncture with the needle without the stylet or with the stylet in?
Yeah, without the stylet, it's already primed with contrast, and I'm ready to inject. So without the stylet. So you see here where you have the live, please, fluoro. Good. Off. So now the needle is attached to a pump, and we have a solution. Open the 20 millimeter axis, please. A solution of saline and contrast. And I'm just going to inject between usually 250 and 500 cc's until I'm happy with the stomach. It's fluid filled. You notice that I gave glucagon, or you can give Buscopan in Europe to basically paralyze the stomach so that it retains the contrast better. And one important thing is it doesn't matter where you puncture initially. Here you see the puncture is in the antrum. We don't like to put the stent in the antrum because ERCP becomes difficult, buried lamb syndrome, et cetera, so we like to be in the body of the stomach. We don't like to be in the fundus or very proximal because it's very vascular area of the stomach. So I think targeting the body is good. Fluoro shot, you see here we're filling, but not great, but it's filling. So we're gonna continue to do that. And then we will be ready with a 20 millimeter lumen opposing metal stent. Good, what you just did, excellent. The fluid was going slowly, so we turned the pump up. Fluoro shot again. All right. One important part of the patient history, a lot of these patients get sleeve gastrectomy, then they get conversion to Roux-en-Y. These patients are more difficult because there isn't much of stomach there, and the stomach will be very thin. Fluoro shot, I didn't think this patient had sleeve, but the stomach, you see, it's kind of collapsed a little bit, but we'll still try and see if we can do it. So I'm still distending here. Fluoro shot. A lot of the contrast already passing despite the glucagon, just patulous pylorus. Okay, so I'm gonna stop here, take this needle out, and let's see now fluoroscopically. Turn our live, please, on fluoro. Turn towards the body there, towards the body, and up. Not really very happy with this, because the stomach is not very well distended as usual, but this is a good part. Fluoro. Okay, so that's body. We're gonna take that up. So we're gonna use a 20 millimeter. Oh, help me push this here, please. Push. This is like so wet. Yeah.
From our side, it's very interesting the shape of the stomach, because when you were moving, there were also many jejunal loops dilated, but with a different shape. So it's very important that you realize in these cases to be right in the right position to see the stomach and not the jejunal loop.
Yes, yes. But here you see the stomach is collapsing very fast here. A little unusual. Fluoro shot.
A lot of fluid in the jejunal loops.
Yeah, here you see this is the stomach, obviously, but so this is the lambs there. And we're in. Gonna push, 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 push. Check this out, please. Gonna deploy the first flange in the stomach, in the remnant stomach, and now pull. And deploy the second flange in the channel. And then let's turn to endoscopy view. Let me know when you have it.
Now we have
Good.
it.
So we're gonna just push it out of the scope here. And now this part is done. Let's see the endoscopy view. Show you here.
Hi, Moen, this is Prableen. So it looks like you went into the blind limb. Is that where you accessed it from?
Doesn't matter where you access it from. You just want the best position to the excluded stomach. Sometimes it is from the pouch. Sometimes it's beyond the GJ. And in the past, we thought maybe going to the jejunum is better to be away from the staple line to avoid maybe permanent fistula. That really doesn't matter. What you want is the best shot to exclude the stomach to put the lambs. So I never look where I am. I just want to make sure I'm not in the antrum. I'm not accessing the antrum. So right now, the next fluoro shot, okay? And the next step is dilating the lambs, and I dilate it to 18 millimeters. And then the third step is suturing the lambs. And then the fourth step is doing an ERCP. If you want to do a same session ERCP, few criteria you have to meet. One is you want to put a 20 millimeter stent. Two, you need to dilate the stent to 18 millimeters. Three, you need to suture it. And four, while doing the ERCP, the ERCP scope, it has to go in nicely and smoothly. Some patients with a big pouch, the stent tends to loop in the stomach, so you should just stop. But in more than 90% of cases, you should be able to do it same session, and that's usually my preference. So we're here, we're gonna just go with a CRE. And we're going to go slowly. Please dilate to 18 to 15 first. Yeah, go ahead, please.
So, Moen, a couple questions. So, were you intentionally targeting proximal body? And number two, how the bypass was done, the surgical report, does that matter to you in terms of one step versus two, despite securing it?
Yeah, it really doesn't matter. What matters is if the patient had the sleeve and then conversion to bypass, because then the stomach is going to be too small. And the procedure can be very difficult, 18, yeah? So that doesn't matter much. But the first point, I like to target the body. The very proximal stomach is very vascular, so we try to avoid that. Distal stomach in the antrum, you'll have buried lambs, and then the ERCP will be difficult because we're right next to the pylorus. We try to avoid that. Are we at 18? Okay, deflate. So the best part is the body of the stomach. So, and this is what should dictate where you access it. So it doesn't matter, it ends up being from the pouch or the efferent limb. What matters is where the other end is so that you're successful with ERCP. So this now is dilated. So we're gonna now switch quickly to a double channel with overstitch to do full thickness suturing so that when we perform the ERCP, we don't experience migration of the stent. So recently we published a paper of a case series with Shayan Irani where you do this type of technique, 20 millimeter dilate, stitch, and same session ERCP, and the outcomes are spectacular with no migration. It's never gonna be zero, but in that case series, it was zero. But still, when you're trying to do the ERCP, you want to make sure the scope is going smoothly. The idea here is to finish the job right away, bring the patient, if you don't need to do more ERCPs, bring the patient back in 3 weeks, take the lambs out. You don't want that fistula to turn into a chronic fistula. Once it turns into chronic fistula, spontaneous closure doesn't happen often. But when it's not chronic, the rate of spontaneous closure is actually pretty high. So that's the intention. Yes, please go ahead.
May I ask you, do you have any experience with the new X-Tack by Boston Scientific in
of course.
locking the lamps? So which do you prefer in terms of safety and in terms of how quick you are? We know that you are so quick with the Apollo that maybe you do not need to have any other device, but what's your feeling?
It's not about quickness, just this gives you a full thickness bite. The X-Tack is not going to do that. It's very, the suture is not strong enough, but also it's not going to be, it's hard to get the tacks between the interstices. So it's just not that suitable for what you're trying to do here with a secure full thickness, strong suture. The extract is really not made for that. So we have the overstitch here, and you'll see it's not that difficult to do. In this case, there's no risk of crossing or patterns and you have a lot of edges. You see the edge here, for example, so you can just you don't even have to use the helix sometimes. So you see here, I don't need the helix here. I'm just gonna take that bite and you have the end of view, right? Okay.
Yes.
Good. So now we will so we took a bite on the wall. Now we want to make sure we're gonna get stent here. And then we will get another bite on the wall. And we're gonna pinch that suture. So this is the needle here. I'm gonna drop it. And we're gonna cinch that. Take another suture on the opposite side. That way, when the ERCP scope is passing, the force is separated between both sutures. We don't want to break any of the sutures. And then we'll perform a standard ERCP. So the beauty of this is you are able to use an ERCP scope, 4.2 millimeter channel, your standard instrument. So it works really well, especially with complex ERCPs, patients who need to have multiple procedures, pancreatic work, large stones, complex strictures. This is now our go-to approach in these patients. We don't do enteroscopy RCP anymore with this anatomy.
So 2 stitches, one of the opposite sides are enough for you to be stable, to stabilize it.
2 stitches are good. This has been our experience. And we'll take back the second suture.
And you look for the opposite side of the stent.
Exactly.
Great.
That's the preference here.
So, Moin,
anybody from the panel has experience with edge?
So, Moin, what is your strategy going to be when you remove the lambs out? Are you going to close this or are you going to leave a pigtail? Because this is a benign indication. If this is SOD, the patient is bound to get symptoms again at some point down the road.
Well, I'm hoping that with the complete, these patients they do very well with a complete sphincterotomy. So I'm hoping that, this is real ampular stenosis. We don't, of course, we don't do SOD anymore, but this is just will ensure complete sphincterotomy, and I think hopefully we're not going to need repeat ERCPs. So my goal will be can I have a helix? My goal will be to bring the patient 3 weeks and remove the lambs. So if the fistula is not chronic, don't do anything with the fistula. I just leave it closed on its own, and we follow these patients up to document that. But if the fistula is chronic, let's say you have a liver transplant patient, you're sending them for 12 months, then out, and just 2, okay? Go ahead. Then these patients, it's a chronic fistula, it's not going to close. You good? Okay, so here I'm using the helix to get just a deeper bite. We don't want to tear see it's crazy how things can tear easily here. So you see, this is the jejunum. With the helix, we only did 2 turns. You can even do 1 turn. Because the wall is very thin. And the second bite is going to be stent. So we get stent, yep. And the third bite is going to be wall again. Out. Let's just do 1 here. 1 complete one. Good. very deep, but it's fine.
So,
All right, gonna drop the suture and gonna tie it and then do the ERCP.
nice. Do you think you may have trouble with persistent fistula because of the access close to the anastomosis here?
It doesn't really matter. The number one factor is chronicity. When we looked at the other factors, maybe uncontrolled diabetes, but we looked at it again and again and again in terms of location of the fistula. It does not matter at all. Initially, this was our thoughts, right? At the staple line, at an anastomosis, devascularized structure, maybe the fistula rate is higher. Nothing really panned out. We have a nice paper. We looked at this. You know, every week, for every week the lamb stays in place, the fistula rate increases by like 7 to 8%, something like that. I forgot the exact number. So it's same with any other thing, right? Chronic fistulas are hard to close. All right, so that's established. We're going to close the system and come out, and then next is ERCP. I know this is Euro EUS, not Euro ERCP. You're welcome, of course, to watch the ERCP, and feel free if you want, if you need to switch, or if you have any more questions.
We will stay with you. We will stay with you.
I think that in the auditorium we will enjoy the ERCP.
Now is the exciting part.
Yes.
In case we will move, but I think that you will manage in 10 minutes.
Well, no pressure, huh? Okay, so we'll have the tom and wire ready, please. So of course, I haven't acknowledged my team. They're moving really quickly here. We have Brittany, Tanya, and Sophia, and Eric, and Denise. A lot of help to get all these scopes, and so we're going in now with an Olympus ERCP scope. So this is the lamb. So just think of it as a pylorus. You want to just aim a little higher, and then go in nicely. So that was smooth. And give me fluoroscopy. And you see here, we see it there. Here, when you go in, you have to turn right. But always I like to see that fluoro picture. If you see the fluoro picture there, yep, is that we're heading towards the pylorus, so that you're not heading backwards. Let's see where's the pylorus here. Sometimes we get stuck at the pylorus. Some of these patients, for some reason, have pylorospasm. We end up needing to dilate the pylorus. Maybe it's that, or just the position is not optimal, how we approach the pylorus. But occasionally, this is a painful part where you have to. I'm hoping it will be okay and easy, because the contrast we saw was passing very nicely.
Is the patient supine?
Yeah, we do all our ERCP supine. This is, here at Hopkins, this is how everybody does it. And we're trained this way. And there are a few things that you have to learn when you do supine ERCP, but it works well. This patient is intubated. Our anesthesia team is happy with full control of the ET tube, and fluoroscopy is easy, and so yeah, patient is on their back. If we have some difficulty sometimes here, we can put them temporarily left lateral. I think maybe that's what you're alluding to.
Yeah, I think.
So we can do that sometimes, but let's hope this is not the most difficult part of the procedure, getting through the pylorus. but it happens. I think maybe there is a component of pylori spasm. Anybody has seen that? Anybody has noticed this? I don't know if Prableen does edge or.
Yeah, I think left lateral, moving the patient left lateral will help here. As you
Yeah,
said.
so let's try here for a minute. I usually, what I do is, since we already have a CRE balloon open, so here you see it's actually open. It's just the axis is a little difficult. So Ash, can you maybe give me some pressure, please? And here what I'll do before you pressure, you see I'm gonna just come back and double check on, you see here, like if we retroflex a little bit, see the axis is still good. So go ahead, Ash. All right. On the face, So this is the advanced fellow to the rescue. Ash here did a great job giving me a good pressure on the stomach, and we are done. Thank you, Ash.
Nice.
And find us, please, ERCP position. Very nice. So that's a nice floppy papilla there, or pretty bulky papilla.
Yeah, that's a nice papilla for sphincterotomy.
Yeah, a lot of sphincterotomy here. So for the most part, it's just a standard ERCP. Occasionally, the position is not great, but generally speaking, it's fine. So let's see here. Kill the wire. Okay, good. Better approach. Stow a little bit. And go with the wire now. Live. Maybe pink. Let me see. Pinker. Up. Live. Yeah, pancreas. Up. Just pull a little more. So we went pancreas first. Live. Up. Live a little bit. Live. Yep. Why don't you give me just an angle tip here? Go ahead, angle tip. So you're gonna just leave a wire in the pancreas, and I'll go. We'll show the audience the double wire technique. I think will be nice to demonstrate it. Sometimes these papillas, like this, the bulky papilla, it can be a little tough to get into the bile duct because there's a long intraduodenal segment of the bile duct, and that segment can be very tortuous. So it's not just getting into the correct axis, it is navigating that bile duct. Putting a wire in the pancreas in the common channel can straighten things and makes it easier to do. Using a floppy wire with a floppy angle tip can also help. Little shot again. Careful. Let me take it so that we don't bounce out.
In such papilla, do you think that a septotomy could be helpful to reach the common bile duct?
Yeah. So if I struggle, I would not go too long. I will go ahead, exchange. Umbo. Okay. Please go. Good. Yeah. So we have wire in the pancreas right now. We should be okay. But if it's difficult to get, then I'll put a stent in the pancreas and just do a septotomy. So it's what I usually do. I go for a fistulotomy. So I would probably maybe try for 5 minutes, not longer, because this papilla will be very nice for a fistulotomy. But since I have a wire right now here, we should be okay. Fluid shot. Good. Is this the last case or any more cases to follow?
We have one more case from Ecuador.
Oh, we don't want to mess with Carlos.
Yeah, we will stay with you for 2 more minutes and then we will leave you. But just let me tell you how much we have appreciated your procedure. Spectacular as always.
Thank you, but let's see if we can finish the job before you go to Carlos.
I hope so.
All right. Fluoro shot. Can you mag one for me here on fluoro? Fluoro? Good. Off. Fluoro again. And go ahead, start off. Can you bow here? Bow, bow, bow. Bow more. Live. More. More. Stop. Right. Off. Maybe a little less, actually. Yeah. Let me feel. Through shot. Live. Same. Off. Fluoro live. Exit. Off. Give me a wire. So here what I'm going to do is I'm going to take a wire tip and let's go and see if I can go with the wire. Yep. Good. Live. No, come back. And bow a little more here. Off. Give me a tip now. There you go. Live. Should be good. Yep, go.
Yeah, you got
Here
it.
we go. So go ahead, umbo and inject. Up. You have both the fluoro and the endo image here, right?
Yeah. Perfect.
Okay, good.
Perfect
Live.
technique.
Thank you. So you see the duct is pretty big.
Yeah.
Let's see the distal duct. It tapers at the end. So this is a good. I'm just gonna take the pancreas wire there. Gonna give indomethacin. I'm not gonna put a stent. And let's stop injecting. I'm gonna do a sphincterotomy now. Combo. Fluoro shot. Good. More. Stop. Okay.
Andiamo in Ecuador.
So when you did a little bit something controversial here in SOD patient, you're not putting a PD stent in despite having a wire access?
Yeah, I think, I do feel that SOD type 1 is a different disease. So historically, the SOD we talked about is very different because it's just not real disease. When you do unindicated ERCP, such as SOD type 2 and 3, these patients have increased risk of pancreatitis. I believe this is ampullary stenosis, and I don't believe in increased risk. But so in my mind, it's not controversial at all. But we're going to give indomethacin. This patient is an inpatient already. And so here, because it's complete sphincterotomy, we're just going to do what I call umbo, safety injection, to make sure there's no microperforation or anything like that. And then we will be done. And I'll show you how we pull the scope before we end here. Live. Up, inject, please, inject. So Sophia is injecting, and I'm
And Professor Kashab, do you...
also suctioning. Fluoro shut. Okay, good. Off.
Professor Kashab, just to...
Final comment before I answer you. So when we come back here, I want to straighten the tip of my scope, and I don't want to be retroflex or angled so that I don't pull the scope with me. And I'm coming back nicely through this pen, and I'm going to double check that it is still on in the lumen here, that it didn't migrate. So this is how you ensure that you're in good shape.
Thank
So,
you, Moen. Thank
welcome.
you. Fantastic job. Thank you very much. Thank you very much again.
Thank you. Appreciate
And
it. Thank
see
you.
you very soon. Thank you very much.
Bye-bye.
Bye-bye. Let's move to Ecuador, to Guayaquil. Carlos, can you hear me? Carlos, can you hear me?
Yes, I can hear you.
Okay, okay. So, you, as always, you are closing the live demos of Euro US, so I want to thank you in advance for your support and for the fantastic cases that you usually prepare for us, so thank you very much. We appreciated a lot your efforts to participate to Euro US. Go ahead and do your last case.
Thank you so much. Thank you to you. For me, it's an honor to close this Euro US again. Really appreciate and honor it. So my team is also very glad to participate. And we will prepare the last case. So Daniela will present for you my assistant from Romania. So Daniela, please.
50 years old female patient with hypothyroidism and obesity with repeated episodes of colic abdominal pain, normal laboratory findings, but multiple gallbladder stones at percutaneous ultrasound that refuses surgery. It is proposed today for US guided gallbladder drainage with lumps.
So this patient refused to have laparoscopic treatment because this is the formal indication for her. However, what we see now today for this approach is that the gallbladder, this patient have for sure chronic cholecystitis. First, I see a lot of small signals that like this wall is 3.6 millimeter. It's a little bit thick, and also the distensibility of the gallbladder is not fantastic. You can see here, in spite to be without eating nothing today, the gallbladder is not very well distended. So I'm going to come back to perform gallbladder drainage today. So we can do a different approach. One is the gastric approach, and then the second one is from the bulb approach. So I believe that the best way to go inside this gallbladder is this approach because the distance from the wall is not too far. And this is very important when we try to make a gallbladder drainage. You see the stones here. So I believe with a 10 by 10 lamps will be enough to perform gallbladder drainage and make a good treatment for this patient. So in these cases, you have two ways. When the gallbladder is not well distended, in this case it's medium. But sometimes it's very difficult. When it's very difficult because of the chronic situation of the gallbladder, in those cases I prefer to use the needle and to inject contrast with saline solution inside to try to perform a well distension as already showed Moen from Baltimore in the stomach. So in the same way you can do it, and it's a safe approach when you don't have, you are not so sure that the gallbladder drainage will be fine. In this case, I'm trying to figure out the best way to go inside and the best place to put my my lamps. So the other tip is that when you pass the lamps, you need to see this. The wall of the gallbladder going the same when you are like with the catheter, you need to see that the gallbladder wall move with your catheter, because if not, you will not have a good succeed inside and you can have some problems with the deployment. So now I am ready. I believe I am in a good place now. You need to perform good aspiration. And I will try to pass my lamps. So now I know that I am inside. So
okay.
Now I am inside.
Now.
You see? A little bit difficult. Yeah. But it's very important when you are passing with the electrocautery, you need to see the bubbles in the water. That is another tip. When you see the bubbles in the water, it means that you are inside. Because if not, sometimes you are not inside and you didn't pass well, and you can have a complication.
Do you usually prefer to perform from the stomach or the duodenum?
It will depend. I prefer from the stomach because in this case I will let just 15 days the axios, because some patients perform ulcer because of the lumps inside the gastric lumen or the intestinal lumen. So now, quiero ver la imagen endoscópica en pequeño. So now I am very well. You can see here my lumps inside the gallbladder, and you can see here in the bowl the drainage. When you see the bilis coming, it's because you are in a correct position and you deploy very well the hot axis, okay? So now I finish.
Yeah. Do you usually put double pigtail stents inside to stabilize the hot axios?
Just in cases when I will last more time. For example, patients that I don't have to remove the axios, or I will less the axios, I will less a double pigtail, not for stabilize the axios. More than all is to avoid, the ulcers coming from the wall of the bowl. It's better, but I think it's correct. I will let the axios open alone. Sometimes you need to let some treatment for the pain, because some patients perform pain, and 15 days after you come back, you remove the axios and you finish to clean the gallbladder and finish. That is all.
In your experience,
Yes.
putting the hot axios in this position quite close to the, or in the stomach, when you are in the antrum quite close to the pylorus, the risk of having a Barrett syndrome, so the flange of the hot axios inside the wall after a while?
Oh, yes. I saw some cases, but more than all in the gastric wall. So in those cases, when I perform in the stomach, I prefer to let also one double pigtail. One, to avoid going inside the food, inside the axios in the gallbladder. And second, to in cases of, have this syndrome, you can find the axios and you can perform a rescue therapy. But you don't see that more than 15 days. If you last more than 15 days, the risk is increasing.
I see. So, thank you very much, Carlos. As always, spectacular, outstanding procedure. Very, very and quick. Thank you very much again.
Thank you.
For being with us also this year, and looking forward to having you back to your US for the next year in 2025. Thank you again.
Thank you and congratulations.
See you very soon. So,
bye.
So everybody, here we are, The EuroES 2024 is finished. We have had 2 days of very, very challenging procedures, live demos from here from Milan and all over the world. I'm very glad to let you know that all the patients are in good conditions. So also with challenging procedures, everything runs smoothly at the end. So I already give credits to my team at the beginning of the meeting, but now we have here part of them because many others are still working. So I want to say thanks to my team and to the fellows who have done a lot of work as well. So thank you very much, and thank you guys for this fantastic support. And see you next year in 2025 here in Milan. Thank you very much, and bye-bye. See you soon.
Thanks to all of you who stayed till this late. Thank you so much, and to those who are following us online.
Congratulations.
See you next year.